ready? morning.
Hello.
Morning, Sandeep. How are you?
Good morning.
Good morning, Dr. Badani. Hi, Ajay. Good morning.
Morning.
Good morning, sir. Arvind, sir.
Good morning, Sandeep. Hi, how are you?
Good morning, Dr. Vinod. How are you?
I'm good. I'm good. I'm sorry I couldn't put that background. I tried.
That's fine. That's fine.
Yeah,
That's okay. How was your meeting yesterday?
yeah,
You
it
had
was
a
great. It was great. Just completed yesterday, finished yesterday evening.
okay.
Yeah.
So we have with us Dr. Arvind Goregaonkar sir and Dr. Ketan Badani. Dr.
Okay.
Arvind Goregaonkar was a past president of the Bombay Orthopedic Society, and Dr.
Okay.
Badani is a very senior faculty in BSS. Good morning, Dr. Bimal and Dr. Gaurav. Welcome.
Good morning.
Aboard.
Morning.
You guys seem to be pretty tired with the academic stuff happening yesterday.
A little bit. But we are ready for today.
Yeah. So we still have around 4-5 minutes to start. So Kshitij, can we put the background which I had made for the first session?
Tech team, can you do that?
The AV team, I'd send a background slide initially. Thank you. Dr. Badani, can you see the PPT now? We can't hear you, Dr. Badani.
We can see it.
Hello.
Yeah, good
Hello.
morning. Good morning. Yeah.
Good morning. You can hear us? Hear me now?
Yes, I can. Yeah.
Okay. I cannot see other videos.
So probably you have hidden your participants. You probably need to unhide them from your settings. Other participants. You can go in the gallery view on your screen and then just click it over there.
Yeah, okay. I'm trying to find it.
Hi, Sandeep. Good morning.
Hi, good morning, Satyan. How are you?
Good, yeah. So you handle this session. I guess Kshitij will introduce you and give it to you, and then you can introduce our guest and take over the session.
Right.
Before we start off, I'll just want to welcome Dr. Binno, Dr. Bimal Pandey, Dr. Gaurav for joining us. Thank you, sirs. It is a great pleasure on behalf of Bombay Spine Society that you all are here. And we hope that we can have many more this cooperative programs in the future as well. I will be in Hall B, and I will come back to this later on.
Right. Okay. Yeah.
Yeah. Thank you, Satyan, for having us here. And it's a great honor and privilege for all of us, actually. And definitely, Association of Spine Surgeons of Nepal would like to associate and collaborate with Bombay Spine Society in days to come as well. Thank you so much.
Thank you, sir. So I'll.
So I think we'll start. It's 8 o'clock.
Yeah, right.
So I would like to welcome everyone, all the delegates for the second day of our BSSCON, and we are starting off with a very interesting session on tuberculosis, and it's a collaboration with the Association of Spine Surgeons of Nepal. And I would like to invite the moderators, Dr. Sandeep Sonone and Dr. Arvind Goregaonkar, to take over this session. Thank you very much.
So thank you very much, Kshitij, and a very good morning to all of you. On behalf of Bombay Spine Society, we welcome you all on this very interesting plenary session. It's going to be an academically packed day. It's a joint collaboration between the Association of Spine Surgeons of Nepal and the Bombay Spine Society on a very interesting topic, thoracolumbar tuberculosis, which we all face in day-to-day life. It's a much debated, much discussed topic, but still it continues to be a dilemma. I would like to welcome on behalf of the ASSN, Dr. Bimal Kumar Pandey, Dr. Gaurav Dakal, and Dr. Binod Bijuguche, who happens to be the chair, who will chair the session with Dr. Ketan Badani, who is also a senior member of the Bombay Spine Society. With me is Dr. Arvind Goregaonkar, who will be co-moderating. Sir has been a past president of the Bombay Spine Society. So without much ado, we will begin this session. We have small talks initially, 5 minutes each, which will highlight the issues, and then we move on to the case presentations. We aim to finish in time by 9 o'clock, so as to hand it over to the moderators for the next session. So can we have the first talk by Dr. Gaurav Raj Dakal on diagnostic modalities in tuberculosis, AVT.
Good morning. I would like to thank the Bombay Spine Society. I am Gaurav and I shall be speaking on the diagnostic evaluation of thoracolumbar tuberculosis. A diagnosis of tuberculous spine can be obtained by clinical evaluation, lab studies, imaging studies, histopathology, and AFP culture. The clinical evaluation, lab works, imaging studies, and histopathology provide us a probable diagnosis of tuberculosis. However, definitive diagnosis can only be obtained by doing a culture. It is important to diagnose tuberculosis because not everything that we see is actually tuberculosis, and 10% are due to non-tubercular causes. And also the presence of MDR and XDR strains make it more important to diagnose tuberculosis and do a sensitivity test. There will be an increase in the lymphocytes. The ESR and CRP are initially raised, and during the course of treatment, both the values fall. IgG and IgM values were initially obtained, but however, it has been discontinued because of the high false positive and false negative rates. Detection of interferons can also be done by doing a quantiferon TB gold test or a ELISpot test. And LFT should be done during the course of treatment to monitor the liver toxicity. A Mantoux test is a non-specific test, especially in our part of the world where tuberculosis is quite endemic. And also it does not provide us a knowledge on whether TB is actually active or not. Any values more than 5 millimeters is considered positive in immunodeficients, patients on steroids, or renal transplant patients, and values above 10 to 15 millimeters are considered positive in normal individuals. The initial modality in X-rays should be X-rays with AP and lateral view. Appreciate the soft increase in the soft tissue shadow. Initially, there will be radiolucency of the vertebral body, but for this to happen, there should be decrease in the mineralization content by around 40 to 50%. There's haziness and erosion of the end plates. Destruction of vertebral bodies, destruction of the disc will ultimately lead to deformity, can be multiple level involvement, and the spine at rest signs should also be appreciated in young individuals. There is an increase in the retropharyngeal space in the cervical spine X-rays. In the chest X-ray, there is a fusiform shadow. Classical spine at risk sign described by Professor Rajasekaran. MRI is the gold standard test. It is extremely sensitive. Initially, there will be a bone marrow edema with end plate erosions. Later on, there will be extensive bony involvement and bone destruction with disc involvement and disc destruction. There will be the presence of paraspinal and epidural abscesses, and the compression of neural elements and cord changes can be appreciated on the MRI. presence of intradural granulomas, and a whole spine MRI should be done to rule out any skip lesions. T1, T2 weighted axial sagittal images followed by stirred images and contrast enhanced images are a must. The amount and pattern of bone destruction is better visualized on a CT scan, and it will help us to plan treatment also, especially during surgery. PET scans not routinely done. However, it can provide us an exact location of the infection. It can differentiate infection and malignancy versus degenerative condition, and also the most important to assess therapeutic response to treatment and whether there is any reactivation. The confirmatory test is by doing a biopsy. Biopsy can be done either in the CT scan or in the OR under fluoroscopy. Open biopsies are seldom done, and it is the percutaneous image-guided biopsies that are usually done either with an aspiration or core biopsies. The sample obtained should be sent for a histopathology, gene expert, and an AFB culture and sensitivity. The gene expert is the results are obtained within 24 to 48 hours, and resistance to rifampicin can be detected. A line probe assay can detect XDR and MDR strains, and the results can be obtained fast within 48 to 72 hours. Along with the AFP culture and sensitivity, bacterial and fungal cultures should also be obtained. These days, due to BACTEC medium, the AFP culture reports can be obtained within 10 to 14 days. In conclusion, not everything is tuberculosis. It is important to get a histopathology or an AFP culture and sensitivity, and the most important is avoid empirical treatment. Thank you. Namaste.
Thank you, Dakal. Thank you very much. That was an excellent overview in such a short time on the diagnostic modalities which are available. And we will definitely have a discussion later on as to what amount of weightage has to be given to each modality in a particular case. So we move on to the next talk, which is essentially about medical management of tuberculosis, the drug management. And can we have the talk by Dr. Bimal Kumar on current guidelines in drug management of thoracolumbar tuberculosis?
Good morning. I'm Dr. Bimal Kumar Pandey from Kathmandu, Nepal. Currently, I'm president of Association of Spine Surgeons of Nepal. We are very proud to be associated with Bombay Spine Society for this annual meeting. My topic today is drug management in spinal tuberculosis current guidelines. Aim of TB treatment is to cure the patient of tuberculosis, to decrease transmission of tuberculosis to others, to prevent the development of acquired drug resistance, to prevent relapse, and to prevent death from tuberculosis or its complications. We have isoniazid, rifampicin, pyrazinamide, ethambutol, and streptomycin as basic drugs. Our drugs isoniazid and rifampicin are strong bactericidal, and they are very effective. And ethambutol is bacteriostatic. It minimizes the emergence of drug resistance. So isoniazid and rifampicin are usually used in continuation phase as well. We have other drugs in our basket to deal with multi-drug resistant tuberculosis. What's the matter of debate? What are the drugs to use and their regime? How long to continue them? In our past, we used ATT for about 18 months, HRJD for 2 months, HR for 16 months, and we used HRJD for 3 months and HRE for 9 months, altogether 12 months. And sometimes we used 5 drugs in the first 2 months of period, including quinolones, followed by 2 drugs, and total of 18 months. Sometimes we used drugs, antitubercular drugs, even for 2 years, and many more combinations were there. Well, what's the current trend? American and British guidelines for musculoskeletal tuberculosis: 2 months of intensive phase, isoniazid, rifampicin, pyrazinamide, ethambutol, or streptomycin. 4 months of continuation phase, isoniazid and rifampicin. Total of 6 months of ATT. WHO guidelines: 2 months of 4 drugs, HRJD, 7 months of INS and rifampicin, altogether 9 months of antitubercular drug. And what the National Tubercular Guidelines says, pulmonary and extrapulmonary tuberculosis, 2 months of HRJD and 4 months of HR is enough. That means 6 months of antitubercular treatment. And complicated musculoskeletal tuberculosis, 2 months of HRJD and 7 to 10 months of HRE, total 9 months to 12 months can be continued in complicated cases. Literature also suggests, and they are in favor of short term of antitubercular treatment, 6 months to 9 months. Even Korean guidelines are recommending 9 to 12 months of antitubercular treatment in bone and joint tuberculosis. Literature says 6 months versus 12 months of antitubercular therapy, no difference observed by the end of 24 months. The extrapulmonary tubercular patients, if they don't improve at the end of 6 months, we must investigate for drug-resistant tuberculosis. And there should be a suspicion of drug-resistant tuberculosis when there is no showing progressive healing within 4 to 5 months of ATT therapy, or if there is increase of destruction process, if sinuses and ulcer continue to discharge, if appearance of new cold abscesses, if there is an increase in size of existing cold abscess, if there is a development of additional active tubercular foci. And when dealing with multi-drug resistant tuberculosis, we have certain medicine group A, levofloxacin, bedaquiline, and linezolid. And there are some drugs in group B and group C. At least we should give 2 drugs from group A, 2 drugs from group B, or 3 drugs from group A and 1 drug from group B. And if any of group A and group B drug are contraindicated, then we have to choose the drug from group C. Treatment regime, at least 4 drugs, 2 or 3 from group A and 1 or 2 from group B for 6 months. Bedaquiline should be stopped in 6 months. At least 3 drugs should be in continuation phase. And duration of the treatment, shorter treatment regime for uncomplicated cases, 9 to 12 months. And longer treatment regime is recommended for complicated cases, minimum of 18 months, and can be extended if needed. Infectious disease specialists should always be there in selecting drug regime in the case of drug-resistant tuberculosis. So the current trend is intensive phase of 2 months HRJD and then HR for 4 to 7 months, total duration of 6 to 9 months. HRE in continuation phase in complicated cases. Infectious disease specialist in treating HR and MDR tuberculosis should always be there. Thank you very much.
So thank you, Dr. Pandey. It was an excellent overview of all the options which are available. This is something which is a very debatable topic. There's always a gray zone in our mind, especially when the patient is completing the duration of tuberculosis at 9 months or 12 months, whether to stop it or continue further, especially when there's a clinico-radiological mismatch. So we will discuss about it later on. And moving on to the surgical part of the treatment, can we have the talk by Dr. Vinod on the surgical principles of management in thoracolumbar tuberculosis?
Good morning, everyone. My topic is on surgery in thoracolumbar TV spine, principles of management. The primary goals of treatment of TV spine is to eradicate the disease, to prevent the deformity, and to restore and preserve the neurological function. We all know that chemotherapy is the mainstay of treatment. It does help to eradicate the disease, but it definitely does not help to prevent the progression of deformity. So the surgical indications include lack of response to chemotherapy at least for 6 weeks. If the patient has a progressive or profound neurological deficit, if the patient has established or progressive deformity, and of course to shorten the duration of symptoms. The surgery can be as simple as abscess drainage, or it can be radical in the form of debridement or stabilization, which can be performed anteriorly, posteriorly, or combined. This is an example in 30-year-old man with L1, L2 TB, where the body height is very well maintained, though the MRI has shown a significant destruction with bilateral paravertebral abscess. This patient was managed with ultrasound-guided aspiration of the pus, and he was started on chemotherapy. And 1 year follow-up, he has completely healed tuberculosis with no deformity. We used to do anterior surgery once upon a time, but this anterior approach is associated with significant morbidity, which can be now performed all posteriorly. If the bottle body height is maintained, though the MRI shows a significant bottle body destruction, it can be managed only with posterior stabilization. Whereas if the bottle body height is reduced more than 50% and it shows a significant destruction, only posterior stabilization would lead to instrumentation failure. In such conditions, it is always recommended to reconstruct anteriorly and stabilize posteriorly. And of course, if there is established deformity, then anterior reconstruction and posterior stabilization is always recommended. This is our own classification of treatment of TB spine, where we have classified into uncomplicated, complicated, and complex. In uncomplicated, the patient will have a pain, but neurology is normal without any obvious clinical deformity. And radiologically, it has shown a intact bottle body height, or the bottle body destruction is less than 50%. In such conditions, a trial of conservative treatment for 6 weeks is given. If it is not responding, then simple abscess drainage or posterior one instrumentation would suffice. If there is a deformity, obvious clinical deformity, then in such conditions, the anterior debridement and anterior reconstruction with posterior stabilization is recommended. In complex, the patient will have a neurological deficit with or without deformity. If there is no deformity, which is type A, then just the drainage of the epidural abscess with posterior stabilization would suffice. In case of the presence of deformity, then anterior debridement, reconstruction, and posterior stabilization is recommended. Thank you all for your attention. Thank you.
Thank you, Dr. Vinod. That was an excellent overview and the guidelines that you have mentioned for operative management. So, so far we have discussed a wet lesion in an adult patient. Now we move on to more complex scenarios, which is a different ball game altogether, the pediatric lesions and the heel tuberculosis. And none other than Dr. Arvind Goregaonkar, which is vast experience, to tell us more on how to handle pediatric and heel lesions and how different are they from the standard classical wet lesions in thoracolumbar spine. So Dr. Arvind, stop please.
Good morning, India. Good morning, Nepal. A big thank you to Nepal for participating in this conference and collaborating with us. Today, I'm going to speak essentially on a pediatric cox spine. What are the difficulties in that? And what are the options we have? Pediatric cox spine is not same as an adult spine. A lot of differences are there. So let us find out how the pediatric vertebral column differs from the adult. Our pediatric spine is immature and more flexible. The bodies are essentially cartilaginous, especially in the younger children. Spinal ligament and the facet joint capsule are more stretchable without any tearing. Paraspinal muscles are relatively weaker and the facet joints are more shallow and horizontal. Vertebral column essentially begins being cartilaginous. Destruction in a cox spine is very rapid in the children, and so they develop a kyphotic deformity. But when it is diagnosed early, conservative treatment gives the excellent result. So what kind of conservative treatment we give? Whether TB without any neural deficit or whether early deficit, a non-surgical treatment works very well. Two important things we need to do. One is the AKT and second is the bed rest or the bracing. Whenever we talk about the AKT, adult may, it is very easy. You can calculate and give the AKT. But in children, you have to be very particular, because the major consideration what happens in a antituberculous treatment children are underdosing should not happen. One. Secondly, the modification of the drug doses as the child gains weight, that is equally important. Must give a appropriate formulation, and must remember that streptomycin and ethambutol are given with care, or they may cause a toxicity in the children. Surgical treatment is indicated in cases with the instability, which can be diagnosed by the spine at risk signs, or it can be because of the progressive neurological deficit. So two indications. One is instability, second is a neurologic deficit, for which we need to go in for the surgical option. Now, what are the problems in the surgical treatment? In the children, bone being essentially cartilaginous, fixation may be difficult. A fusion or achieving the arthrodesis is delayed, and sometimes you may need a second attempt to do the bone grafting, and additional bracing is needed to protect the instrumentation. Pediatric cox spine, the biggest problem after successful treatment of the cox spine is development of the kyphotic or kyphoscoliotic deformity. As you can see in the images, the child at the age of 5 years, it was a straight one, and at the age of 10 years, we have found that it is a big deformity, and patient also has a neurologic deficit with that. The cause of the deformity is very clear. It is the anterior vertebrae which are not growing, whereas the posterior elements, they keep growing, and so there is a stretching of the cord. And so the patient is, in spite of being the angle may be same, but at the same time, because of stretching of the cord, patient will develop a neurologic deficit. So let us find out how do we manage all these patients with the deformity or the heel spine and with the trouble. So if patient has a kyphosis with no deficit, either you accept the kyphosis, which happens quite often in our country, or sometimes the child, especially the female child, at the age of 16 or 18, they want to get a cosmetic correction, and therefore patient can go for the cosmetic correction. But at the same time, the amount of the risk involved must be explained well to the patient. With the kyphosis with the neurodeficit, it's a big trouble. Here, you can do only decompression without changing any angle of the kyphosis, or you can do a decompression with the correction of the deformity. Now, let's have two examples. Now, this is a kyphotic deformity with the cord compression. Patient is 13-year-old male patient presented with a kyphotic deformity with progressive neurologic deficit. Now, this is a myelogram done that time. This is quite a old images. That time MRI was not so easily available also. So this is what was done. The myelogram was done and showed a block at the level of angular deformity. What we did is we went ahead with the anterolateral decompression, which is shown as in a picture, where the 3 to 4 ribs are removed and reach to the kyphotic area or internal gibbus, excite the internal gibbus and relieve the cord compression. Now this is only to relieve the cord compression. Here the angle of the deformity does not change. But because it is a fused spine, it is otherwise also stable in spite of doing an internal gibbectomy. So this is a post-op myelogram what we have, which we can see the free flow of a dye. At the same time, the patient is without any deficit, walking tall. Now this is an example of a correction of the deformity. This is a 7-year-old female bought by parents due to the concern of deformity noticed 2 years back with deficit. and it was a progressive. That was the angle, 85 degree. And here definitely we need to do something, because you can't accept the deformity. Definitely not, because especially because there is a cord compression and neurologic deficit. We got a CT scan done and found out the angle. It was 7, 8, 9, but 10, 11, 12. 3 vertebrae were completely destroyed and forming the internal gibbous. There is a pre-op MRI showing the cord compression at places. What we did the pedicular screw pass proximal and distal to the deformity. After that, we had put a temporary stabilization rod, and we started excising the internal gibbous. On either side, the posterior elements were removed, and then from the just side of the cord, we started excising the internal gibbous. Here you can see the internal gibbous, which is almost removed. A complete space is available under the cord, and nothing is compressing on the cord. This is how it confirms it. Now here we wanted to enlarge or lengthen the anterior column, but at the same time we wanted to compress the posterior column and shorten the posterior column. So anterior distraction or anterior opening and posterior shortening, that is how the procedure goes. This is what was done. The cage was put in a spacer, and posteriorly it was compressed, and this was a post-operative picture where we could get a correction of 40 degree. We did not try desperately to get a more and more correction, because that can be hazardous to the patient, and therefore whatever correction we got very easily and acceptable, we accepted that. This is a patient after the 6-month post-op, and what we found is deformity, whatever the 40 degree was immediate post-op, that is well maintained. This is the patient with the bracing, standing and walking, and this is a difference in the curve of a sagittal. So take a message from here. Pediatric cox spine is different from the adult cox spine, and don't treat as the same. Conservative treatment works very well in a pediatric age group. Fixation whenever needed is difficult. Interbody fusion is delayed. You have to be very careful for that. The kyphotic deformity with or without deficit is the end result of most of the childhood tubercular spine. Deformity correction, decompression always at a high risk, and therefore the prevention of formation of such deformity is one of the best treatment for the pediatric age group. Thank you for your kind attention.
Thank you very much, ABG sir, for throwing a light on a very difficult scenarios and telling us the practical guidelines and applications, as well as accepting our limitations in these conditions. Now, we all have complications in surgeries. The same way goes to this difficult sort of entity. And I would like to throw some light on the ways in which we can try and avoid complications, although we still are going to have complications in these conditions. So can we have my talk played over there? A very good morning to all of you, and it's an honor to be speaking in this particular session, a joint collaboration between the Bombay Spine Society and the Association of Spine Surgeons of Nepal on avoiding complications in thoracolumbar cox spine. The previous speakers have covered most of the topic, and preventing complication is just about sticking to what they have mentioned. So to begin with a case, we have two cases, almost similar ones, of a D12L1 cox spine with similar amount of kyphosis. Now you can see in this, one case went on to complete healing and remodeling of the lesion, whereas the other case landed up in progressive kyphosis and late onset neurological deficit. Both these patients have received the same type of treatment, including the antituberculous medicines, and it was surprising to find a variable result. Now, there are certain variables when it comes to treatment in tuberculosis, like the disease variables, the extent and location of the disease, the presence or absence of drug resistance, the patient factors like the age, the immunity, and the surgeon factors like decision making and the surgical technique and expertise of that particular surgeon. However, certain basic rules apply. The road, if we follow it properly, is clear cut and straight. We need to have a high degree of suspicion. Biopsy remains the cornerstone of diagnosis. Tuberculosis is basically drug management. The indications of surgery are very, very specific, and we need to give special attention to the biomechanics and the surgical execution. It is only when we try to take a shortcut do we land up in complications, and we frequently name them failed surgery. However, we need to have a relook and reassess whether it is really failed surgery or is it the surgeon which has failed. So coming to the basics, if we have a look at all these pictures and wonder which of them is tuberculosis, the answer is none of them. So the point is that multiple lesions can mimic tuberculosis, and we really need to make an attempt to diagnose these conditions. As I said, the cornerstone of diagnosis remains the biopsy. Ideally speaking, each and every lesion should be biopsied in today's day and age. There are multiple ways in which you can do it. It could be CT guided, sonography guided. CM is something that we all can do as orthopedic and neurosurgeons. And open biopsy is something which we all take on table. The accuracy is more than 80%, and the things to ask for are a histopathological examination to rule it out from different conditions, gene expert to rule out rifampicin or INH resistance, and then obviously to ask for sensitive drugs. Drugs always remain the first line of management. Always involve a chest physician or even a simple physician, because in case these lesions turned out to be resistant lesions, then probably you are caught off guard. Always suspect drug resistance like MDR, XDR or TDR, especially if there is no clinical radiological improvement, and consider starting second line drugs to prevent surgical failures. We need to understand that tuberculosis is basically a medical disease and anti-tuberculous treatment is mainstay of treatment. Do not treat the radiological picture. We all know that radiology heals with good, sensitive, acting anti-tuberculous treatment. Indications for surgery are very, very specific: neurology, instability, and deterioration of pain, which is a relative indication. There are certain special conditions like pediatric tuberculosis, which was already mentioned by the previous speaker, where the aim is to prevent kyphosis, and there are well described signs for this like spine at risk signs. Finally, we need to make sure that we pay special attention to the biomechanics. If we understand the load bearing column of the spine, it is composed of two main columns, the anterior and the posterior. In tuberculosis, it is usually the anterior column which is destroyed, so very, very important to pay spatial attention to the anterior column and reconstruct the anterior column, or else, especially in junctional and thoracolumbar tuberculosis, it is going to land up in kyphosis. So here is a case of a 45 years old female, 120 kgs, who had resistant coughs. The patient did improve after posterior surgery. However, here you can see on the CT scan, the patient has got an anterior void. That is where we decided to go in and reconstruct the column anteriorly by a transdiaphragmatic approach. Surgical execution is very important, otherwise you can land up in these sort of failures with implant failures, construct failures, adjacent segment kyphosis. So we need to have special attention to the other details apart from approach. Decompression remains the mainstay of neurological recovery. What I want to emphasize over here is that you need to have a good bed or so-called end plate preparation for sound grafting and reconstruction. In fusion of the spine, grafting remains the most important stage. And finally, you need to supplement the whole construct, that is decompression, grafting, with good amount of neutralizing instrumentation. So in short, we need to have a high degree of suspicion. Biopsy and drug management remain the mainstay. The indications of surgery are very specific, and special attention should be paid to the biomechanics and surgical execution. Thank you very much. So thank you all the panelists over here. For want of time, I would like to move on to the case presentation. So I would be presenting the first case over here, and we will discuss all the issues which are concerned. And then Dr. Binod will be presenting the next case. So can I share the screen over here for my first case? So is the screen visible?
Yes, we can see the screen.
Yeah, right. So this is a case of a 40 years female, around 120 kgs of weight, with a D12L1 lesion, who had back pain since 6 months. She was started on anti-tuberculous treatment somewhere else, purely on the radiological picture, which was quite mild at that time. No biopsy was taken. The back pain increased. She became non-ambulatory due to increasing pain. And neurologically, she had non-functional power in both the lower limbs, grade 2 to 3, and there was no bladder involvement. This was the MRI picture, which showed the presence of an anterior lesion causing a little bit of cord compression on one side. So with this radiological picture, can I get in Dr. Gaurav over here, Dr. Gaurav Rajdakal?
Yeah.
And ask him, depending on the radiological picture, how would you go about it regarding regarding establishing the diagnosis in this particular case? Dr. Gaurav?
Yeah, okay, so thank you. So if you look at the MRI and the CT scans now, there is definitely a disc is involved along with the paradiscal region, but there is not much of soft tissue shadow, the whatever abscess you are seeing is very less. Unlike tuberculosis, it should be more of an abscess, and there's also disc destruction.
Right.
And this patient has severe back pain, and the back pain is not yet relieved. By 2 months' time with ATT, the back pain should have decreased by now. So definitely maybe something else, and the next step would be going over the blood exams, but then getting a definitive diagnosis by doing a biopsy is a must now.
Right. So I got the point. So Dr. Bimal, in this case, the patient has got neurological deficit with non-functional power. So ideally, as Dr. Gaurav said, that we need to have a histopathological diagnosis in the form of biopsy and establish and then go ahead, because this could be something else. But when the patient has neurological deficit, I guess the scenario changes totally. So how would you manage in presence of neurological deficit? You would still wait to get in a biopsy, or you would go in and operate? Dr. Bimal? I think we have lost him.
They have to unmute to speak.
No, I think he is unmuted, but I think his video is getting hanged. So can we have Dr. Goregaonkar sir over here? Sir, your comments on this particular entity? Dr. Goregaonkar sir, Kshitish, can you hear me?
Yeah, I can hear you. Tech team, can you allow the faculty to unmute themselves? They are not able to unmute themselves.
Hello, can you hear me?
Yeah, I can. Go on, Dr. Bimal. Yeah.
So with such a gross deficit, I think the surgical intervention is mandatory, because irrespective of the diagnosis, we need to relieve the cord compression, and therefore surgical decompression with the fixation is mandatory, and send whole tissue for the examination to confirm the diagnosis. And one of the most important thing, you must get a sensitivity done. It's not only the diagnosis, but what remains is a sensitivity. If you miss out on that, then you are starting AKT, but it is not working. And therefore, this getting a confirming the diagnosis and getting a sensitivity at the first go itself, before starting the AKT, that would be the best. But when the patient comes at this age, I think the go ahead with the surgery, decompress, fix, and then send a tissue for the diagnosis and sensitivity, and accordingly change the AKT, whatever changes to be done.
Right, right, right. So that's very important, having all the weapons in your hand. So medical weapons, the drug weapons are very, very important. So Dr. Bimal, are you with us right now? Can you hear us? I think we can't hear Dr. Bimal. Dr. Binod, are you around?
Yes, Shandip, I'm there.
Yeah. So we all have a relative good consensus over here in
Yeah.
India regarding regarding how to approach about it, because we believe that biopsy is very important and establishing a diagnosis is very important. What's
Yes.
the scenario in your country? How do you go about it? Because probably histopathological diagnosis and the means to achieve it might not be available to every surgeon. So what's your role on
Yes.
empirical anti-tuberculosis medicines in conditions like this?
Yes, the scenario is not that different as compared to India, but definitely where facilities are available, like in the big hospitals in the cities, we definitely would like to get the histopathological diagnosis before starting ATT. So the empirically starting ATT has been regarded as an unpardonable error. Uh, can you hear me?
Yes, we
Yeah.
can. Yeah.
But having said that, in the rural areas where the facilities are not that easily accessible, and the people are not, that much affordable, and in our part, we have a geographical difficulties to reach to the, the hospitals where they have adequate resources or facilities. In such cases, we consider that, our area being an endemic zone for the tuberculosis, we give a trial of ATT. Otherwise, if the facilities are available, we always get the biopsies done and
Right.
start ATT.
Right. So that's
Yeah.
a very important point he made, that just starting empirical AKT when you have avenues to make a histopathological diagnosis is probably criminal in today's day and age.
Yeah.
So Dr. Gavrav, can we have him over here if he's around?
Yes.
What is the current anti-tuberculosis protocol that you follow? That because we have seen multiple papers mentioning all sorts of protocols. There's a lot of gray zone, a lot of confusion regarding the duration of anti-tuberculosis medicines, especially in primary sensitive and in resistant lesions. So what is the protocol that you follow in primary cases and in resistant cases?
Okay, so there are two ways of approaching this here. One is the individual practice of the spine surgeon or the orthopedic surgeon. But what I generally do is we have the guidelines was laid out by the Nepal Orthopedic Association that we should do it for 18 months. And it is not yet changed. So personally, for me, I stick to the NOA, Nepal Orthopedic Association guidelines of 18 months.
Right. So in case at the end of 18 months, you still find some abscesses on the post-operative MRI, or at the end of 1 year, you find some abscesses on the MRI, but the patient is clinico-radiologically improving, would it tempt you to stop the AKT, or you still stick to your guidelines, which you mentioned?
No, if the patient is doing absolutely fine, CRP and ESR have returned back to normal, there is mineralization in the X-rays, then I stop it at 18 months. I don't go further unless the patient is not doing well.
Yeah, and what's your protocol in resistant lesions? Do you involve a chest physician or a physician, or you do it all yourself?
Yeah. So I don't manage the resistant lesions myself. I send it to the chest physicians or the infectious ID specialists.
Yeah. So that's a very important point which we all also follow over here, that involving a chest physician for medical management, especially in resistant lesions or you're suspecting resistant lesions, is very, very important, because we need to believe that those are the best people to handle the medical part of the treatment. Now, moving on to the management, Dr. Badani, if I can get you inside, what would you do in this particular condition? What is your mode of management surgically?
So as we all discussed, I think there is no doubt that surgery is necessary for this patient. I hope you can hear me.
A little loudly, please, Dr. Badani.
Yeah, hello.
Yeah, we can.
Yeah, so there is no doubt that surgery is required for this patient. And of course, we need to analyze the MRI properly.
It's too low. Can you speak up? Your microphone has some problem,
Hello?
Dr. Badani.
Hello?
Yeah, we can. Go on.
Hello. Yeah, so it is necessary to decide the extent of decompression required, extent of stabilization required. We are at the DL junction, and we need to spare as many discs below as possible in the lumbar spine and yet get adequate stabilization. One of the important things in this would be to decide the stabilization would be a plain X-ray, which will actually give you the quality of bone, availability of the bony fixation points, the pedicles, etc. So here, as you can see, this is the current X-ray.
Yes, yes. This
And
was
the
the X-ray
fundamental,
before we operated. Yeah, right.
yeah. So here, uh, this L1 seems to be quite good. Good. I think the distal one is the L1 and the proximal is D12.
Right,
So
right.
yeah, so D12, D11, all these vertebrae look good. I would probably go L2 to D11, and I would probably consider if this bone quality looks good and intraoperatively, if I find that the D12 L1 disc is good and the end plates are strong enough, I would just put an interbody cage, do the sufficient decompression, probably add a posterior fusion as well.
So you would do an anterior reconstruction with a posterior one.
Absolutely, posterior
Right, right.
stabilizing, all posterior approach.
Right, 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 right. Dr. Binod, how would you manage this case over there?
Uh, this is a very interesting case. Since there is not much of bony destruction as seen in the plain X-rays, MRI is always oversensitive, which shows more of the bony destruction. But depending upon the plain X-rays, since the vertebra are more of the cancellous bone, so you need to have at least 50% of the bony destruction to be radiologically visible. So based upon that fact, if you look at the plain X-rays, then the vertebral body height is very well maintained. So in this particular case, I would only go posterior stabilization and decompression of the spinal cord without anterior reconstruction.
Right, right, right. So this is what I have done, because this patient was around 120 kgs of weight, a very hefty, short female. I decided that I'll decompress posteriorly and then do an posterior fixation, a long segment one. I did not approach the column anteriorly because this patient was deteriorating on AKT. So I took a biopsy from this area. While taking a biopsy, I found that the proximal body was also quite porotic, and there was a lot of lysis, which probably we missed on the MRI and the CT scan. So the question is, in this case, Dr. Goregaonkar sir, do you think this is enough, or something more had to be done?
I think if you go for the decompression posterolaterally, even the X-ray shows like a body is almost intact like. I'm sure there must be the void. And this fixation can have a trouble because the anterior support is not there. So sometimes the space is not very big. It may be smaller. In that case, you can use a pliff cages also. Not necessarily every time you have to use a mesh cages. You can use a pliff cage and try to stabilize that with a single pliff cage. So once you get a support, the chances of failing is less. At the same time, the AKT must work. Otherwise, everything is going to fail.
Right, right. I'm very glad that sir made this point. This is what experience teaches us. So just to show you another case, a similar one with a sort of a lower lesion in which the patient had done almost the same thing. He stabilized the whole thing. And this is the X-ray at the end of 1 year where the implant and the construct is failing. And this is at the end of 2 years. So this was almost a similar case where we did not have a histopathological diagnosis. So Dr. Binod, your comments on this particular similar scenario, why has it failed? Apart from what Dr. Goregaonkar mentioned, that this probably was the reason that there was an anterior why it has collapsed. Any other reason that you can think of, Dr. Binod?
Yeah, I completely agree with what Dr. Goregaonkar has mentioned. If you don't have adequate anterior support, then the posterior tension band is definitely going to fail. In the first case, compared to the second case, do you have the preoperative plain X-rays of this second case, sir?
I don't have it because this was operated somewhere else, and this patient came to us.
So you see, looking at this particular X-rays, you see the disc is completely disrupted between these two affected vertebral bodies, which indicates that there is a significant void between this vertebral body, which is actually not supporting the posterior instrumentation. So there is a lack of anterior support for the ligamentous structures posteriorly. So that is the reason why the instruments has failed.
Dr. Gaurav, any other reason that you can give apart from the surgical point of view? This patient also from because you had a talk on your drug management. So would you suspect resistance in these particular cases?
Yeah, basically, I just want to reiterate that this pseudoarthrosis can be due to either deficient anterior column and non-healing of the anterior column. And second is some amount of disease process may still be left, maybe MDR, XDR.
Right. So for want of time, I'll just rush through and tell you what we actually did. So in this case, as you all mentioned, that there was a void and we decided to reconstruct it by posterior revision and anterior reconstruction. Similarly, coming back to the first case, and I mentioned, is this enough? This patient turned out to be resistant lesion at the end of 6 weeks. Just because this patient was heavy, I did not immediately start mobilization. She recovered neurologically. But as you can see on the post-operative CT scan, as Dr. Goregaonkar mentioned, there was an anterior void. This was a resistant lesion. So learning from our experience regarding the case which failed, we went in and reconstructed anteriorly to give a good solid anterior support. And this patient went on to heal clinico-radiologically quite well. So this is all about the case. So two most important thing is that to be sure that the AKT is acting, and biomechanically we have to be on sound ground to do a good reconstruction and stabilization of the spine. So thank you very much, and we move on to the next case by Dr. Binod. Dr. Binod, can you put up your screen sharing?
Can you let me share my screen, sir?
Dr. Sandeep, I was so sorry that I missed a middle part of that. I was disconnected for a while.
Yeah. So can I share the screen for 2 minutes? Yeah. So this is. Can you see my screen now, Dr. Bimal? So, can you see my screen? So this was the case, which was a similar case, which failed clinico-radiologically because of want or short of anterior support, and we reconstructed it. And learning from this case, we also reconstructed this particular case, which had anterior void, and that was a good result. So this is what I wanted to present.
Do you suggest that we should go for CT scan before doing revision or any type of surgery before the CT scan, just before operation?
So in my case, sir, we do not do CT scan in all cases. I usually take an assessment on the MRI, and as the X-rays also give a good indication the sclerosis in the X-rays. But yes, if I find that while doing biopsy, there's a lot of anterior void, especially at junctional levels in female young heavy patients, I would definitely do an anterior reconstruction by a posterior lateral approach, which Dr. Goregaonkar mentioned.
Can I ask one question? Do you do DEXA scan or some sort of testing for osteoporosis in those patients before?
Not in all cases. Only when we suspect that these patients are old and the porosis is quite visible on the X-rays.
Sure.
Yeah. So for want of time, we will just go to the next case by Dr. Binod.
Yeah, thank you, Dr. Sandeep, and I'll go quickly. This is a very short case presentation. So this is a case of 45 years old lady. So who has presented with pain for a duration of 6 months, and she has an obvious clinical deformity and which is progressing over a period of time, and her neurological deficit.
Dr. Binod, your screen is not visible. Your PPT is not visible. Yeah.
Okay.
Yeah.
But it's visible on my side. Let me share my screen once again.
Right, please do.
Yeah. Is it visible now?
Yes, it is.
Yes.
It is.
Sorry. Now?
Yes, it is.
Is it visible now, sir?
Yes, Dr. Binod, yes.
Okay.
I can see.
Yeah. So this is a case of 45 years old lady who presented with the pain for a duration of 6 months, and she had a progressive deformity, and there is obvious clinical deformity in the form of kyphosis. And the neurological deficit she had at the time of presentation was bilateral foot drop, and bowel and bladder was normal, and no history of trauma and no history of contact with the tuberculosis in the past. So based upon this clinical finding, we asked for our x-rays, and x-rays showed that there is a significant kyphosis due to destruction of the L1 vertebral body. So can I, get in Dr. Gaurav, that based upon this x-ray finding.
Can you put on the x-ray, please, Dr. Binod?
Yeah, it's on. It's on.
We can't see the x-ray.
Can you blow it up? Can you blow it?
Can you put it on full screen?
It's on full screen, sir.
No, it's not on PowerPoint mode.
This is on PowerPoint. On my side, this is on PowerPoint mode.
Right,
no, we cannot see it.
Okay.
Right. Take your time. Take your time. Can we just move on to the x-ray on the lower slide?
So this is the previous one. This is the x-ray. Can you see the x-rays?
No,
It's not moving.
it's not moving.
I think you should click on the slide, not slide itself.
Yes, that one maybe.
I did that.
Next one.
Yeah. Yeah. Next one. Next slide. Next slide.
Now,
Not go next slide. Just click on the left side of your
Dr.
slide.
Binod, come out of PowerPoint mode. Come out of PowerPoint mode and just click on the slide. Come out of PowerPoint.
Yeah.
A lower one.
now,
Don't play the PowerPoint mode.
okay.
The one on the right side. One on the right side. Lower
This
down.
one?
Lower slide. Lower slide.
Just
Yeah, I think if I may interrupt, I think I can see till Dr. Binod puts up the slide. I can see that there's a L1 collapse with a healed lesion at L1. Whatever X-ray I can see over here. So the point probably right. Now we can see it. Yeah.
I
Take
think
over,
I
Dr.
should
Binod.
continue in this mode.
Yes, please.
Yeah.
Go on. Go.
So can I get in, Dr. Gaurav?
yes.
So, yeah. Based upon this X-rays, can you tell whether this is the healed disease or the disease is in the active stage?
Okay, so this patient, looking at the X-rays, this patient has a collapse of the L1 and the L1, and there's a complete collapse of the L1, and there's a deformity. This patient has a deformity, and then you do not have a. Okay, so this looks like is there a neurological deficit? Foot drop.
Yeah, neurological deficit in the form of bilateral foot drop.
Okay, this I think for me is a healed disease leading to a neurological deficit, deformity leading to a deficit. Yeah.
Right.
What?
So, Dr.
Yes.
Binod, if I may interrupt, this patient has a bilateral foot drop. What makes you think that a lesion at L1 should have a bilateral foot drop? Do you have a screening of the lower lumbar spine somewhere at L4, L5?
Yeah, what do you think? What investigations would you ask for in this particular case, Dr. Sandeep?
Right. In presence of bilateral foot drop, I would definitely be looking at the lower lumbar spine to rule out if the patient has got a lesion somewhere in the lower lumbar spine.
Okay. Would you like to get the plain X-rays only, or you want to get some other investigations done?
The MRI.
Okay.
MRI. Right.
So I'll go to MRI now. This is the blood parameters she had. The CBC was normal, CRP was normal, but the ESR was 65 in first hour. Okay, and this is her MRI picture. So, Dr. Sandeep, can you comment on this?
So this is a clear-cut case of a healed lesion, a query healed lesion, although it shows intensity changes, but clinico-radiologically we need to match. If the patient is clinically fine as the image that you showed and not too much of pain, this is probably a healed kyphotic lesion in the spine, although there is a little bit of epidural cuff and abscess, but the management won't change too much. This is definitely surgical management. So for want of time, just a couple of questions from either side. Dr. Bimal, how would you manage this case? And the same question I would be putting to Dr. Badani. And then we will see what Dr. Binod has done. Dr. Bimal, what would you do?
Definitely, first of all, I should try to get some biopsy report from there, FNAC or biopsy. But since patient is having foot drop and there's deformities there, definitely surgical treatment is the choice of the treatment.
Right. Dr. Badani, what would be your surgical treatment of choice?
Yeah, what I would do is she would require a posterior stabilization and something like a PSO, and because it's a heel disease, it's a dry lesion, so you'll require something like a PSO and then correction of the deformity and anterior reconstruction with cage via all posterior approach.
Right.
That would be that. And
Right. So you were
one more thing I want to say, this bilateral foot drop is a feature of a conus lesion.
right.
Yeah,
So you want to stabilize it by doing a posterior instrumentation and recollecting the deformity so that to give it a biomechanical stability. So
Yes.
final comment from Dr. Binod. Just show us what you have done and your rationale for doing so before we wind
sure.
up this session.
Yeah. So what we did was we went through posterior, and this was the incision, and we exposed the vertebral bodies, and then we excised the entire vertebral bodies, stabilized posteriorly, and removed the necrotic tissues, and tissues were sent for biopsy also. And this is how we got the correction of the patient, and this is how the correction of the kyphosis was done, and this is the radiological picture. And after surgery, she improved neurologically also. So this is what we have done.
So that's a very great way of reconstructing and managing this case. You have achieved almost everything in this case, a good biomechanical fixation and stability to the spine. So thank you, esteemed panelists, because we are really short of time, and I think we have managed to end on time, especially the first session of the day. So I would like to thank all the panelists over here, especially the esteemed faculty from Nepal, from joining us over here. And I hope and pray that we continue this association in the future. So thank you very much all, and over to you, Dr. Kshitij.
I'd like to invite the Secretary of Bombay Spine Society, Dr. Satyan Mehta, to introduce the next speakers.
Thank you, everyone.
Okay, thank you, everyone. Thank you for having us with you.
Thank you.
Answer. Thank you again. Thank you to Association of Spine Surgeons of Nepal for gracing us with your presence. It has been a very good session, a very good start to the meeting, and we hope that we can associate it more and more in the future. I request you to please stay back for the presidential session as well, and it will be good to have you around for that. Thank you, Sandeep. Dr. Sandeep Sonone is a very important member and a vital cog in the Bombay Spine Society. Thank you for conducting this session very well. After having an exciting weekend on 13th and 14th of November, where we had all the operative spine courses, and then we went on to the main conference this weekend, and now we are reaching the crux of the conference, which is our presidential session. We will be having some very esteemed speakers who will be all introduced by Dr. Srivastav in the session. Don't miss this at all, because all these talks, as we were discussing, are worth their weight in gold. And for any level of spine surgery that you do, you will be definitely gaining from these talks. Without further ado, I invite our senior spine surgeon from Bombay, Dr. S.K. Srivastav. Sir, we are honored to have you as our president, and you have been guiding us with the correct principles and morality that is needed for this organization, guiding us in the right direction, making sure that everything is going correctly and professionally. And I invite you to please take over this session, sir. Thank you very much, Dr. Satyan. Can I share my screen? So, very good morning to all of you. Thanks a lot for inviting me for this talk. It is my proud privilege to deliver this talk in front of this August gathering. I'm going to talk on factors affecting the long-term treatment outcome in craniovertebral pathology. The analysis of poor clinical outcome has to be done in each and every case. Now, suppose you see this case,
What is the problem? Even it is operated, the outcome was not good. And why it had happened? There is a significantly reduced clivus canal angle, increased atlanto-dense interval, there is a reduced retrodental space, radiological features of neural compression is there. So there is poor neurological recovery, or there may be neurological deterioration in some cases. Backed out implant before bony fusion, it is going to leave instability and deterioration. The rod breakage and loss of initial reduction. And you see in this case, there is a appearance of the kyphosis. Some of these cases, they come to us and, everything has been tried earlier by the previous surgeon, but this becomes a difficult task to revise it. So we should be aware about, all these factors. There is a persistence of occipitocervical kyphosis. You see here, clivus canal angle is 90 degrees. There is a cervicomedullary compression, and that has led to the neurological deterioration. Compromised alignment and fixation. In this case, there is a persistence of kyphosis. Dens is still angulated significantly because there is inadequate levels of fixation. And this is classically known as toggle effect. So there is a significant forces working in this region. One level proximal and one level distal surface fixation is inadequate. The biological factors must be addressed properly. If there is inadequate fusion, this is going to happen. And it is most common at the graft C1 arch interface. Proper decortication of C1 arch must be ensured. Proper quality grafts should be used. Smoking and osteoporosis leads to negative effect in this fusion area. It is important to realize three important factors working in this specific region: the unique anatomy of this region, complex biomechanical factors, and specific pathology associated factors. Cognizance of all these factors in a patient makes a successful foundation for long-lasting fruitful results. This area has a unique anatomy. The craniovertebral junction encompasses cervicomedullary junction. It is the top story of the column. This is a vital region with the vital centers. This is a junctional region. It is hypermobile, and there is a risk of instability. It has unique anatomy. It has a Y-shaped beam. C1 has no anterior loading structure. And the vital structures are mainly brain, spinal cord, and vertebral artery. The ligaments are the main stabilizing structure. Mobility is at the cost of stability here. Congenital anomaly and traumatic and destructive lesion leads to instability. Main ligaments are providing stability, but destruction of these ligaments, and there is a less bone, there is a less contiguous fusion surface. And we should be aware about that. The surface preparation is extremely important, and when you are laying down the onlay graft, you must try to stabilize by some means. There is a complex biomechanical factors, and alignment of the column is extremely important. And we come to know about these things by plain X-ray, MRI, and CT. Plain X-ray, one can see the instability by doing the dynamic view, and you come to know about all these things, whether there is an existing anomaly, whether there is a bony destruction, there is a neural affection, and how is the overall alignment of the column. There are various radiological parameters, and I will not be going in detail of all these, but these are extremely essential, and we should be aware about if we are treating such regions. Out of all these, there are three important radiological parameters: the clivus canal angle, which is very commonly used; cervicomedullary angle, which is most important to soothe the neural compression or kinking; and cervical lordosis with the distal SVA. This is extremely important. Normal CCA is 145 to 160 degree, and in this case, you can see there was a reduced CCA. Normal CMA, that is a cervicomedullary angle, it ranges from 135 to 175, and in this case you can see there is a significant compromise and there is a neurological deficit. Now in this patient with normal clivus canal angle, but there is a reduced CMA in this case. So what is more important is the CMA, and which tells the neurological compression. Alignment of the craniocervical region with cervical lordosis and distal balance SVA is extremely important. There are specific pathology associated factors also. There may be congenital anomalies, which anomaly may be there in the osseous, neural, or vascular structure. There may be missing bone, abnormal alignment, abnormal assimilation. There may be neural compression. There are issues of implant anchor. If the bone is missing, there may be poor bony surface for fusion. And there are different acquired pathology. Infection, the TB is very common in our setup. There may be traumatic lesion, there may be degenerative lesion, there may be inflammatory lesion. And all these can lead to neural compression, and there may be instability. Again, here also there may be a problem of the implant purchase, because bone might be very porotic. The poor bone also leads to poor fusion. So alignment failure, neural compression, and pseudoarthrosis always gives poor outcome, and we should be aware about it. Irrespective of the pathology, we must achieve acceptable biomechanical alignment, acceptable cervicomedullary angle, and a stable fixation with very sound bony fusion. This would definitely allow us to have a long-lasting, fruitful outcome in any given case of craniovertebral pathology, and we must pay attention to it. The tuberculosis of craniovertebral region, it is a destructive pathology. It leads to destruction of ligament and bone, and there may be instability in all possible plane. AP direction in coronal plane, there may be scoliotic tilt, there may be basilar invagination, and there may be rotatory displacement. Now, in this case, you see there is like a hat on hook appearance. It is slipped forward significantly. The tumbling of the heavy skull, and there is a significant destruction. So all that can lead to a neurological deficit. There is a varied presentation in TB. Now, in this Y-shaped beam, the one side, the arm of the Y is missing, and this has led to eccentric collapse and scoliotic tilt. This patient has significant neural compression. Tuberculosis is a medical disease. With sensitive AKT, there is a good healing. With close observation of all these three key points, craniovertebral TB can be treated conservatively. Now, in this case, there is a CV junction TB. We initially put the patient on SIAS traction, X-ray with brace. It is nicely aligned, and see the 2 years follow-up. It has healed very nicely. So it can be treated conservatively, but you have to follow all these three key points. Instability in a child significantly destroyed the osseous thing. Occipital-cervical fixation and fusion was done in this case. He recovered very nicely. Another case, C1C2 Cox. Now here we found that once there was a good purchase, and we accepted this, but the fixation and fusion was actually extended in the occipital area. Significant bony destruction, increased prevertebral shadow, and here you see the reduced CMA, and that had led to the neurological deficit in this case. We approached from behind only, we drained all the pus. So one moment you open the C1, C2 joint, the pus comes out. And this case I had operated 25 years back, and see the amount of the graft, and this gives a very good result, sound fixation and fusion. Reducible AAD, we can use transarticular fixation where the bone quality is good. You can use this. Partially reducible C1, C2, here you pass a separate screw. And in this case, you can see the laterally the joint has been open, the C1 and then we part the reduction in this case, and you see a good reduction could be achieved. Bone grafting is extremely important. You can see here I had tied the graft with the Vicryl. So this has very easily congenital craniovertebral anomalies. Now, this is another entity which comes very commonly in our clinical practice. Menges was the one person who described this comprehensive surgical approach in great length. Then Dr. Lahiri started doing the plate and screw fixation of atlantoaxial subluxation. Dr. Goel published this in '94. Later on, Dr. Goel also published a joint jamming technique. Now, in 2006, Professor Wang came with this paper, and this was extremely helpful paper for all of us. And as for any neglected joint dislocation, release is required. So now, why not for the anterior structures are contracted and tight, inhibiting the reduction. Once you release the anterior tight structure, reduction is very easy, and we started following this. So we first did the transoral release, where you try to release all the tight structure. This has been released. You cut the longus colli, you cut the capsule of the joint, and you find that you are able to bring the dents very nicely, and it has the basilar invagination has been corrected. Then you close down and turn the patient. Now do the posterior job. So posterior surgery, midline posterior exposure, anchor point, you must have C2, C3, two level at least down in all the significant basilar invagination cases. Under contour the rod or plate, and once you approximate it, you get a very good approximation and reduction. Now fusion is a crux, you must fuse it very nicely. Now we got this case who had a mouth opening of less than 1 finger. And here we did extrapharyngeal release. And after this case, we started doing all cases extrapharyngeal release and no transoral surgery. Now in this case, see the significant amount of the basilar invagination, significant CM angle decrease and neurological deficit. We did with this anterior transverse incision and identify the area. You can see with the traction, it has come down very nicely, and do the posterior fixation and fusion. It has come very well. So this was the pre-op CT. This is post-op CT. You can see the angle has been corrected very nicely. Retrodent space is retained again nicely. Clivus canal angle restored. There is a restoration of CCA and SAC. So you can see when the MRI pre-op and post-op, so there is a restoration of cervicomedullary angle. And we published this in 2015. All irreducible AADs can be converted to reducible AAD by anterior release. There is no difference in the reducibility of AAD, whether anterior release is done by transoral route or extrapharyngeal approach. Extrapharyngeal approach is a commonly used approach and less morbid. So take home message, to have a long-term fruitful outcome, it is extremely important to analyze the existing pathoanatomy, neural compression, and altered biomechanics in each patient in view of existing pathology and possible mode of sturdy fixation, to realize the status of osseous bed for bony fusion, to spend quality time during steps of bony fusion. Failed surgery in this region is extremely difficult to revise and get a long-term good outcome. It should be the first and last surgery at that level. Never compromise in any surgical step and try to be a super fast surgeon. The first chance is the best chance, and aim for the best outcome in given situation. So I'll conclude, irrespective of the type of craniovertebral anomaly, following three key factors decide the long-term outcome: acceptable biomechanical alignment, acceptable cervicomedullary angle, fixation with bony fusion. Taking care of these three factors ensures a long-lasting, fruitful outcome. I thank you very much for your kind attention. Thanks a lot.
Thank you, sir, for an excellent talk. This is a very specialized field of spine, and we need to be very, very focused and to get a perfect result in these patients. This way, your talk is open for any questions. If there are any questions, we can, ask Dr. Srivastava, sir. Yes, Dr. Wang.
Good morning, sir.
Good morning. I have a question, Dr. Srivastava. What do you think? You said about the cranio-cervicomedullary angle. What do you think is the cutoff where you start getting poor results? Because I have seen patients with fixed in kyphosis that still do well if the fusion has occurred. So I don't know. Some don't, but some of them do. So if there is a successful fusion, so is there something that you aim to achieve?
Yeah, extremely nice question, Chitesh. I think many people who are dealing with all these things, they are aware about that. There is a Steele's rule of 3. You have a good space behind the cord, and that accommodates even these poorly attained biomechanical access. But this talk I am giving after 25 years to show the long-term outcome. Usually what happens if there is a significant biomechanical malalignment, there is a severe kyphosis. Later on, because of this poor biomechanical alignment, there are late failure, and patient again comes with the deficit with the fusion-like mass posterior. It is fused, but it is not. So it is better to achieve first time. Okay. So what I actually try to achieve is initially we don't do all these post-operative cases MRI, because earlier we used to use this hard ciliary subluminal wire. The CT myelo at the most you can do, but the CCA gives you enough hint. If the CCA is very bad, in that case, you expect problem in these patients. Moreover, the other procedure where, even the, when you bring the basilar invagination, the many a times patient improves. And even if you see the SAC is not that much, significantly corrected. So since there is a good space, these patients will recover, even if there is a compromised CM angle or CCA angle. But I think 110 is usually the angle when it starts deteriorating.
Thank you, sir. Dr. Ingelalikar, sir, your question, please.
Sudhir,
yes, sir.
You said you were doing all these cases earlier transoral, and then you shifted to extraoral.
Yeah.
What are the main difficulty there? And therefore you felt like changing and you continued with extraoral.
Yeah.
Technically.
Yeah, we have been trained of doing, ACDF, and it is a very easy procedure, and all of us are doing this. In the transoral surgery, there is a significant morbidity. The healing of the wound is one. If you have not approximated it properly, there is a giving way of the, closure, and there may be infection, and that has led to a significant problem. So that's why anteriorly when we are doing, it is just a release. So soft tissue release, it takes less time, and it is very easily, it can be done from, extrapharyngeal approach.
Now, could you by going from one side, could you approach the opposite side and release soft tissues on that side? Because we have found that when we did this, sometimes the rotational alignment still remained. In fact, when we tried to correct it, once it rotates rather than completely comes back posteriorly.
No, actually, sir, when we are doing anterior release, the opposite side, suppose we are approaching from the left side, the right side can be very well, released nicely. Because practically the incision is slightly on the left side, but practically we are able to see the whole cervical spine anteriorly from, both sides. Longus colli is nicely visible, and it can be done without any problem. Even for the rotation, you have released everything from the anterior. Whatever little remaining is there, you can do further from posterior, because we are going to flip this patient and we are going to approach from behind. I think anterior release is superb, and it should be practiced.
Okay.
Thank you, sir. So, Dr. Srivastav, sir, I would like to invite you now to please invite our esteemed faculty and chairpersons for the next session, and go ahead.
Thank you very much, Satyan. And it is my proud privilege to invite, Dr. Yu Shen. This session we are going to have, combined with CSRS AP, and it is my proud privilege to invite President of CSRS AP, Professor Yu Shen. Can I have the slide, please? Wama, tech team, please. So Professor Yu Shen is president of CSRS AP. He is member of Chinese Medicine Association, member of Chinese Orthopedic Association, Chinese Academy of Orthopedic Surgeons, member of Chinese Rehabilitation Medicine Association, member of Cervical Spondylosis Society, member of Beijing Medicine Association, and member of Beijing Orthopedic Association Cervical Spine Society. He is the corresponding member of Cervical Spine Research Society, active member of Cervical Spine Research Society Asia Pacific section, and member of International Society for Advanced Spine Surgery. It is my proud privilege to invite Professor Sun Yu. Kindly join us, sir, and be our co-chair for this session. Professor Yu Shen, please.
Hello.
Is he there? Hello. Good morning.
Hello,
and welcome. Yeah, good morning and welcome. So please join us as the chairman of this session.
Thank you. Thank you so much for inviting us to join this Bone Marrow Spine Society's annual meeting. I have been online for a while, and the meeting was so excellent and discussion was so good. and also the case discussion and also presentation are excellent. So I have learned a lot. So I'm happy to moderate this session with Dr. Sadish, and in this session we have 6 presenters. So first of all, then let's invite Professor Abumi from Japan, and he's going to talk the dropped head syndrome. Professor Abumi, please.
Yeah, Professor Abumi is not new for us. Rather, he's a well-known international faculty and is a great academician. He is the founding president of CSRS-AP, Professor Emeritus of Hokkaido University, and consultant at Sapporo Ortho Hospital Center for Spinal Disorder, Japan. Now, I invite Professor Abumi to deliver his talk on dropped head syndrome. Professor Abumi, please share your slide.
Okay. Can you hear?
Yes, sir.
Can you see my slide?
Yes, we can.
Okay. Yes. So thank you so much for inviting me to this meeting. I'm very glad to see the doctor from India, Nepal, and China. So my topic is the surgical treatment of drop-head syndrome. Drop-head syndrome is a very special deformity in the cervical spine. You have to consider several specific factors to select the treatment. We have many causative disorders of drop-head syndrome, such as the motor neuron disorder, such as ankylosing spondylitis, post-myelo, neuromuscular junction disorder, such as myasthenia gravis, muscle disorder. We have many: idiopathic or primary cervical myopathy, radiation-induced myopathy, etc. And also, sometimes endocrine or metabolic disorder cause drop-head syndrome, such as the Cushing syndrome or hypothyroid myopathy. But many neuromuscular disorder we cannot manage the drop-head syndrome caused by the neuromuscular disorder. But some case of drop-head syndrome, such as the post-injury, post-laminectomy, post-infection, etc., can be surgically managed. So, drop-head syndrome is developed by 2 factors. One is dysfunction of posterior cervical stabilizers, including a neck muscle, posterior bony element, etc. Second is a rigid thoracic spine. Thoracic spine is less flexible and cannot compensate cervical kyphosis, especially in the elder patient. And drop-head syndrome patients had the symptom of horizontal gaze disturbance and limited ability of swallowing, respiration, etc. That leads to dyspnea, dysphagia, sometimes dysphonia. Once kyphosis developed in drop-head syndrome, and loading axis shifted anterior, transferred anterior. So this caused a vicious cycle of deformity development. And on advantage stage of drop-head syndrome, posterior muscle group does not work at the extensor. So in the final stage of drop-head syndrome is a chin-on-chest deformity. This is a case of a young girl, 11 years young girl. She had the post-laminectomy kyphosis after expression of intramedullary spinal cord tumor. Now, this
Dr. Abumi, can I interrupt? So your slides are not moving.
Yeah, moving.
No, the slides are not moving.
Not moving. Okay. My computer is moving.
Because we could only see one slide for a while.
No. Maybe something wrong.
Can you put up the PowerPoint and not play it in the PowerPoint mode maybe? You'll have to click on every slide to move ahead.
Okay, I'll send a new slide. Maybe.
We have Dr. Abhumi's presentation. We will play it from our end.
How about now?
We can play the presentation for you so that you can just speak. You'll have to say next if it doesn't work.
How about now? It's moving?
Yeah.
Now, yeah.
Yeah, it is working.
Now it's
Okay.
moving. Yes.
Yes, sir, it is moving. Please go ahead.
Okay. This is not a Dravet syndrome. This is a young girl. She had a post-rheumatic kyphosis after extirpation of intermediate spinal cord tumor. But this deformity is flexible, and the global spinal balance is not so bad. So we can manage this patient only cervical fixation, cervical correction like this. But no, it doesn't work. So, okay, but if patient has like the Dravet syndrome with global spinal imbalance, they require recovery of global spinal balance. Okay, can you see? We have two tools for deformity correction in the cervical spine. One is cervical instrumentation, another is the destabilization by spinal osteotomy for rigid deformity. So we have many cervical instrumentation: anterior screw, pedicle screw, laminar screw, and white screw like this. So, but pedicle screw is the strongest. So pedicle screw fixation provides greater product strength and stability for repetitive loading. So we can expect high capability of deformity correction. This is very good tool for deformity correction of the Dravet syndrome. So the cervical pedicle screw had the good stabilizing effect. We can stabilize unstable cement, correction of the kyphosis, and reconstruction of the cranial vertebral junction deformity. Another tool is osteotomy, cervical osteotomy. For the Dravet syndrome, we can use two types of osteotomy. One is complete rejection, SPO, and another is the PSO, pedicle subtraction osteotomy. This is a closing wedge osteotomy. But we can use this only for cervical surgical junction. Yeah, Smith-Peterson osteotomy, SPO, is simple osteotomy. But we have a risk of iatrogenic foraminal stenosis by shortening of the posterior column. We have to be careful. And the next is a pedicle subtraction osteotomy. This is more safe for nerve roads, but we can use this osteotomy only at the cervical surgical junction of C7 or T1. Lateral column resection is more extensive osteotomy, but we seldom use this osteotomy for deformity correction. I have the 20 cases for last 20 years and surgically managed Dravet syndrome. The gender is mostly 13 men and 7 women. And age was 65.7 years in average. 9 patients was idiopathic, and 4 patients had the post-laminectomy at the Dravet syndrome by post-laminectomy or post-laminoplasty. 2 was caused by rheumatoid arthritis, and 2 was caused by post-traumatic or Parkinson's syndrome. And 2 cases had the ankylosing spondylitis. 1 case had rheumatoid arthritis. All patients complained horizontal gaze disturbance, and 13 patients complained dysphagia, and 4 patients complained dysphonia and dysphonia. 8 patients had cervical myelopathy. In 7 patients, deformity progressed to chin-on-chest deformity. Regarding the osteotomy I did, 16 patients did posterior osteotomy alone. 14 patients had Smith-Peterson osteotomy, and 2 patients had the pedicle subtraction osteotomy. 2 patients required a combined anterior and posterior osteotomy. 2 patients with flexible deformity did not require osteotomy. Regarding the instrumentation, I used cervical pedicle screw fixation on all patients. Fusion level was the C2 or C3, C4 down to T2 or T10 and 18 patients. 2 patients required occipital surgical fixation. They had Atlantic axial instability by rheumatoid arthritis. This is the overall result. I would like to very talk simply. All patients had bone union, and 2 patients required extension of fusion level down to the mid or lower thoracic spine. And 8 patients had a myelopathy preoperative, but completely healed in 6 patients. 2 patients had partially improved, not completely improved. We had several complications. 3 patients had a transient nerve root lesion by iatrogenic glomerular stenosis, C5 nerve root lesion 2, and C8 nerve root lesion 1 patient. And the nerve root complication was healed by foraminotomy in 2 patients, and 1 patient had healed spontaneously. And 1 patient had a correction loss by C2 pedicle dislodgement. This is the correction rate of kyphotic deformity, subphagic deformity, kyphosis. The preoperatively, the 76 degree in average improved to 19 degree in average at the final follow-up. Regarding the transposition of the loading axis, skull plumb line. So the skull plumb line, the plumb line from the external acoustic foramen. And all patients, 14 patients had transferred to the anterior posterior of the sacrum. This is a good result. But 6 patients had remained improved, but remained at the anterior of the sacrum. Sternum, not sternum, sacrum. This is one case of a 78-year-old male. She had Dravet syndrome, but etiology was unknown. She had mild myelopathy. So I did C376 laminectomy and SPO at 3 level and C2 down to T6 fixation. And post-operatively, this patient had C5 nerve root palsy bilaterally. So I did additional foraminotomy for this patient and healed completely. You can see the global spinal balance improved very well. This is a little bit problematic case. This patient had Dravet syndrome and cervical surgical kyphosis was very severe. You can see apex of the kyphosis, the upper thoracic spine. But this patient had not so rigid, flexible. So I did fixation from C2 down to T3, C3, T5. But the apex of the kyphosis was maybe around the T4 or T5. So this the fusion level was not sufficient. We have to more longer fixation must be done. So 4 months after the first surgery, and this patient had a T6 fracture at the T6, and distal junctional kyphosis developed. So I did fusion level down to T10, and we had a good result for this patient. You can see global spinal balance has much improved. This is the ankylosing spondylitis by case. This patient had T1 chest deformity and kyphoscoliosis, young boy. I did pedicular subtraction osteotomy at C7. And I did osteotomy from posterior to anterior completely and corrected the kyphosis. Yeah, you can see cervical kyphoscoliosis improved, not completely, but improved well. This is another case of the ankylosing spondylitis. This patient was also young man. And you can see from the upper thoracic spine to down to the sacrum completely fused by unclotting spondylitis. So on the first step, I did pedicle subtraction osteotomy at C7 for correction of cervical thoracic kyphosis. This is okay. But during the waiting the next surgery of the lumbar osteotomy, she held down and he had a fracture at T10, 11 level. You can see this is a the extension injury of the lower thoracic spine. But so we extend the fusion level down to the L1. But the scalp line will still remain at the anterior of the sacrum. So we considered another osteotomy must be done. So finally, I did the L3 PSO for this patient. L3. So we can see scalp line improves very well. The C7 line is on the sacrum. So at the L3 PSO, I did 22 degree of kyphosis correction. Fusion was extended to the sacrum. We have to consider to decide surgical strategy many factors. Many factors should be considered for selection of decompression and fusion level in flexion surgery of Dravet syndrome. One is condition of spinal cord nerve root compression. Patient, they have a myopathy or head or not. And we have to consider rigidity of the cervical and thoracic spine. Location of plumb line from the center from the center of C7 and the external acoustic foramen, we have to consider two plumb line. And the length of kyphosis curve. And also we have to think about the global spinal balance. This is my surgical strategy for Dravet syndrome. We have to consider C7 plumb line and the scan plumb line and the global spinal balance. We divide the three types. Type A in the type A, and C7 plumb line locate posterior of the sacrum, and thoracolumbar spine is flexible like this. In these types, we can manage shorter fixation of the upper cervical spine to the upper thoracic spine, relatively shorter fixation. But if patient had type B deformity, C7 plumb line locate anterior of the sacrum and the flexible thoracolumbar spine. We need longer fixation for this type. In this patient, we extend the fusion level to the middle over the caudal of the middle cervical spine, apex of the kyphosis. And the third type C is a more rigid case. And plumb line, the anterior of the sacrum and rigid thoracolumbar spine, like such as ankylosing spondylitis. We need second stage surgery, cervical or lumbar osteotomy and other osteotomy for this patient. Twice osteotomy we need, like this. So we have to think about the osteotomy procedure. We have two approach, posteriorly only or combined anterior posteriorly. And the method of the osteotomy is PO or PS, which is better for this patient. And the osteotomy level must be considered, apex of the kyphosis or more caudal. This is the model of the Dravet syndrome, and the apex of the kyphosis is C45, and the caudal end of kyphosis is C71. So if we do correction of the cervical kyphosis by C45 osteotomy, and correction of kyphosis is okay, but transposition of the loading axis is not sufficient. But if we do osteotomy at C71 at the junction of the cervical surgery, we can get more good transposition of the plumb line. For correction of the Dravet syndrome, fusion area must be different from ordinary cervical kyphosis. Restoration of the cervical or global spinal balance is more important than correction of the kyphosis itself. Cranially, we require up to C2, C3, or more cranial. Caudally, extended to upper thoracic spine mandate, and in some cases required extension to middle lower thoracic spine, considering the pre-operative C7 plumb line, curve location, flexibility of the thoracic and lumbar spine, etc. Sorry. Surgical intervention for Dravet syndrome caused by neuromuscular disorder had been considered difficult and usually non-effective. However, sufficient correction can be provided by selected patients by combined use of cervical osteotomy and strong instrumentation. Surgeon can choose osteotomy type of SPO or PSO and approach of posterior alone or combined anterior or posterior. Level of spinal osteotomy and length of instrumentation must be decided considering deformity types and size and global spinal balance. Thank you for your attention.
Thank you very much, Professor Abumi. Now, since the next talk of Professor Sun is also on severe cervical kyphosis, I think we will take the questions together. Now, I request Professor Sun to deliver his talk. His talk is on the reconstruction after the correction of severe cervical kyphosis, the application of customized 3D printed vertebral body. Professor Sun, please.
Hello, everyone. I'm Dr. Sun. I'm from Peking University, Third Hospital. My hospital is
Tech team, the voice is not clear.
in north part
Vama,
of
the
the
voice.
city of Center. Because this is a pre-recorded video, so please replay it. The voice is not good. Please replay this video.
They are replaying, sir.
But the voice was terrible. Dr. Sun, I'm from Peking University, Third Hospital. My hospital is located in the north part of the city of Center, which is about 20. Dr. Sun, I'm from Peking University, Third Hospital. My hospital is located in the north part of the city of Center, which is about 25 kilometers away from Beijing Capital International Airport. My hospital has the biggest spine center in north part of China. Today, I'm going to talk about the reconstruction after the correction of severe cervical kyphosis, the application of customized 3D printed vertebral body. Severe cervical kyphosis is identified generally like local kyphotic angle more than 40 degrees. Sorry, the slides are not moving. So this is MP for video. Including the change of biomechanics, accelerated degeneration of adjacent segments, hyperlordosis of lumbar spine, and most severe is the spinal cord compression. For the treatment strategies of severe cervical kyphosis, we can is to decompress spinal cord compression listen the proper sound. Adequate correction.
I informed them, they're just looking at it, sir.
Yeah,
first
Dr.
step
Srivastav,
of treatment
can we move on to the next talk
surgical
while we
correction.
figure this out?
Yes, yes, we can do that. I think that will save the time too. And So, they should set it right in the back office, please. Or we will tell professors.
No, we'll go to the next talk and
yeah.
we'll get back to this.
Yes, that will be better. Now it is my proud privilege and glad opportunity to re-invite Professor Raj Sekharan. He has been always there in our conferences. Professor Raj Sekharan doesn't require any introduction. He is chairman of Department of Orthopedics and Spine Surgery in Ganga Hospital, chair AO Spine International Board, president Asia Pacific Spine Society. He is past president of Asia Pacific Spine Society, CCOT, CSRS AP, past president of IOA, ASSI, and ISSLS. He is an adjunct professor of Dr. MGR Medical University, a Hunterian professor of Royal College of Surgeons. Now, he has been very close to us, and all of us in India always look towards him for any academic challenges. He has mentored many of us, and now I request Professor Raj Sekharan to deliver his talk on compromise of thoracic inlet in cervicothoracic deformities. Professor Raj Sekharan, please.
Good morning. At the outset, I would like to thank Dr. Sudhir Srivatsa and the organizing committee for this wonderful conference, for this great opportunity to be connected with you. So the topic of my discussion is the significance of the thoracic inlet status in cervicothoracic deformities, as this is one area which is often neglected in our assessment of patients. When you see major deformities are like this, either in the cervical region or in the cervicothoracic region, we know that there is a lot of issues like issues concerning body image, general function, neurology, and also the high mortality and morbidity that may be associated with surgery. And one of the reasons for this is pulmonary dysfunction. And for pulmonary dysfunction, we always try to correlate it with uneven trunk growth, the narrow and distorted rib cage, the location and magnitude of the curve, which all leads to a loss of the vital capacity. But rarely do we actually see or talk about or evaluate one of the other important anatomical regions, that is the thoracic inlet. Now we know that the thoracic inlet is the superior thoracic aperture, the upper opening of the thoracic cage, and forms the important area of passage of vital structures from the neck to the thorax. And if you can see over here, there could be a lot of difference and compromise in this thoracic inlet whenever there is a deformity of the spine involving this region. It need not be an actual deformity of the cervicothoracic region, but the deformity can be higher up in the cervical spine, or it can be lower down, but the spine can be involved in a huge compensatory lordotic curve, which actually severely compromises the distance between the sternum and in the cervical and the spine, causing a distortion. Now, this could affect a lot of physiological process, but these effects have not been studied very carefully, because when you have an alteration in the chest wall rib vertebra complex, it will lead to thoracic inlet narrowing, and does that lead to cardiopulmonary dysfunction. Now, our interest in this area actually started off with this case, where you can see that he has got a very severe cervical kyphosis. Clinically, you can see that there is a huge kyphosis over here, and the entire thoracic spine was converted into a large lordosis. A 135 degrees kyphosis in the cervical region with 105 degrees lordosis at the upper thoracic region. Now, this actually led to a severe compromise of the thoracic inlet, as you will see. And as usual in all these huge deformities, which we can term it as a buckling collapse, you can see that multiple levels, the facet joints are completely dislocated. Now, our idea of this surgery was that we would loosen and straighten the curve as much as possible by a halo gravity traction, which we applied for 3 weeks. And this was quite useful to reduce the kyphosis to 84 degrees. Subsequently, we did a first stage anterior surgery where there was an anterior release, there was a corpectomy done, a temporary spacer was placed, and then the drama started. When in the second stage, on the same day, we planned to do a posterior column shortening osteotomy and deformity correction. So the patient was placed prone, and immediately over a period of 1 to 2 minutes, there was a slow and sudden onset of bradycardia and hypotension, followed by complete asystole. And so the patient was immediately turned for resuscitation, but we found that the heart rate became normal and slowly returned everything normal immediately on turning the patient to supine position. After stabilizing the patient, 2 additional attempts were made on placing the patient prone, and every single time, within 2 minutes of placing the patient prone, the patient had slow bradycardia and asystole. So the surgery was abandoned, and an analysis of the CT and MRI was done, and we found that there was a severe restriction of the thoracic inlet, which we had not taken into consideration before the surgery. Now, this was supposed to be the cause for this phenomenon, because we know that the right thoracic inlet, we found that it was very severely narrow, and prone position actually caused a further dynamic compromise. And because this is the location here of the right vagal nerve, and we know that the right vagus nerve supplies the sinoatrial node, which is the natural pacemaker of the heart. And the pressure of the medial end of the right clavicle on the vagus nerve caused a sympathetic inhibition, resulting in sudden parasympathetic overtone, leading to bradycardia and a complete asystole. Now, in physiology, this phenomenon is well known and is called the Basol-Jarris reflex, a subtle irritation of the right vagus nerve leading to a complete asystole. Now, once we realized this phenomenon, then we went on to this, another attempt where if we planned that when the patient is placed prone, if there is a Basol-Jarris reflex occurs, then we will do a thoracic inlet decompression, and then we will proceed with surgery. So this is exactly what happened, and we then went on to excise the medial end of the right clavicle. And once this was done, it was possible to place the patient prone without any change in the cardiac status. And then a posterior deformity correction was completed. And this was the excellent result that he had from 126 degrees to 45 degrees. And you can see the excellent result that he had. Now, this case actually led us to do some literature search. And we found that there was a lacuna in literature on the effect of narrowing of thoracic inlets. And we wanted to find out whether this narrowing correlated with the thoracic cage parameters and also the pulmonary function. So the study was done in Ganga Hospital. So the idea being to correlate curve characteristics with thoracic inlet measurements and pulmonary dysfunction. And we wanted to find out whether the calculation of a thoracic inlet index will be good in predicting pulmonary dysfunction. So this was done between August 2017 to August 2018, a one-year study done prospectively in Ganga Hospital. And we included all cases above the age of 8 years, cervical and thoracic scoliosis, kyphosis or kyphoscoliosis, and the deformity had to be greater than 30 degrees. And these were the exclusion criteria. We divided the patients into 3 groups. Group 1, which had 31 to 50 degrees. Group 2 had 51 to 80 degrees. And group 3 were cases which had a deformity of greater than 80 degrees. In all these patients, the thoracic inlet index was calculated. Now, this is a very simple calculation, which can be done on the MRI in a cut that is taken at the uppermost level of the sternum in the axial cut. So you do a transverse diameter, which is the maximum transverse diameter between the bony margins at uppermost sternal level. And the APS measurement was the maximum anteroposterior distance between the vertebra and the sternum at the same cut. Now, the inlet index was a ratio of the transverse measurement to the anteroposterior measurement. Now, this is a very simple measurement, and you can see that it can be done in the MRI, which is usually done as a preoperative assessment for these patients. There was no need to do any further investigation, and also there was no need to do a CT, which often increases the radiation to these young patients. So once this was calculated, this was correlated to many other rib cage parameters as transverse thoracic diameter, hemithorax height on concave and convex sides, concave and convex apex to rib distance, and AP measurement at the level of the manubrium. Now, these are all the normal radiological parameters which are used for in the calculation of the effect of the deformity on the pulmonary function. And for the calculating the pulmonary function, we did the 3 tests, and it was divided into these ratios depending upon moderate was between 41 to 51, mild was between 60 to 79, none was greater than 80. But if there was below 40, it was considered to be a severe restriction of the pulmonary function. Now, these were the controls which were also used to find out. And you can see that we had 80 patients and 20 controls, and the mean age of 14 years. 70% of them were females and males, and the etiology of the curves are shown here. Most of them were congenital or idiopathic, and there was between these two groups, it was equally distributed between 2 and 3. Now, group-wise distribution was that we had 6 patients in group 1, which is that deformity was between 31 to 50 degrees. The majority were in group 2, 70% almost, in deformity of 51 to 80 degrees. And 24% were severe category, which was more than 80 degrees. In the coronal plane, the maximum deformity was 114 in one patient, and in the sagittal plane, the maximum deformity was 109 degrees. Now you'll find that the thoracic inlet values correlated a lot with the nature of the deformity. Now in the controls, the maximum deformity was thoracic inlet index was 4.14 and minimum was 2.35. Whereas in group 1, it was, you can see that as the deformity increased, and group 3 is the group that had a deformity of greater than 80 degrees, you could find that the maximum was 7.35. And this actually correlated well with the pulmonary function. You can see that as from controls to group 1 to group 2 to group 3. And in group 3, the maximum was 7.35 from with the average of 3.94. This is actually showing the same values and how it increased with increasing deformity on the thoracic planes. Now you can see that the distance between the vertebra and the sternum in controls is so huge compared to what can happen when there is a huge lordotic compensatory curve at the same level when there is a huge deformity. Now, we did a multivariate analysis on what were the factors which affected the pulmonary function. And apart from the curve parameters of increased kyphosis, a upper level kyphosis, and the apex proximal to T5, we found that one of the things which was significantly affecting the pulmonary function, correlating, was a thoracic inlet index of greater than 5.6. Now, if you had a thoracic inlet dysfunction, and if your indices was more than 5.6, you had a moderate dysfunction. And if it was more than 7, it was a very severe dysfunction. So here we had an opportunity that just by doing the MRI, which is normally done as a preoperative assessment, and by doing a calculation of thoracic inlet, we were able to predict a moderate pulmonary impairment if the inlet index was greater than 5.6, and a severe impairment if the inlet index was 7.1. And it correlated very well with the clinical predictors of tachypnea, accessory respiratory muscle use, and also the radiological parameters. So this indices we found it to be very careful. Now, when we went back and saw what is the literature spread on this important topic, we found that there was a lacuna. So there were only case reports, or most of them were assessing by CT based, which is not very ideal in these young children of the problems of irradiation and an additional cost just for this. And we found that in patients who are very young and who may not cooperate for a PFT, then we can actually look at this as one of the indicators for pulmonary dysfunction. So we thought that this study was quite useful, novel, because it correlated the thoracic inlet distortion, anatomical entity, an anatomical measurement which has not been very much used routinely in our clinical practice. And what is important is that it can be calculated from MRI, and it avoids the use of a CT base. Of course, there is a limitation of the study, but we had a huge sample size of 80, and we need to have a PACS and perfect cuts to have the perfect calculation. But I think that this is an important tool that actually to bring a focus of us in the use of these in patients who are greater than 8 years, and it predicts the impending pulmonary impairment. So when you find that the index value is greater than 5.6, then we need to be very clear about the pulmonary function problems that it can happen. So this is one index which will help you to get a good idea of pulmonary function at no additional cost and no radiation. So if you have a problem of bradycardia or alteration of heart rate, when you are actually positioning the patient prone, we need to be careful and check for whether there is a dynamic inlet narrowing and whether there is the phenomenon of Basol-Jarvis reflex. So thank you very much for the opportunity to discuss.
Thanks a lot. Thanks a lot, Professor Rajsekharan. And since there was a lot of technical issues, we will be taking questions at the end. Now, Dr. Chitish, can we play the talk of Professor Sun? Yeah, please.
Hello, everyone. I am Dr. Sun. I'm from Peking University, Third Hospital. My hospital is located in the north part of the city of Center, which is about 25 kilometers away from Beijing Capital International Airport. My hospital has the biggest spine center in north part of China. Today, I'm going to talk about the reconstruction after the correction of severe cervical kyphosis, the application of customized 3D printed vertebral body. Severe cervical kyphosis is identified generally like local kyphotic angle more than 40 degrees. The consequences of severe cervical kyphosis can be severe, including the change of biomechanics, accelerated degeneration of adjacent segments, hyperlordosis of lumbar spine, and most severe is the spinal cord compression. For the treatment strategies of severe cervical kyphosis is to decompress spinal cord compression by the proper and adequate correction of kyphosis. The first step of treatment is pre-surgical correction by means of traction The purpose of traction is to extending the anterior column and shortening the posterior column, and that will make a surgical treatment easier. The occipital-mandibular traction is the most common method we used, but it has the shortage of limited force, hard to tolerate, and ensure effect, so it has been used less and less. Continuous skull traction is the most popular method used during the practice, but it also has the shortage of painful, difficult to nurse, and is definitely not suitable for the kids. Since 2006, we created a new method of traction. It's called balanced suspended traction. It has an advantage of non-invasive, no hurt, and more freedom for the patient. Patient can be off traction during the daytime for dining and toileting and bathing, and during the night he can be off traction for good sleep. Suspended traction can also be used with OM traction or skull traction as a combination. Once the kyphosis has been partially corrected by the traction, we are in step 2 of treatment, surgical correction. If patient has a minimal collapse of vertebral body, we can just use anterior discectomy and fusion on the plate to correct the kyphosis. This is an idiopathic cervical spine kyphosis with a kyphotic angle more than 60 degrees. We put him on a suspended traction for 1 week. Then he received 3 levels ACDF. The kyphosis has dramatically reduced. This 12-year-old girl had an idiopathic cervical spine kyphosis. The cup angle is more than 77 degrees. She received combined traction for almost 2 weeks. On the day 13 of traction, the kyphotic angle is only about 7 degrees. She received 3 levels ACDF, and the cervical lordosis has been restored after the operation. At 1 year after operation, her neurological function returned to normal, cervical lordosis remained, and the spinal cord compression was thoroughly relieved. In some patients, the kyphosis cannot be partially corrected by the traction, so we have to give them anterior, posterior, anterior procedures, and this can be done in 1 stage or 2 stages. This patient suffered from post-laminectomy kyphosis. The cup angle is nearly 60 degrees. He received combined traction for 6 days. The cup angle improved about 30%. So he received posterior release and osteotomy, a multi-level ACDF, and the posterior fixation and fusion. After operation, the kyphosis was dramatically corrected and the neurological function obviously improved. This 5-year-old little boy had uneven steps and left hand weakness for half a year. The cup angle was near 100 degrees. He received a combined traction for 1 week. The kyphosis was dramatically corrected. Because his anterior column is too small to bear any implant, so we have to perform the posterior release and the correction and fixation only. 5 years after operation, he returned for review with normal neurological function and no hardware failure on the cervical spine. Some patients, their kyphosis has been partially corrected by the traction, but they had very severe collapse of vertebral body. So in that situation, then we have to perform a corpectomy. This little girl suffered from osteochondral dysplasia, and her cup angle was 70 degrees, but she had skull traction for 2 weeks with minimal improvement of cervical kyphosis. So we put her on a suspended traction for 1 week. The cervical kyphosis obviously improved. She received C3 corpectomy with the implantation of a titanium mesh, but 1 year after surgery, she returned and we found the mesh subsidence happened. Fortunately, the neurological function remained normal. This is another example of severe cervical kyphosis, and he had previous ACDF. He received combined traction. The cup angle was dramatically improved. Then afterwards, he received posterior osteotomy, multi-level corpectomy, and posterior reconstruction for the final correction of cervical kyphosis. His neurological function improved after operation, but from X-ray, and we found the titanium mesh didn't fit the end plate very well. During past 10 years, the application of 3D printed metal implantation in orthopedics has been developed very well. Now it is a mature and stable technology, and also it has a larger surface, smaller intensity of pressure, with satisfied bone ingrowth. In 2014, the world's first case of 3D printed customized artificial cervical vertebral implantation was performed in our hospital. This patient had a cerebral palsy with severe cervical spine kyphosis. He received suspended traction. Now afterwards, we performed the anterior-posterior approach and 3D printed artificial vertebral body implantation. 8 months after operation, and we can see the fusion has been solid. This patient had a severe congenital cervical kyphosis and also combined with the postlaminic kyphosis due to intramedullary tumor. After receiving the suspended traction, a combined anterior-posterior approach was performed with 3D printed artificial vertebral body implantation. This 3D printed metal artificial vertebral body has the advantage of minimal request or even no need for bone graft. It can be used as a reconstruction of 1 or 2 vertebral bodies. But this 3D printed metal artificial vertebral body has some shortage, like poor self-stability. The longer implant, the worse stability. Sometimes the implant displacement and subsidence happened, especially in longer implant. This 79 years old gentleman suffered from CSF and severe degenerative cervical kyphosis. He received hybrid surgery with the corpectomy and ACDF, but 3 months after the operation, he returned with a neurological deterioration. From the X-ray, we find the subsidence of 3D printed artificial vertebral body with the feeder of the plate. For the purpose of the revision surgery, we designed a new implant with a self-stable customized implant with a screw fixation into the vertebral body. His neurological function improved after the surgery and no hardware failure after the operation. This 40 years old gentleman suffered from tuberculosis of cervical spine. At the beginning, he only had neck pain, but after the massage, he developed incomplete quadriplasia. After 2 weeks skull traction, the cup angle was only 16 degrees. So we made a surgical plan. So after the skull traction, a multi-level ACCF will be performed with a self-stable customized implant with a screw fixation into the vertebral body will be performed, and also with the posterior instrumentation. But we found a problem with this kind of implant. The implant may shift backwards during the screwing into the vertebral body. So we designed a new implant with a self-stable customized implant with a screw fixation into the vertebral body and with a flange. Finally, he received a 3-level corpectomy with a self-stable customized implant with a screw fixation into vertebral body and a flange fixed into the vertebral body with a posterior C2 to T1 instrumentation. After operation, his neurologic function improved, and the anterior column of cervical spine has been reconstructed. The 3D customized artificial vertebral body can also be used in other cervical spine disorders like OPLL. After the corpectomy, the implant was put into the gap. As the screw drive in, the vertebral body was pulled towards the implant to achieve a solid fixation. And also, as the screw drive in, the flange was pushed towards the vertebral body to achieve a solid fixation. In summarization, the 3D printed customized artificial vertebral body has the advantage of good adaptability, good stability, good radiological result. It can be used as the application of reconstruction in cervical kyphosis and other cervical spine disorders. Before I finish my talk, I would like to welcome all of you, my dear colleagues, to join our own society, Cervical Spine Research Society, Asia Pacific. The 12th annual meeting and the 2022 instructional course of Cervical Spine Research Society, Asia Pacific will be held in March 24 to 26, 2022 in Beijing. The new deadline for call for abstract is December 1st, 2021. Please visit our official website at www.cssap2022.cn. I hope the COVID-19 pandemic will be well controlled worldwide so we can have a chance to see each other in Beijing. Welcome to China. Thank you very much.
Thank you very much, Professor Sun, for an excellent talk. Since all three talks, previous talks were of deformity, I think we can have 1 or 2 questions, please, as we are running short of time and we have exceeded a lot. Please. Now there is a question for Professor Sun. How does one take dynamic nature of correction of kyphotic deformity by pre-op CT-based 3D model?
So yes, so we put patient on the traction, and after the traction has been, before any treatment, the patient will have a original CT scan. Then we put all the data and into the computer to help us to design the plan of the correction. Then for some severe kyphosis, now we just repeat the CT scan after the traction. So we bring patient to the CT room and restore this traction equivalent. Then patient will have a CT scan under the traction. So that we can have a design for the correction and also for the model and more precisely. So that's the plan, and also that's the way we're doing just now.
If there is no further question, then I invite Dr. Ajay Sethi, the consultant spine surgeon from Ganga Hospital and past secretary of SSI, to present his talk on extended OPLL. Dr. Ajay, please.
Greetings. I'm Dr. Ajay Shetty from Ganga Hospital, Coimbatore, and I'm going to speak on extended OPLL. At the outset, my sincere thanks to Professor SKS and the Bombay Spine Society for giving me this opportunity. We do know that the posterior longicular ligament extends from the tectorial membrane of the base to coccyx. Therefore, any ossification or pathological ectopic ossification of the PLL can extend from the cervical spine from C1 up to the thoracic and lumbar vertebra. Even though popularly reported in the Japanese literature, we do now know that the OPLL is present worldwide. If you look at the prevalence of OPLL worldwide, in the Asian subcontinent, earlier it was reported as 2 to 3%, but now we know it is about 6%, whereas in the US it is about 1.3 to 2.5%. What has changed with time is the imaging modality of choice, with CT scan being the imaging modality of choice. There is a higher prevalence that has been reported. In the Indian subcontinent, the incidence of OPLL is unknown. Therefore, with this, we did a study of 2,500 CT scans, and we noted a prevalence of cervical OPLL of about 5% in the Indian population. The most commonly affected decade is the sixth decade, and most common involved level is C5-6 level. When you look at the various phenotypes of OPLL, the segmental type is common, which is similar to the Japanese study, whereas the second most commonest is the mixed one, whereas in the Japanese study, it was the continuous one. When you look at the association between the cervical OPLL and the thoracic OPLL and thoracic OLF, you can see that thoracic OPLL is about 7.8%, whereas the thoracic OLF is about 36%. When you look at the Japanese studies, they have quoted a coexistence about 56%, whereas of OPLL, whereas of thoracic OLF, it is about 44.9%, which is much higher than our study. It's probably because we used a trauma series of patients which were much younger overall in age. What about the extended OPLL? That is the OPLL that extends into the cervicothoracic junction. In our study, the majority of the thoracic OPLL is situated in the T1, T2. This T1, T2 are the upper thoracic spines. This is similar to the study which was published in 2018 by Hirai et al., wherein they also noticed that majority of the OPLL occurs in T1 in men and T3 to 4 in women. But of interest is that whenever you have severe OPLL of the cervical spine, there are multiple ossified lesions along the cervicothoracic and thoracolumbar junctions. They also noted that patients with high cervical ossification index, there is multiple vertebra that is involved, has got a higher risk of ossified lesions in the whole of the spine. The importance of all this is the fact that whenever you have OPLL in the cervical spine, it's always important or mandatory to screen the whole of the spine. And if necessary, you may need to use a CT scan to diagnose significant lesions in other areas of the spine. It's also important, Hirai et al. In one of the other studies also noted that the thickness and extension of the ossified lesions may be associated with lower extremity dysfunction in cervical OPLL. That means whenever there is a cervicothoracic OPLL, there is a higher chances of disability in this particular group of patients. What is characteristic of this group of patients? The presence with early onset of symptoms with regards to age, associated ossifications of other spinal ligaments. Since it's a transition from lordosis to kyphosis, it allows a posterior fallback and a posterior approaches could be adequate. It could be either in the form of a laminoplasty or laminectomy. What we usually use is either a lateral mass screws in the pedicle screws or a pedicle screw construct. We also use pedicle screws on one side, and we have found that there is no difference in outcome between a solitary or a bilateral pedicle screw constructs. In our analysis of 63 patients of these patients, about 7% of them did not have any change and 6% had worsening of neurology with a gradual recovery. What is OPLL extending to C2? It is basically called a C2 plus OPLL. That is OPLL when it is situated cranial to the inferior end plate of the C2 vertebra. It's usually an extension from C3. It's in the earlier phase, it usually does not cause compressive myelopathy because of the wider canal diameter. What is different? It's relatively rarer. There's no clear guidelines on its management. The complexity of its anatomy makes it much more difficult to approach from the anterior side. As I mentioned, there are various approaches. Anterior approaches has been reported as by this article by Kimura et al., where they have used a modified Shikata's technique of using plate screws or a plate screw fixation if it's visible. But what is interesting is when you look at this result of the 16 patients, 7 patients had complications which were significantly higher. And the increase in JOS score was only 11 to 13, which is not very, very significant. It may be indicated in patients who did not have any major improvement following a posterior surgery, then probably an anterior approach could be indication. When you look at the posterior approach, either you can have a laminoplasty or laminectomy with instrumentation. But we do know by the deformity studies of the cervical spine that the instrumentation of C2, which does not affect the outcome, in terms of radiological or functional outcome. With this in background, we did a study of our patients. We had 61 patients. As you can see, the patients were much older with significant medical comorbidities, either 2 or 3 comorbidities in 30 to 40% of the patient. The mixed type was more commoner. The more number of levels were involved. And this is one of the case examples who underwent surgery with a significant neurological improvement. Or more examples. But what is important is that there was a significant neurological improvement from a mean JOS score of 10 to 15, with excellent in 44% and good in 54%. We had 6 patients with CSF leak. I will explain to them as to why I think it is. There is no difference in outcome between the K-line positive or a K-line negative group, or in between the HZ positive or HZ negative groups. When comparing our results with the existing literature, we found that our results almost matched to the published literature on this particular topic. And what our study reveals is that the space available for the cord is minimal in C2-5 level when compared to C2 minus OPLL, where commonly it affects the lower cervical spine. They have got a longer segments that is spanned. Intraoperative dural tear was a significant complication for us. And it posterior instrumented laminectomy and fusion gives reasonably good results. As I mentioned earlier, it was in the beginning when we started using ultrasonic bone cutters. As you can see, when you have the OPLL in the center, that's not a problem. But when the OPLL is extending laterally, if you're using an ultrasonic bone cutter, there is a limited space between, and hence there is a chance that when you are using the cutter through and through, it can cause a dural tear. Therefore, beware when you have an eccentric ossification when you are using an ultrasonic bone cutter. To conclude, the prevalence of cervical OPLL in Indian population is about 5.12. High cervical OP index increases the risk of ossified lesions in the whole of the spine, and hence whole spine screening is advocated. And in C2 plus OPLL causing myelopathy, the results is as similar to C2 minus OPLL, especially in our scenario of post-instrumented laminectomy and fusion. Thank you. Thank you very much.
Thank you very much, Dr. Shetty. I would ask you to, Dr. Shenling Wong, I'd invite him for the next talk and allow him to share screen. We will take questions for all the 3 speakers at the end. Dr. Wong, are you able to share your screen?
Yes, I'm sharing my screen.
Thank you very much. Please go ahead.
Okay, thank you, Chairman and professors, and thank you, Chairman and Professor Bumi, to invite me to have a lecture here. My topic is transoral release and posterior reduction for CVG kyphosis. I'm Shenling Wang from Peking University Third Hospital. In this hospital, Peking University Hospital, we had a craniovertebral junction team, and Professor Chao Wang was the previous head of this team, and from the last year, I followed him to be the head and the chief surgeon of this team. So for CVG kyphosis combined with swine neck, especially in the condition of irreducible atlantoaxial dislocation, is difficult to treat and had a dangerous procedure to correct the kyphosis. And in the literature, the procedures include anterior decompression fixation, anterior decompression, and posterior fixation. In our team, we use anterior soft tissue release and posterior reduction, and we published this procedure and case series 15 years ago in Spine Journal. In Dr. Manis's 2015 algorithm, he divided CVG deformities into two issues, reducible or irreducible. But these two sides of this tree separated from each other, and it can not be converted from irreducible to reducible. That's his tree. And in our tree and algorithm of Peking University Hospital, we use transoral release this procedure to make a conversion from irreducible deformity to reducible deformity. From the right side of this tree, we can see we make almost all the cases from the right side of irreducible issues to the left side reducible. That means easy and safe procedure to make the reduction of these issues. So today I introduce the transoral soft tissue release procedure using a single case. This patient was female, 46 years old. She had right hand numbness and calmness for 3 years, and her right arm and left hand and right leg numbness weakness continued. And physical examination reviewed muscle strength of the right extremities is lower, and she had myelopathy signs. Pre-op X-ray showed that she had atlantoaxial dislocation and swan neck of the lower cervical spine, too much lordosis and kyphosis of CVG. This is preoperative CT. We can see she had basilar invagination because of C1 occipitalization and atlantoaxial dislocation, and the tip of the odontoid compressed the brainstem. And also she had the left side C2 pedicle agenesis. And preoperative MRI showed she had basilar invagination, anterior compression, carried deformity, and especially severe syringomyelia from C2 to C5. She had a big syringomyelia. So the diagnosis is irreducible AAD with occipitalization, BI, cervical myelopathy, syringomyelia, especially she had a CVG kyphosis. The surgical plan for her is traction under general anesthesia. You can see after 10 minutes traction with 1/5 of the body weight insufficient, incomplete reduction. So the transoral release was performed. This is an anterior procedure. We can make a gas tube first, and then sterilize using iodophor. We open the mouth and the tongue. Again, we use iodophor to release and decrease infection rate. And then we perform 2 soft pellets via the nose. Then we use a Codman retractor to open the mouth and open the field. And we use epinephrine to decrease the bleeding. It's a midline incision, and we cut the anterior ligaments and the longus colli and longus cavities to release first step. Then we remove the C1 anterior arch. Then the left side lateral mass of C1, C2. We use a curette to release the left side C1, C2 joint. During this procedure, we use traction of 1/5 of the body weight. So that's the step of release the left side alar ligament. And this is tip of the dance, and this is apical ligament. We pull down the tip of the odontoid, again the left side alar ligament. I skip the right side soft tissue release because the time limit. So this is last step of anterior release. This is very soft. Then this is the end of anterior procedure. After the release, it's easy to pull down the dense tape. So that means little and soft stress for the posterior reduction procedure. Then the same time posterior reduction procedure. Also 1/5 body weight of the traction. Epinephrine and lopicaine. This is the right side C2 pedicle exposure. Because this patient has left side C2 pedicle absent, so we have to use the right side pedicle screw mostly on the right side, and the left side is C2 laminar screw to help the right side. So the most of the strength was on the right side C2 pedicle screw. So we have to use a long C2 pedicle screw, and we decided to extend the fixation from C2 to C3 to help the fixation and reduction procedure. This is C3 lateral mass screw. This is the entry point of C2 left side laminar screw. We first insert and connected the right side pedicle screw and the C3. Then we pull down the screw and roll together to reduce the kyphosis and correct the kyphosis. And the left side is not so strong, so we use laminar screw and C3 lateral mass screw to help the right side. We use mossilized iliac bone to make the fusion. perform the furin bed is mostly like the ilic furin. So this is a preoperative X-ray, the left side. This is post-operative 5 days. The kyphosis is correction. From the pre and post-operative CT, we can review that the kyphosis correction is very good and a little bit over reduction of the DANS and C1. Because this patient had a big syringomyelia, so over reduction is enough and effective for her. This is post-operative only 5 days. We can see very much decreasing of the syringomyelia. 4 months follow-up, she had dynamic X-ray is very good, and furin is very rigid, and the furin is solid furin from C2 to the occiput. So this is pre-op MRI, this post-op 5 days, and 4 months later, almost disappear of syringomyelia and compression. So 4 months out, she had a very good gait and right hand function. So for this procedure, we use transoral release and posterior reduction for CVG kyphosis and irreducible atlantoaxial dislocation. Transoral release is effective for CVG kyphosis correction. This procedure can convert the irreducible deformity to reducible with very easy and safe to avoid the odontoid ostomy. This safe and effective. And also transoral release decreased the strength between the occiput and the C2 hardware to reduce the hardware failure. Thank you for your attention.
Thanks a lot, Professor Wang. Excellent talk. We'll take the questions later on. Now I invite Dr. Somajit Basu, the President-elect of ASSI, to give his talk on atlantoaxial rotative subluxation. Dr. Basu, please. Start his talk.
Good
please.
morning. I'm thankful to Bombay Spine Society for inviting me to this conference, and my topic is atlantoaxial rotary subluxation and its evaluation and management. What I shall try to cover in the next 10 minutes: definition, predisposing factors and etiology of atlantoaxial rotary subluxation, go on into the kinematics of C1 C2 rotation, the imaging protocols which have been so well described recently, and the types of atlantoaxial rotary fixation, and finally the treatment algorithm. It is defined as conditions inclusive of all gross departures from the normal rotational relationship between C1 and C2, and it is characterized by a persistent and often painful rotational deformity with the head in the cock-robin position, as if the chin is turned to one side and the neck is laterally flexed to the opposite side, reminiscent of a robin listening for worms. The commonest etiology is, of course, trauma, and secondly, it is infection, which might be an esophageal infection or proximal lymphadenitis in the neck region, which is Grisel syndrome, and tubercular infection. Previous surgery, especially of the head and neck region, can lead to soft tissue contractures and ultimately atlantoaxial subluxation, and an assortment of disorders ranging from rheumatoid arthritis to Down syndrome, Merkel syndrome, and some congenital cervical anomalies, including a failure of the proatlas leading to absence of the lateral mass of the atlas has been importantly associated with this condition. Now let us look at the kinematics of C1, C2 rotation. There are three distinct phases. The first 23 degrees, C1 moves alone. The next 23 to 65 degrees, C1 and C2 both move. C1 moves more than C2. And beyond 65 degrees, C1, C2 move together. Now, obviously, if you plot the C1, C2 angle graph, the initial first 23 degrees, the gradient is 1. That means the C1 alone is moving, and the C1, C2 angle increases according to the increase of movement of C1 from the neutral axis. For the next 23 to 65 degrees, there is a double motion phase. That means the angle between C1 and C2 gradient gradually decreases from 1 to 0, and in the next few degrees, that is beyond 65 degrees, the two bones move in unison, and that means that they can rotate up to 90 degrees, and this implies that the head turns beyond 65 degrees. Rotation exclusively occurs at the lower part of the spine. The kinematics of C1, C2 rotation was put forward by tackling Pang, and this is the curve which he put forwards, as I had explained in the last slide. If you look at the C1, C2 angulation plotted on the y-axis and the C1 movement from the neutral axis on the x-axis, in the initial first 23 degrees, you have a linear relationship. That means the C1 moves as much as the C1, C2 angle increases, and in the next few degrees, that means 42 degrees, you have a gradual diminution from 1 to 0 of the gradient of this curve, because in this part the C1 and C2 moves together, and the C1 C2 angulation gradually comes down, that the increase of C1 C2 angulation with the increase of C1 angulation gradually comes down, and after that beyond 65 degrees they move in unison, and in this entire part ultimately, that means beyond 65 degrees, the C1 and C2 are locked at an angle of 43 degrees with each other. The imaging protocols also has been put forward by tackling Pang, and there are three sets of CT scans which have been described. The first is in the P position, that is the presenting position with the head undisturbed and in a subluxed position. The next is with the head turned to or close to the 0 position by the physician who is attending the CT scan, and that is the P0 position. And finally, the head is cranked to the opposite side as much as tolerable, within the tolerable limits of pain, and this could be the P underscore or the corrected position. Now, if you look at the angulation of C1 to C2, that is the C1 C2 angulation, this is basically the angle of C1 from the vertical and an angle of C2 again from the vertical. So C1 minus C2 is the angle to look forward for. Obviously, as they move, the angle is C1 minus C2. So based on the severity of the pathological stickiness between C1 and C2, group 1 represents the extreme form with the two bones locked in coupled configuration. Group 2 is less severe stickiness, in that presenting separation the angle was reducible, but C1 could not be made to cross C2. And finally, if there is a minimal stickiness, C1 should be forced to cross C2, but only if the head was cranked to the expected null point at 0 degrees. Of course, this does not include irreducible atlantoaxial rotary fixation, that means the Fielding-Hawkins types 3 and so if you look at the three examples here and the initial position of the P position, that means at the subluxed position which the patient initially came to you with, this is the CT scan. That means C1 is rotated over C2, C1 angle is 40 degrees, C2 is minus 5 degrees, which means that the C1 C2 angle is plus 45. Now in this, if they are very mild, that means the C1 could be rotated to the opposite side, with the C1-C2 angulation ultimately at -25 degrees on the P underscore position. This means this is highly flexible. Whereas here you can see that it is very immobile, and C1-C2 angulation to start with was 45. It became just 40 degrees. That means just 5 degrees could be corrected. And in the middle part, that means type 2, it is not too sticky, again not too mobile, it is usually C1-C2 is plus 40. So in type 1, which is maximum sticky, maximum stiff, this C1 could not be rotated beyond C2, whereas in the minimally stiff, you can see that C1 rotates over C2 if the head is cranked to the opposite position. These are three clinical examples taken from the same paper, in which the proximal row is the C1 cut, the distal row is the C2 cut, the middle column is P0, and the left column is P underscore, and the right column is P. That means the position at which it came in a sublux position. So you see, this is type 3, where C1-C2 angulation becomes negative. That means this is the most flexible, and as you can see, C1 started off with this side, that's C1 with the angulation like this from the vertical, and here at P minus position or P underscore position, the C1 could be made to rotate completely over C2. C2 is here and C1 has gone beyond C2, so that means C1-C2 becomes negative. Whereas type 1, which is the most sticky, C1-C2 gets fixed at something very close to -40 degrees. So this is the subluxed position where she came with P, and this is the oppositely cranked head, where you can see C1 does not even come to the neutral, but C2 rotates like this, but C1 remains locked in about -40 degrees. And in between is type 2, in which the patient started with like this, in which the C1 is rotated over this C2, and in the oppositely cranked position, you can see that it has just come in line with C1-C2 and decreases. This means it's just become something like 5 or 10 degrees, but still has not become negative. Once it becomes negative, it is very highly flexible, which is type 3. Now, the original classification of types of atlantoaxial rotary fixation was given way back in 1977 by Fielding and Hawkins, and which we know in type 1, capsular ligament disruption occurs, and there is a peg view asymmetry with the atlantodense interval less than 3 millimeters, and the odontoid is the pivot. That means the C1 rotates over the odontoid, whereas here the atlantodense interval is not disrupted, and there is a capsular disruption to C1 joint. In type 2, there is a transverse ligament tear along with the capsular disruption, and here one particular facet joint of C1, C2 is the pivot or the axis over which C1 rotates, and here the ADI becomes something between 3 to 5 millimeter. If they are treated early, this unilateral subluxation can be reduced. And in type 3 and type 4, there is transverse ligament as well as secondary ligament tear. In type 4, there is also an odontoid disruption. So in type 3, both the lateral mass moves forwards with the ADI obviously more than 5 millimeters, and in type 4, both move backwards. Both the joints of C1 move backwards to C2, and this can only be possible with a odontoid fracture. Now let us look at the treatment algorithms. All acute and subacute atlantoaxial rotary fixation patients should be treated with halter traction, and on reduction the child should be braced for 3 months. This is the typical patient presentation in an acute and subacute phase, and they are usually well treated and the patients remain asymptomatic. Now in chronic or delayed presentations, they are usually managed with skull traction followed by halo vest immobilization for 3 months. And all recurrences while in or after removal of halo fixation, as well as all irreducible deformities after 2.5 weeks of skull traction treated by surgical fusion of the C1-C2 joint. If you look at this particular patient, she was an acute subluxation, and this was the initial CT scan and initial traction, followed by bracing for 3 months, cured her completely. Now, let us look at a chronic or delayed presentation. This is a patient again who had a delayed presentation, and this was the rotation of C1 on C2, and this is her with a halo after traction, and this halo was continued for 3 months. All recurrences while in or after removal of halo fixation, all irreducible deformities, even after 2.5 weeks of scalp traction. For example, this patient presented with a fixed irreducible atlantoaxial rotary fixation, and this was her initial traction where she didn't reduce, and that was why we did a complete open reduction of the joint, followed by C1, C2 Mager's screw fixation. This was the final result with a deformity completely corrected. Thanks for your attention.
Excellent talk, Dr. Basu. Now we'll be taking questions. The first question has been asked by Professor Sun to Professor Abumi. He is asking, can you start my video? If a kyphosis correction gets C5 palsy, how to predict whether it will be required, or if revision foraminotomy is required? You had 3 of these and 2 had foraminotomy and 1 did not. How is that decision made? And one more question he has asked to you, that is, when do you consider to extend the fixation down to thoracic spine below T3? Professor Abumi, are you there? Hello.
I think we can't see him in the list. We can take the next question.
Yeah, the next question has been asked by Dr. Sandeep. Question for Dr. Raj Sekharan. Is there any difference in interpretation of similar T1 value in kyphotic and lordotic spine at inlet level? And how does one take into account differential upper rib cage deformity in severe deformities, especially dysplastic ones? Professor Raj Sekharan, are you around, please? Can you take this question?
Is the question for me?
No, I think it's for Raja.
Raja? Okay.
Yeah, no, yes, the last question is for you.
Dr. Wong, how many fixation points do you think are ideal in the cervical spine if you are doing this procedure? Like you said that you did cervical, can this work only on the C2 pedicle and the lamina screw? You took additional lateral mass screws. Do you do that all the time?
So I can answer the question about the one, and I think the question is for the Dr. Sheng Yiwen. How many fixation parts in the cervical spine are needed for this procedure? So generally speaking, in our hospital, if the patient have a very solid bone for the C2 pedicles, and just from occiput to the C2 is needed. But if the bone quality is not good, and sometimes if they cannot put a bilateral pedicle screw for the C2, then Professor Wang Chao will extend the interfixation down to C3. In Dr. Sheng Liwang's case, he put the one last side for the pedicle screw and another side for the laminar screw. So I think that's the reason why he extend the interfixation down to C3. So there's one question for me, and what is the way to prevent the C5 palsy? It's a big question. So the reason for C5 palsy is quite complicated. But the general speaking is the principle is a stenosis of neuroforamina of C5. So for any kind of a procedure, is even just a simple open door laminoplasty or like a more complicated case like cervical kyphosis. If you find a C5 palsy, you just need to take an X-ray, CT scan, and sometimes combined with MRI. If you can see the C5 nerve root foramina is narrow, then in our hospital now we just take 2 weeks conservative treatment to see what happens. If the neuroforamina is very narrow and very stenosis is severe, then after 2 weeks conservative treatment, and if no more improvement, now we have to consider the second operation to enlarge the neuroforamina.
A nicely answered question. Another question is from Dr. Basu to Professor Sun. When do you use pedicular screws in the subaxial cervical spine, and when do you put lateral mass screw?
Good question. I think for this general speaking, for the cervical kyphosis, for the adults or a large age of a pediatric patient, and if their lateral mass is strong enough, then we always think about the lateral mass screw first. If their lateral mass is too small, then we have to consider the pedicle screw fixation. So because for freehand pedicle screw insertion, sometimes it will have quite high complications. But if you use the navigation system, and they will be much easier. And also, if you have a robotics, will be much easier as well. But generally speaking, the lateral mass screw can take more than, I think, 90% of cases to achieve a solid fixation.
Now thank you. Another question is from Dr. Chitish Chaudhary to Dr. Wang. Did you ever encounter a situation where you could not get reduction with transoral release when the joint were not bony fused? Dr. Wang.
Thank you for your question. Normally, we use transoral release during the procedure because of the very rigid, irreducible AAD. Sometimes in the situation of bony fused between C1 and C2, it's very difficult to make a reduction. So sometimes we have to use osteotomy via the transoral release. Sometimes we use soft tissue release. Sometimes, especially for the bony fusion between C1 and C2, is difficult and hard to release. So transoral release make a very useful procedure for this situation. And how many of the transorals get a wounded problem in your series? Sometimes we have infection from the transoral approach. Maybe this rate is about 10%, but we don't have any instrument during the anterior and transoral procedure, so that's safe, because even the wound problems occurred just like infection because of no instrument there, so it's easy to treat. Thank you.
Another question is from Bashu, that even if there is a problem, sometimes the C5 palsy, sometimes the C5 palsy is delayed. Initially, it is not there. So, what is the cause of this delayed palsy, Professor Sun?
Yes, it's generally speaking, and the cephalic palsy happened in 24 to 72 hours after surgery. If patient return from the operating room and his territory is weak, so that's not the definition of cephalic palsy. It's due to the intraoperative injury. So if they just develop 1 or 2 days after operation, is what they taught about the cephalic palsy. The problem is a neurological, is a neuroforaminal stenosis, and 2 days, 1 or 2 days after surgery, the nerve root have edema, and that might be the reason to cause muscle weakness. Thank you.
Thank you. Another question is from Dr. Chetish to Dr. Basu. Once you have succeeded in treating AARF in halter and brace, at the end of treatment, do you get CT scan again to assess the thickness of the C1, C2 rotations?
If the deformity is well corrected and the patient is painless, I wouldn't expose the child to another CT scan. But if I do feel, for example, in the one case which I showed you who had a delayed presentation, if you notice, she did not have complete correction of the deformity. She came to us 3 months after that, and we initially put her on a couple of weeks of skull traction, and she reduced by about 80%. And we had a discussion with the parents of the children who refused more of surgery. So we put her on a halo, and after 3 months, when we took off the halo, if you notice, she had about a 10 degree of torticollis, which was there. So in that case, I did a CT scan to prove that it was not fully reduced, which I shared with the parents. But otherwise, if the child is fully, clinically, she has got a good rotation movement, painless, clinically the deformity is well corrected, I wouldn't expose him or her to another radiation for a CT.
Thanks, Basu. Now, another question is for Dr. Wang. It is from Dr. Sandeep Sonone. How do you control the hypermobility after anterior release before posterior fixation? Your precautions.
Thank you. That's a very good question, and I have answered this question several times during the meetings. The hypermobility after anterior release, some doctors will consider is as not so much safe during the procedure. So because of the traction procedure we have and the external muscles control the alignment, so it's the safe during the procedure from the anteriorly or the posterior procedure. But during the procedure, we put the patient from anterior to posterior position, that the skeleton tone should be controlled by the chief surgeon himself and turn around carefully. So during the procedure of about 600 cases, anterior and posterior combined procedure, is very safe for these 600 patients. So in my opinion, that's not so much considerable dangerous during the procedure. Thank you.
Thanks. Another question is from Dr. Chetish to Dr. Ajay Sethi. These OPLLs have shown to have progression over even after surgery. Do you have a protocol to follow these long term? If yes, how long? Dr. Sethi.
I mean, definitely we need to follow them on a regular basis. I mean, what we usually do is look at clinical assessment and look for any deterioration. If there is any deterioration or new onset worsening of symptoms, then only we'll investigate. If not, we would not investigate either in the form of always with MRI, and if necessary, only with CT scan. There is no time limit. You have to follow them up till they are alive.
Thanks a lot. I sincerely thank all the participants, all the faculties during this session. And now I declare this session to be closed. Thank you very much. Now we'll be moving to the gold paper session. Now I hand over the proceeding to Dr. Satyan Mehta. Satyan, please.
Thank you, sir. Thank you for an excellent session. I must congratulate all our speakers, all our faculty, and thank them as well. You're all pioneers in this field, and we have a full house today. with all the people who have registered for the conference are presently watching this session. So we have 100% attendance for this. Thank you very much. It was an excellent, very impressive session. We will now move on to the next session, which is another prestigious session. This is the gold medal paper session. We received almost 80 or 80 to 90 papers for presentation, abstracts for presentation in this conference. And out of these, we have selected the 6 best papers which are going to be competing for the gold medal. All these papers are going to be assessed by judges who will not be named on the session here. And at the end of the session, we will be announcing the winner of the gold medal paper session. So I want to invite our moderators for the session, Dr. Ingal Alikar and Dr. Sandeep Sonone, to chair the session.
Yeah, thank you, Satyan. We were wondering whether Abhay Nene, where has he disappeared? But thanks for replacing him with Sandeep. Friends, you'll realize here, can you hear me? Can you hear me? Okay. Friends, we have 6 papers competing with each other for this gold medal session. And you'll be surprised to know that 4 papers out of 6 are on radiological aspects of something or other. It's surprising that so many people are now looking at this. Let's begin our session with the first paper. First presenter is Dr. Jwalant Patel, and he's going to present his work on spine surgery checklist, a comprehensive perioperative protocol. Dr. Jwalant Patel. Please stick to your time.
Good morning, respected chairperson, seniors, and colleagues. I'll talk about spine surgery checklist that is suggested and proposed by the authors. I would like to acknowledge all my co-authors for this study. To err is human. However, this sentence cannot be proved in the court of law if the error is preventable one, and the preventable errors are not uncommon with respect to the spine surgery that can result from the various reasons like lack of training, experience, fatigue, stress, lack of regulation and rules, huge workload, inadequate communication, and some social factors. Let me give you some case example from my study. There is an elderly gentleman with cervical myelopathy. He was operated with laminectomy. However, intraoperatively, we encountered a profuse uncontrollable bleeding, and there was no grouping and cross-matching done. And we lost the patient intraoperatively due to the non-availability of the blood. In another case example with a mobile grade 2 latissimus, we had a misdirected S1 pedicle screw, and while repeated attempt, we made a bigger hole. However, there was no rescue screw available in the implanted, and we have to deal with a compromised fixation. So like this, in many such instances and situations, that has prompted us to introduce a checklist. Like in a virtual meeting checklist, there is a strong need for spine surgery specific checklist that can reduce the failure, achieve the success, that can cover the weakness of human memory and forgetfulness, and increase the efficiency by adopting some simple steps. If we see the current surgery checklist approved by the WHO, it is a generic one. It is not a specialty and subspecialty specific. There is a lack of spine surgery specific checklist in the literature. In one of the studies, they have mentioned that 1 out of 2 spine surgeons during their entire career, they perform 1 wrong level surgeries. So the aim of this study were to propose a spine surgery specific checklist that can recognize the risk factor and human errors and reduce the surgical and post-op complication, and to evaluate the efficacy of novel checklist and its outcome. It is a retrospective study performed at a single tertiary care hospital between 2015 to 2017. A total 858 spine surgery patients were included that were divided between the study group and the control group before and after implementation of the checklist. The exclusion criteria were patient less than 10 years of age, polytrauma patient, and patient with less than 2 years follow-up. The preventable errors were divided between the 3 groups. Adverse event means the error has resulted into the harmful consequences. A near miss means the error is realized just in the nick of the time and the action is taken to reduce its translation. And the no harm means the error has not resulted into any harmful consequences. The checklist has three components: pre-operative, intraoperative, and the post-operative component. Here is a pictorial image of the pre-operative, intraoperative, and the post-operative checklist component with inclusion of the signature of senior spine surgeon, training fellow, ward in charge, and the OT in charge. It is a table showing the clinical and the demographic data of the two groups. However, there was not much significant difference with respect to the number of patients, mean age, type of surgery, region of spine operated, pathologies included, mean hospital stay, and the mean follow-up between the two groups. Coming to the result, there was significantly reduction in the perioperative errors like bleeding complication due to the incorrect position, complication due to the implant-related issue, surgical site infection, prolonged hospital stay, all were significantly reduced after implementation of the checklist. If we see the major complication like dural tear, unplanned ICU stay, reoperation rate, respiratory complication, all were significantly reduced after implementation of the checklist. So the preventable adverse event are actually the harm from the medical care rather than the underlying disease that result from the failure to apply an accepted strategy for its prevention. And the checklists are the key critical strategy that reduce the preventable human errors. If we see the WHO checklist, it has concluded that it reduced the mortality and complication. However, it is a generic one. There is a need for spine surgery specific checklist in the literature. And the wrong level spine surgery are the glaring example of the preventable human errors. The novel spine surgery checklist, it is a comprehensive 37-point perioperative care that reduced the preventable errors from 15% to 3%, including surgical site infection, prolonged hospital stay, unplanned readmission, and the wrong level surgeries. If we compare the current checklist and the WHO checklist, the our checklist is relatively elaborative. That includes the presence of various surgical levels, approaches, intraoperative imaging, issue of implant and implant-related complication, and the post-operative checklist component, which is very unique to our checklist. I would like to highlight some specific points on the post-operative component of our checklist that include the red flags and whether the proper discharging advice were given to the patient or not, like the bailout surgical plan, fiber optic were available or not, whether the bone graft available or not, whether the microscope, CM, navigation, and neuromonitoring was available or not. All these were included in the checklist component. Of course, there are certain limitations to our study, like it is a single center retrospective study, and there is a lack of comparison because there are no specific spine surgery checklist available in the literature. So there is a large randomized and the multi-center studies are needed. To conclude, the proposed novel spine surgery checklist, it is efficient, reliable, and cost-effective. It is a time-saving tool and subspecialty specific. It reduced the preventable adverse event, enhanced the surgeon's confidence. It reduced the miscommunication among the primary surgeon, training fellow, and OR staff. Thank you very much.
Can you start, open my video, please?
Sandeep, you can ask the question.
Yeah, thank you, Dr. Patel. So any questions for Dr. Patel? So we can take questions, to do the questions before we move on to the next talk. Vidya, sir, you wanted to ask any question?
My video has been stopped.
Yeah, we can see you, sir. We can see you, sir.
Yeah, Dr. Jwalan, this has elaborately always consumes time. I want you to tell us how meticulously, how arduously this was followed by everybody who was concerned.
Good morning, sir. Thank you for the question. Initially, sir, it was started and included as a part of our training program. We have given the formal introduction and training to the training fellows, ward in charge, and the OT in charge. And we, before the admission, starting from the admission to the discharge, we follow a routine these checklist protocols, and everyone included in the healthcare personnel, starting from the patient admission to the surgery to the post-op part until the post-op discharging advice were given. All points were included, and the training fellows does the job before the surgery and in the intraoperative as well as the post-operative parts.
So somebody oversees that everything is done.
Yes, sir.
Everything is done fine to time.
Yes, sir. We have now developed a web-based checklist protocol also, so that the senior spine surgeon who has invented the checklist,
he cross-check as well as the verify and make sure that the compliance of the checklist is done properly.
Yeah. Dr.
Very often we have seen such checklists of different aspects of management are done, and after a few days, because they are elaborate, they sort of wither out and they're not followed anymore.
Yeah.
Don't let that happen to you.
Thank you, sir. We have one more question, Dr. Jwalant.
Yes.
When was this the utility of the checklist depends on the time when it is assessed pre-operatively. So when was this pre-operative assessment done? A day or month, or what was the time duration of assessment?
Yes, sir. The checklist has total 3 components, sir: pre-operative, intra-operative, and post-operative. The pre-operative components, the training fellow on the day just prior to the surgery, they perform all the pre-operative checklist. During the intraoperative part, just before positioning the patient, we make sure that the intraoperative checklist component has done properly. And in the post-operative, after the patient has moved to the wards, we make sure that all the post-operative component until the discharge has properly done or not.
Okay. Okay. Thank you.
Thank you.
So we move on to the next paper by Dr. Nitin Adsul on clinical and radiological outcomes following the use of triangular sacroiliac joint cages in addition to sacral two screws to enhance spinopelvic fixation. Dr. Adsul.
Work on clinical and radiological outcomes following the Petrov technique to enhance spinopelvic fixation. So if you fix L4 to S1, there is 168% added.
Can we increase the AV, please, the audiovisual team?
If you fix only the L5,
can we increase the voice, please?
There is a 52% added stress on the sacroiliac joint. In the current literature, the
audiovisual team, can we increase the volume, please?
Following the long fusion is between 12% to almost 35%.
Can we increase the volume, please?
By our group, which has already been published.
Can you stop this presentation? Tech team, please go to the next talk and figure this out so we don't waste time.
That audio was really inaudible.
To go to the next
talk. So we will have the next talk by Dr. Umesh Kannade.
Umesh Kannade, correct.
Yeah, on non-fusion anterior scoliosis correction.
Non-fusion anterior scoliosis correction surgery, a novel promising modality for the treatment of adolescent idiopathic scoliosis. Time-tested traditional spinal fusion is considered the gold standard for the surgical treatment of adolescent idiopathic scoliosis. However, certain studies showed that an increased risk of decreased spinal growth over the length of fusion construct, decreased spinal mobility, adjacent disc degeneration, back pain in the long term with spinal fusion. Surgical treatment of idiopathic scoliosis has experienced some innovations in the recent years, especially as regards to the treatment of the bovine spine. Non-fusion anterior scoliosis correction is a new revolutionary motion preserving treatment for adolescent idiopathic scoliosis. Non-fusion anterior scoliosis surgery is classified as growth modulating option in which the spinal column continues to grow in a harmonious way. Vertebral body tether modulates the spine growth according to Uter-Workman principle, thus providing additional progressive spontaneous correction, utilizing the remaining growth potential. Fewer existing clinical studies evaluating the novel anterior vertebral body tethering in skeletally immature children have questioned the midterm efficacy with concerns of overcorrection and curve progression and return to the theater or conversion to standard fusion surgery. The great advantage of non-fusion anterior scoliosis surgery is that it is not irreversible as it does not induce spinal fusion. It can be revised with spinal fusion in case of an unfavorable outcome with no downside for the patient. Non-fusion anterior scoliosis correction surgery differs from the traditional vertebral body tethering in that it relies more on intra-op translational and derotational maneuvers instead of merely tensioning the band during correction. We hypothesize that non-fusion anterior scoliosis correction surgery offers significant fusionless correction and stabilization of curve progression in patients with adolescent idiopathic scoliosis with a low risk of perioperative and postoperative complications. The main aim of our study was to investigate the safety and efficacy of this novel non-fusion anterior scoliosis correction technique in the surgical treatment of patients with adolescent idiopathic scoliosis. This is a prospective cohort study. We enrolled 45 patients with a minimum follow-up of 1 year. Adolescent idiopathic scoliosis patients with a structural measure curve between 14 and 80 degree, having more than 50% of flexibility on dynamic X-rays. We collected data regarding skeletal maturity, curve type, Cobb angle, surgical details, including blood loss, duration of surgery, and SRS-22 questionnaire. We followed up patient with serial measurements of the Cobb's angle, sagittal alignment measurement, and SRS questionnaire. This is the implants used for the surgery. This is 3-prong staples. This is titanium edge-coated screw with blunt tip for bicortical purchase. This is non-threaded locking cap. This is the tether material, which is made up of the polyethylene terephthalate, and this is the MS compression with pistol group, which is used for intra-op tensioning of the tether cord. Coming to the results, the mean age of the patients was 14.9 years. Majority 19.5% of the patients were female with a mean follow-up of 24 months. The mean Sanders and Reiser scores were 7.15 and 4.2 respectively. We divided the patients according to the linkage classification. Majority 42.22% of patients were of type 5 Lenke and 35% of patients were type 1 Lenke, and 5 patients each divided into type 3 and type 6 Lenke. The operative data included duration of the surgery was mean duration is 162 minutes, estimated mean blood loss was 112 mL, and mean radiation exposure of 0.6 centigrade. Mean radiation exposure time was 8 seconds, and the mean number of instrumented vertebra was 7. Coming to the radiological measurements, the mean main thoracic Cobb's angle preoperatively was 52%, which corrected to 17.2 on the first erect field and 16.92 on the most recent field, achieving a correction of 68% with a p-value of less than 0.01, which is statistically significant. The mean thoracolumbar and lumbar Cobb's angle was 51.45, which corrected on first erect field to 13.48 degree, and on most recent field, it got corrected to 14.24, achieving a correction of 72%, which is also statistically significant. The mean pre-op SRS score was 78 and post-op SRS score was 92.5 with a p-value of less than 0.05. This is the case of 14-year-old girl with Reiser 5 and Sanders 7 presented with Lenke 5 CM. Preoperative radiograph shows a Cobb angle of 51.4 degree. Shows a B figure shows immediate post-op erect radiograph with a Cobb measuring of 28 degree, achieving 46% of correction. At 2-year follow-up, the angle corrected, Cobb angle corrected to 18.5, achieving a further 33% of correction. This is another case of 14-year-old girl with Reiser 5 and Sanders 7 presented with Lenke 5 CM. Preoperative radiograph shows a Cobb angle of 43.1. B figure shows immediate post-op erect radiograph with Cobb measuring 12 degrees. 1 year follow-up, it corrected to 11.3 degrees, and 2 years follow-up, it got corrected to 6.1 degree, achieving a total of 85% of correction. On discussion, the study evaluates radiological and clinical outcomes of non-fusion anterior scoliosis correction surgery in patients with adolescent idiopathic scoliosis. Our early results with the novel non-fusion anterior scoliosis correction technique demonstrate significantly higher curve correction, the immediate post-op and progressive curve correction at a 2 years follow-up. Non-fusion anterior scoliosis correction offers promising curve correction and stabilization of curve progression with low risk of complication, particularly with regard to the long-term impact on unfused segment with preservation of the spinal mobility and decreased risk of the adjacent level disc disease. There was no any complication, no patient demonstrated worsening of the deformity, cord breakage, implant failure, or necessity for revision surgery or conversion to fusion at the latest follow-up. The exact role of the non-fusion anterior scoliosis correction surgery in the management of adolescent idiopathic scoliosis remains limited, particularly with regard to the specific surgical indications, post-operative lung function, quality of life scores. Yet, the data presented here provide the additional support for the surgical procedure. This is a review of some published clinical studies on non-fusion anterior scoliosis surgery. Our study data matches with the existing literature. Last year, we have published a series of 10 patients with a mean follow-up of 24.1 months. We achieved a correction of 71% with no complications. The limitations of this study were small sample size, lack of control group, and not objectively measuring the spinal range of motion. Coming to the conclusion, we conclude that our preliminary experience with the novel non-fusion anterior scoliosis surgery as an alternative technique to fusion to stabilize progressive adolescent idiopathic scoliosis curve is promising, but it has to stand the test of the time. Long-term outcome of large series documenting the ideal candidate for surgery, ideal curve characteristics, ideal timing for the surgery, and required magnitude of intraoperative curve correction will be critical for this novel technique to reduce the reoperation rate and conversion to fusion surgery. Thank you.
Thank you, Dr. Umesh.
Any questions? Otherwise, I have a question to ask him. You've done all these X-rays in standing position?
Yes, sir.
And who monitors the positioning for the X-ray?
So we fellows go and monitor the position for the X-ray.
Yeah, because even 5 degrees of rotation during standing will completely change the Cobb angle.
Yes,
whether
sir.
you go on the left side rotation, right side rotation? We have seen this. The same patient's X-ray done in 2 minutes span in the different rotations of a whole trunk will give completely erroneous information.
Yes,
So,
sir.
sir,
Agree,
that was one of the questions which was asked. How do you ensure derotation in your maneuvers by an anterior approach and correct placement of screws in rotated vertebrae?
Yes, sir. Preoperatively, when we plan the surgery on the preoperative X-ray, normal X-ray, we draw the patient's spine on the normal paper, and according to national grading, we write the rotations of the vertebra to be instrumented on that level. And while inserting the screw, so usually ask what is the rotation of the concerned vertebra, and we rotate insert the screw according to that rotations. And while tightening, tensioning the band, we always give some kind of the derotation, translation and derotation. Yes.
And,
Dr. Kanade, what is the lifespan of these anterior rods?
Sir, this is a short term. There is no long term studies. Up till now, 5 years they have done studies, follow up studies by Peter Newton. They have suggested tether breakage, but it has a 3000 square Newton meter of tension ability, sir. We till now 2 years up to we have started the first case in 2017. We have not appreciated in tether breakage.
No, because the tether breakage may not be appreciated.
Yes, sir. There is one paper, sir, that shows if on serial X-rays there is if more than 5 degrees of angulation on the consecutive screw, we can suspect a tether breakage in that segment.
Again, same thing. The rotation will make a huge difference in your assessment.
Okay, Dr. Kanade, there's one more question. What are you doing differently to have such low rates of complications?
Yes, sir. So we are doing the intraoperative translation and derotation. In other studies, they are merely tensioning on the convex side without addressing the rotation and all that, so that the tether is getting twisted intraoperatively only. So when you ensure the derotation and the translation and tightening, tensioning and locking the screw at the same time, we ensure that the tether cord is straight. So, and intraoperatively, we should take care to not to damage the cord.
How do you ensure rotation on the table?
Yes, sir.
What is it that you do?
Yeah, sir. I told in previously we draw the spine.
Certain yes, we noted.
Yes, sir.
All right. Okay, we proceed to the next paper now. Sandeep, call the third person.
So the next paper is by Dr. Bharat Patel on a new clinico-radiological grading system of adjacent segment degeneration after posterior lumbar fusion.
Thank you to BSS team to give me opportunity to present this paper in BSSCON, and thank you to my co-guide. Adjacent segment degeneration always start with the lumbar fusion. It follows cricoid and villi degenerative cascades. Radiological incidences always precede with the clinical presentation. So can we classify the adjacent segment degeneration based on the radiological severity changes of degeneration? So purpose of this study to establish a new severity score based on the radiological changes, evaluates its clinical reliability and proposed line of treatment depending upon a severity score and clinical disability. It's a retrospective observation study. The patient operated between 2007 to 2014 are included in this study. All lumbar fusion, open MIS with minimum 5-year follow-up are included in this study. So this is our follow-up protocol in our center. All patients underwent post-op MRI at more than 5-year follow-up. 2 independent radiologists were included in this study, and they studied a severity of disc degeneration, facet arthropathy, and lumbar canal stenosis on final follow-up MRI and X-ray of the patients. So disc degeneration are graded from 1 to 4. That includes normal disc with maintained height, black disc with disc height reduction less than 15%, black disc with disc height reduction more than 50%, instability, or the disc failure that extrusion or the pseudo disc. So this is how the scoring was done from 0 to 3. The facet arthropathy was graded from normal facet, early arthritis, advanced arthritis with lateral recess stenosis, and the facet effusion. And this is how the scoring was done from 0 to 3. The lumbar canal stenosis was graded using a Lee et al. Classification, and that graded from no stenosis to severe stenosis group. The disability was graded using a modified ODI score. The patient was grouped into two groups. The first group, in group A, the patient who has maintained daily living activity till final follow-up and there is no fresh complaint are included into the group A, while the patient they present with the new fresh complaint of repetitive exercism with and without radiculopathy and disturbed daily living activity are keeping group B. So these are the statistical analysis used in the study. So this table show that there is excellent clinical reliability between the two radiologists to score this radiological signs. 686 patients are included in this study. Average age was 59.6. Average follow-up was 7.2 years. So out of 686, 614 patient having a minimal disability and their charted radiological score range between 1 to 3. In group B, 72 patients are included. Out of that 72, 44 patients have a moderate disability, and then majority of the patient, the charted radiological score are range between 3 to 6. And the 28 patient having a severe disability and their radiological score range between 6 to 9. This diagram shows that as the radiological score will advance, the disability of the patient will progress. So they come to the conclusion that these are the radiological scores. Less than 3 it is called as no significant ASD. 3 to 6 called as moderate ASD. More than 6 called as significant ASD. So this is the case example. Total score 4 with my moderate disability. The patient was treated conservatively at that time. Another example, the total score was 8 with significant disability and advised surgery at that time. Another example, total score 7, significant disability, advised surgery at that time. This example showed the total score 5, mild to moderate disability and treated conservatively at that time. So the patient having a score less than 3 with no disability, no specific treatment will be required. But if the patient having a significant disability, then rule out for the other cause for the disability, and this patient may require a lifestyle modification. If the severity score is between 3 to 6 and mild to moderate disability, conservative treatment will helpful, and this patient may also require a lifestyle modification. But if the patient having a significant disability, this patient will require a strict observation. You may still try conservative trial, transforaminal and epidural injection will help, but this patient may require a surgery in the future. So counseling is very important. And the score, if the score is more than 6, and all these patients, majority of these patients having a moderate to severe disability, and the patient will require a surgery. So limitation, it is a single center study. Observation bias is always there. Retrospective studies. Conclusion, we propose a new scoring system based on the severity of radiological score. It is easy to classify, excellent clinical reliability. It will guide line of treatment for adjacent segment degeneration. And we have started this scoring system to apply in our degenerative lumbar canal stenosis patient to patient to grade the lumbar canal stenosis in our routine OPD. Thank you.
Thank you, Dr. Patel. Just one question before anybody asks you. It is proven in the literature that the radiological instability might occur before the clinical instability. So, and frequently there's a mismatch between the radiological and clinical instability, especially in ASD. So how is your paper different, and does it throw any more light on this particular issue?
So, good morning, everyone. So majority time, the patient, the radiological signs are preside over the clinical presentation. But when the patient in this study, it's a retrospective analysis. So we have observed the patient more than they included the patient which are presented more than 5-year follow-up. So at that time, we say that majority of this severe score are majority of the patient, the disability are moderate to severe. So aim of the study that whether this patient are right now with surgical or whether it may proceed over the surgical, that scoring and scoring will give us a prognostic thing. Okay, this patient not today is much symptomatic, but yes, this patient may future, it may go into the significant disability and it will require a surgery.
Thank you.
Dr. Patel, did you study whether the disc gave more trouble to them or facets gave more trouble, and that could have prognostications? Could you hear me? Did you do any
classified the facet in the degenerative cascade? We observe.
So I think Dr. Bharat Patel, what he wanted to ask was that how do you know whether the disc is giving the issues or the facets is giving the issue, and is there any way in which you have studied these things as decision-making factors in your management?
So what we have observed that the disc degeneration will start early, and the facet will be followed by after that the degeneration.
Okay. Probably you didn't understand my question. All right, let's proceed to the next paper. Sandeep?
So the next paper is by Dr. Nitin Adsul. So can we have Dr. Adsul's paper, please?
Society for giving us opportunity to present our work on clinical and radiological outcomes following the better technique to enhance spinopelvic fixation. So if you fix L4 to S1, there is 168% added stress on the sacroiliac joint, and if you fix only the L5 S1 level, there is a 52% added stress on the sacroiliac joint. In the current literature, the incidence of sacroiliac joint pain following the long fusion is between 12% to almost 35%. This is the study done by our group.
Dr. Kshitij, we can't hear this one also.
I'm doing it again. Once more.
Yeah, thank you.
Thank you, Bombay Spine Society, for giving us opportunity to present our work on clinical and radiological outcomes following the better technique to enhance spinopelvic fixation. So if you fix L4 to S1, there is 168% added stress on the sacroiliac joint, and if you fix only the L5 S1 level, there is a 52% added stress on the sacroiliac joint. In the current literature, the incidence of sacroiliac joint pain following the long fusion is between 12% to almost 35%. This is the study done by our group, which has already been published with 317 patients, out of which 38 patients developed a new onset sacroiliac joint pain after the long fusions, and the incidence was almost 11.9%. The current complications of iliac screw while fusing the patients to the pelvis are up to 44% incidence of screw loosening, usually asymptomatic, infection up to 20%, prominent or painful screws, difficulty connecting to the adjacent construct, neural or vascular injury, acetabular penetration, and sacroiliac joint dysfunction. So there are few advantages of S2 AI screws, which has been introduced since last few years. I will mention the technique in short. The S2 AI technique uses a starting point in the sacral ala between the S1 and S2 and neuroforamina, directed towards the anterior inferior iliac spine, allowing inline anchors without additional connectors or dissection. It allows the iliac crest bone graft harvest, and it crosses the sacroiliac joint and reduces the SIJ movement. But this screw, if used alone, it has a lot of complications, almost 2 to 3%, including SIJ pain, loosening of the S2AI screw, set screw dislodgement, neck fracture, shaft fracture, and requires revision in up to 1.6% of the patients. So this technique of SIJ fusion, it includes the one cage and the S2AI screw on each side. So this study showing the S2AI screw when used with the A-leaf and the bedrock technique, there is decreased bending movement and decreased range of movement at the sacroiliac joint compared to all the available techniques. I'll show you this with one example. This is a 68-year lady with adult degenerative scoliosis with PILL mismatch of about 15.4 degree with severe bilateral leg pain and back pain and bilateral sacroiliac joint pain. Her scoliosis was around 52.9 degrees and there were multiple levels of foraminal stenosis as we see. So we planned all these patients using the surgery map. We did all the cases in 2 stages. In stage 1, we did the anterior procedures, O-leaf and A-leaves by 2 different approaches. And in stage 2, before doing the stage 2, we do a whole spine X-ray to assess the balance and also the UOS scan. This is the post-operative X-ray showing the good correction with well-balanced spine on the UOS scan. And intraoperatively, we use 2 guide wires. So this is the tiered off view showing the inferior guide wire is for the S2AI screw and the superior guide wire is for the cage. And we used navigation for all our patients. This is the technique. This is for the S2AI screw and the pink one is for the cage position. Intraoperative view in Siam. Then this is the view showing the navigation guided screw and the cage position. We check on the Siam the position of the screw and the cage. The similar steps carried out for the contralateral side of the sacroiliac joint, and this is the intraoperative C1 picture showing the position of the cage and the S2AI screw. So in this study, we used total 15 patients. Preoperatively, EQ5D, EQ5D VAS, ODI, VAS questionnaire scores were obtained in all the patients. The enhanced spinopelvic fixation using the bedrock technique were performed in a single tertiary care specialist center at Royal National Orthopedic Hospital by 2 senior spine surgeons. All the implants were inserted using the computer navigation. We prospectively reviewed patients' reported outcome measures at 6 months and 1 year follow-up. CT scans were performed in all the patients at 12 months to assess the fusion rate, and all the patients had a minimum 12-month follow-up and were assessed for SIJ pain. So out of all the patients, 10 patients had degen scoli with positive sagittal balance, spondylolisthesis and positive sagittal balance in 2 patients, and 3 patients were like revision spines, revision surgery for previous flat back fusions and metal failures. So we included total 15 patients. At 1 year follow-up, there is significant improvement in the clinical parameters of the patients. And for fusion, 15 out of 15 patients had a CT scan at exactly 1 year post-operatively. The CT scan of all these patients revealed good evidence of fusion at 1 year with bone growing through the sacroiliac joint cages. There was no case of distal implant failure or evidence of the screw loosening. So to conclude, the clinical and the radiological results from our study reveal that the use of triangular sacroiliac joint cages in addition to the S2AI screw, which is we call as a bedrock technique in long construct adult deformity surgery, results in the good outcomes with no mechanical failure of spinopelvic fixation. Thank you.
Thank you, Dr. Arsul. So before we have a question, I just wanted to ask, did you take into account any lumbosacral biomechanical parameters before you decided to do this particular technique, or you just did it on all the cases?
Thank you, sir, for the excellent question. So, what we do is we first do the SI joint injections, then we do the RF ablation for the patients. That takes around 6 to 8 months, and after that we decide if still the pain
No, my
persists.
question
Then we will
was,
do the
did you take into account the lumbosacral joint biomechanical parameters before you decided to put in another screw into the S2?
Yes, yes. Preoperatively, we check all the parameters.
So what were the
We
objective criteria for you to decide on this particular technique?
No. For SI joint fixation at present, it's only the clinical criteria, no radiological criteria.
There's a question over here. Yeah, there's a question over here. Why not put 2 iliac screws on each side and use a 4-rod technique? Is it different? Or
Yeah, that was a good question. But iliac screw doesn't fuse the SI joint. So even previously we tried to S2A screws, but the screws basically don't help much in the fusion. That's why we started putting the cages.
Dr. Arsul, as I gather, you did not do what we call a formal sacroiliac joint fusion and bone grafting. You did only fixation. Correct?
Yeah, yes.
And your only the bone which was within the cage was the osteosynthetic area.
Yes.
Okay. Long term, what do you expect them to show you in long term? SI joints? Or it's only the strength of the implant you're depending on?
Yes, sir, because since it is a minimally invasive thing, we are not exposing the SI joint, like we are not planning to fuse the entire thing. So we just putting the cages, so 1 cage and the 1 screw. And
so it's a
there
hole,
is not much space actually left.
So it's a hole across the SI joint, going beyond the SI joint. Yeah, okay. All right. Thank you very much.
I think we need to move on because we are short of time.
Get on.
So let's have the next paper by Dr. Akash Shakya on preoperative T1 MRI images carry a poor post-op prognosis in cervical myelopathy.
Good morning. My name is Akash Shakya, and at the outset, I would like to thank BSS for giving us an opportunity to present our research in the gold paper session. Through this paper, we tried to determine if a preoperative T1 MRI change indeed carries a poor post-operative prognosis in patients operated for cervical myelopathy. Cervical myelopathy secondary to old age and degeneration is a very common cause of disability and morbidity, and it is one of the most common presentations in spine clinics. As it is such a major health concern, a number of studies have been done to determine the various prognostic indicators, and a number of studies are also going on at the current time. With the advent of MRI and it having gained popularity and affordability, radiological evaluation for the same has also taken off. However, the most common sequence that has been studied is the T2 sequence, with the T1 imaging being given comparatively lesser attention as compared to the T2 sequence. Combining the two, a number of classification systems have been described, which use either one or a combination of both. Some also use the grading of. In this study, we tried to assess whether T1 changes do indeed matter, and if they're present, whether they translate into a poorer outcome. A retrospective analysis of prospectively collected data was done at Dr. B.M. Central Railways Hospital, Mumbai, which is a tertiary care spine center in Mumbai. All the patients were operated for cervical myelopathy over a duration of 40 months, that is between May 2017 to August 2020, were included in the study, who had a minimum follow-up of at least 1 year. We used 2 outcome measures. The first one was the modified Japanese Orthopedic Association score and the visual analogs. We assessed these preoperatively and at postoperative 3 months, 6 months, and 1 year. All the patients who underwent surgery underwent a 3 Tesla MRI with 3 mm slices, which were assessed and reported by a radiologist who was blinded to the clinical data. Coming to the inclusion and exclusion criteria, we included all the patients who were operated for cervical myelopathy having an age more than 45 years, a minimum follow-up of at least 1 year, and having a complete data set available for analysis. We excluded patients who had no MRI changes on the cervical spine, who had a pre-existing spondyloarthropathy or a history of trauma, tumor, or infection in the cervical spine. We also excluded patients who had a history of previous cervical spine surgery. This flowchart demonstrates our study protocol. We scan and screen for all the patients who are operated with cervical myelopathy during the time period of 14 months of the study. By applying the inclusion and exclusion criteria, we could find 182 patients which satisfied these criteria. These are further subdivided into two groups. The first one was composed of patients who had only T2 changes in their MRI. These numbered 110. And the second group consisted of patients who had both T1 and T2 changes in their cervical spine MRI. These numbered 72. Coming to the results, this table represents the demographic variables, and as can be seen by the p-values, they were comparable across the two groups. Similarly, the perioperative variables were also comparable across the two groups. The groups are also similar with respect to the approach and the number of levels operated upon. Coming to the MJOS scores, these show a very significant finding. Although the preoperative scores were comparable among the two groups, the post-operative 3-month, 6-month, and 1-year comparison show a significantly poor MJOS score in patients who had both T1 and T2 changes as compared to those who had only T2 changes. However, the post-operative 1-year score was significantly better as compared to the preoperative scores in both the groups. However, the VAS scores are comparable at each point of assessment across the two groups. And the VAS scores at the end of 1 year were significantly better as compared to the preoperative VAS scores in the two groups. Coming to discussion, a number of studies have been published with respect to the T2 and T1 changes. However, a number of studies, for example, Vada et al., Vedantam et al., Chekli et al., and Zhang et al. Have observed that T2 changes indeed carry a very poor prognosis for and very poor post-operative prognosis in cases of cervical spondylotic myelopathy. However, not everyone agreed on the same. A study by the team of Michael Fellings et al. And the team from Ganga Hospital said that although T2 alone was not a poor prognostic indicator, a combination of T1 and T2 changes indeed carried a poor prognosis. Now, what could be the reasons for a poor prognosis in patients having T1, and what are the possible implications of the same? To begin with, T1 changes most probably represent irreversible changes that occur in the cord, most probably gliosis, which are irreversible, and thus this provides a better indication to the prognosis after surgery, as cell gliosis cannot be reversed. However, T2 changes are supposed to be caused because of multiple factors like cord edema, obstruction of spinal fluid, degeneration of the gray matter, and myelomalacia. Now, some of these are reversible changes, and thus, in the presence of only T2 changes, these can be reversed. However, it is not always the case. Another way of looking at it could be that these represent a continuum of changes, with T2 changes preceding the T1 changes. As the cord becomes irreversibly damaged, the T1 changes appear, and hence the presence of T2 changes alone might represent an ideal window of intervention to prevent further and permanent deterioration in such patients. We have a few limitations. We are limited by a retrospective nature of our study with a limited power. It is also a single-center study, and we have not used other functional criteria. We have not assessed the post-operative changes in the MRI in the patients, and the grading and classification systems previously described has not been used in our study. To conclude, the presence of T1 changes in the post-operative MRI do indeed represent a poor prognostic indication for the post-operative functional outcome in compared to patients who had only T2 changes. A combination of T1 and T2 changes, however, is a much better prognostic indicator than either T1 or T2. In the presence of other adverse indicators, for example, an advanced age, presence of diabetes mellitus, and others, an expected guarded outcome after surgery should be explained to the patient and discussed with him. However, a presence of T1 changes should not be deterrent to proceed to surgery, as the postoperative outcomes after the surgery are much better as compared to the preoperative status of the patient. Thank
you, Dr. Akash. So any questions, Vidya sir?
Yeah. Did you essentially look at sagittal sections or coronal sections also?
Good morning.
Coronal sections. Hello. Did you essentially looked at sagittal sections of MRI?
Yes, sir.
For both T1, T2?
Yes, sir. The sagittal sections were compared. Although we looked at the coronal and the axial sections as well too, but we did not include them in our analysis.
Because so often you find that the T2 changes are seen over larger areas, but T1 changes are eccentric on one side. And if your section has gone to the opposite half of the body, you probably not see anything there. So because T1 changes are always lesser extension-wise or extent-wise than T2. So unless you take into account both of them and really make something out of that, then you will be able to say, but making only a statement that T1 changes would influence your outcome is not exactly true.
Dr. Akash, just one question. Considering both the groups simultaneously, did you take into account other factors like diabetes, age of the patient, duration of symptoms, all these things?
Yes, we had.
Were all these factors neutralized in both these groups, T1 and T2 weighted images?
Yes, we did there was a table in the presentation as well in which demographic indicators are found to be comparable. Especially the incidence of diabetes and smoking was comparable in both the groups. There was no significant difference.
Okay, fine.
I may ask a question. How does this...
Samir, we can't hear you. Samir, you're muted.
We can't hear you.
Okay,
Yeah, Samir, go on. Now we can.
Doctor, how does this, the findings of this study, assuming they're correct, how does it affect your clinical regimen? Has it affected your clinical practices in any way, your indication?
It's a retrospective study. We've just done it, but probably it will...
Agree, but in future, are you going to use these findings in any way to change your clinical management?
It might happen actually, because as I said in the paper, that the T2 changes come before the T1, and so it represents a window to intervene. Probably.
Okay. Sir, I think we need to move on to the next paper because we are really running short of time.
Okay.
The last paper is by Dr. Thonangi Yashwant. Can we have his paper up here, please?
Dear chairpersons and colleagues, I thank my team for the contribution to this study. Osteoporosis is a huge burden. Up to half of the population aged 50 years or more are affected by vertebral compression fractures, and more than 1/3 of the postmenopausal vertebral compression fractures in women who are non-osteoporotic on DEXA. Underdiagnosis is the main reason for the highly prevalent untreated osteoporosis, which results in fractures. Normally, 80% of the load goes to the trabecular bone, but this ratio widens to 90-10 or even 95-5 with age as the sagittal vertical axis moves anteriorly, causing imbalance. Besides, stress shielding causes aggravated anterior vertebral body bone loss. Be it the fragility fractures or implant failure, it is this trabecular bone that is involved the most. The consequences of osteoporosis are devastating. Maybe the chronic low back pain, be it the vertebral compression fractures, implant-related complications with the incidence as high as 60%, which include the pedicle screw loosening, case subsidence, pseudoarthrosis, junctional failure, the proximal junctional kyphosis with an incidence as high as 30%, and sagittal imbalance. Health and economic burden is highly significant after a fragility fracture. The risk of mortality increases by 15 times, and morbidity affects activity of daily life activities and quality of life, as they are trapped into a vicious cycle of fatigue, reduced nutrition intake, and immobility due to the pain, compression sequelae, or deformity and sagittal balance. This implies apparent burden of osteoporosis is much less than the true burden, hence it is imperative to have a precise estimate of burden of spinal osteoporosis for an individual and community at large. Standard protocols which recommend DEXA and its limitations are often discussed but disregarded, be it the overestimated vertebral bone mineral density or discordant related conclusions. World Health Organization clearly suggested The reason for the considering DEXA as gold standard as it was the dominant technology back then. And they recommended hip DEXA. Also, they suggested to consider low bone mineral density at any other site in the presence of a fracture. Now it changed its position and suggested for a new gold standard according to the site, technology available, as well as that which helps in fracture risk assessment. In spite of these concerns, nothing has been done globally for a better evaluation of spinal bone mineral density. With this background, we did this study considering QCT as the gold standard for spinal osteoporosis. Ours is a prospective comparative study comprising 780 postmenopausal women randomly assigned to QCT and DEXA. 447 underwent QCT and 271 underwent DEXA. The following are the exclusion criteria. There is no significant difference between the age distribution of the two groups. The age distribution curves are similar. The mean ages and the ranges of the ages are also similar. There is a statistically significant difference between QCT and DEXA with respect to the means and modes of the T-scores. The means and modes of QCT are much less than -2.5. There was a highly significant difference between the T-scores of QCT and DEXA, and the bell curves plotted to illustrate the distribution of T-scores depict the peak of the QCT curve is in osteoporotic zone, while the peak of the DEXA curve is in osteopenic zone. While the proportion of the non-osteoporotic or normal women are much higher in DEXA than in QCT group. So among those who were screened, almost 60% in QCT group are osteoporotic, and almost 70% of the DEXA group are not osteoporotic. Spinal osteoporosis plays a predominant role in spine surgeon practice, and precise evaluation of this trabecular bone is crucial to address this burden, because trabecular bone is the zone of compression, fractures, pedicle screw loosening, progressive kyphosis and sagittal imbalance, and the changes of which lead to back pain occur. Vertebral trabecular bone takes the main spotlight in the context of spinal osteoporosis, and optimum trabecular bone density is critical for the success of spinal fusion. But DEXA gives us the integral bone mineral density of both cortical and trabecular bone. The aerial estimate is given by DEXA, but the density is volumetric measure. The sclerotic bone of the posterolateral elements, abdominal aortic calcification in AP, and rib and iliacrus overlap in lateral, fat overlap falsely elevate the vertebral bone mineral density. Also, the DEXA is being affected by the patient positioning. Recent evidence from literature suggests implant failures and vertebral fracture rates are significantly higher after fusion surgeries in osteoporosis. And micro-CT ex vivo study suggests lumbar DEXA doesn't represent microarchitecture of the trabecular bone of the lumbar spine. On the contrary, QCT enables us to focus on the region of interest on the desired trabecular component of a specific vertebra. It is more precise than DEXA. It gives a volumetric measure of the trabecular bone and it has no discordance related confusion. It is not affected by bony or fat overlap. There are speculations about the radiation exposure and cost, which are comparable to DEXA. We are delighted to inform you that our article has been accepted for publication in Spine Journal. We conclude insisting for a special attention to spinal osteoporosis as it plays a key role and is a key denominator in management of most spinal conditions. And QCT should replace DEXA as the gold standard for evaluation of spinal osteoporosis. Thank you.
Thank you, Dr. Yashwant. So there's a question. If DEXA is not reliable, why was it used as a benchmark to assess this particular CT?
So there was an interruption in the voice. I cannot hear the question.
So if you feel that the DEXA is not so reliable, why was it used to assess as a benchmark for this particular investigation? The CT, the QCT.
So first of all, hello.
Go on, Dr. Yashwant, we can hear you. Yeah, we can.
Yes. Our study clearly states that the drawbacks of DEXA, which are well discussed everywhere. Wherever we go, they say DEXA scan is gold standard, but it has its limitations like that. And coming to the spine, there is a lot of bony overlap in AP-DEXA because the posterolateral elements, which are often sclerotic with age, and even the abdominal aorta calcification, which can often falsely elevate the vertebral bone mineral density. Besides, the DEXA also has the drawback of variation with positions because of it causes bony overlap and all. So we believe that DEXA should be replaced by QCT, citing these drawbacks.
Okay, Dr. Yashwant, overall, you think that your QCT will show osteoporosis earlier than DEXA will show, or it will show larger than DEXA will show? And do you think that has changed your management pattern? You're operating more cases because of QCT, or you're treating them with a teriparatide or something more frequently than with DEXA alone before?
Not just that, sir. One thing is we can.
In fact, I'm asking you, has your treatment of osteoporosis become more aggressive surgically as well as non-surgically than with the use of DEXA earlier?
Than the use of DEXA, one thing is we can truly uncover more patients with spinal osteoporosis, and it's like we can give a perioperative medical management in more people. So we better to it is like enriching bone before going for instrumentation. Wherever we come across studies for osteoporosis, we talk about long fixations and very aggressive instrumentation with bone graft and all. I feel it's like flogging a tired horse because as long as we don't improve the basic bone quality, the complications are coming.
We know that indication. Question is, have you become more aggressive in the treatment of osteoporosis because of this?
Yes, sir.
Do you think you are
because
giving teriparatide to more people than before? Do you think you are doing surgeries more than before for osteoporosis?
We are definitely giving.
Yeah, Dr. Yashwant, I think we got the point. We need to close out this session. VTI sir, with your permission, because we are quite overboard.
Thank you.
So thank you all the presenters, excellent papers. And now we hand it over to Dr. Satyan and Dr. Kshitij to conclude this session.
Thank you, Sandeep. Thank you, VTI sir, for handling this session. We've had some excellent papers and a lot of discussion on all these papers. We could have gone on for another hour if we were to discuss them in detail. Such was the quality of the papers. So I want to congratulate all the presenters as well in the gold medal section. And please be tuned, because we will be announcing the winner in maybe an hour or so. Now, for the next session, which is again invited BSS orators, it is a very impressive, exciting session on cervical spinal cord injuries. I hand over to our president, Dr. Srivastav. Sir, please introduce our speakers.
Thanks a lot, Dr. Satyan, and a very good afternoon to all of you. Now we are going to have a much awaited BSS oration session. And this year we have chosen the topic of cervical spine column injury and cervical cord injury. And the two orators which we have chosen, they are master in this field. I would like to introduce our first orator, Dr. Shankar Acharya. Dr. Shankar Acharya is chairman of the Department of Ortho Spine, Sir Gangaram and Associated Hospital, Spine Center Director, AO Spine Fellowship, Chief Administrator, Physical Medicine and Rehabilitation. He is the President of Association of Spine Surgeons of India. He is the President of Delhi Spine Society, ex-chairperson of AO Spine India, and ex-trustee of AO Foundation. We are glad to welcome you, Dr. Shankar Acharya. You kindly share your screen, please. Thank you. Thank you very much.
Thank you, Dr. Srivastav. I think you have to unshare before I can share. Thank you. And thank you for your kind words, and thank you for inviting me for this talk. And thanks Kshitiz and all the members of the Bombay Orthopedic Association, Spine Association. And it is a great pleasure to see Dr. V.T. Ingelarikar and the previous session. Dr. Srivastava has asked me to talk on management of cervical trauma, neglected cervical trauma. And it is interesting to know that when we normally see a couple of cases a year, but when I went through the literature, I found that maximum work has been done by Dr. Chavra, Dr. Srivastava, Dr. Basu, and Dr. Jain and Rajshekharan have written a chapter on it. So we shall discuss what is the definition of a neglected traumatic cervical spinal cord injury. Why does it get missed? What are the issues, challenges for treatment and complications, outcome, and some learning points, and some cases which I have picked up from my series, and I shall show them to you. Actually, there is no classic definition of a neglected cervical spine trauma, and usually it is more than 3 to 4 weeks old. And Chabra and Dr. Rajshekharan in their chapters have written that they are different in two different worlds. So we have a developed world where an injury, if it is missed in the emergency room or in the accident emergency, that it means a neglected fracture, irrespective of the time duration. However, in the developing world as ours, there are various causes which causes delay or neglect of a cervical spine trauma. Injuries may be missed. There may be delayed presentation by the patient himself because of lack of awareness or minimum symptoms or distant to available healthcare, or there may be less awareness by the surgeon or the treatment or the treating doctor, and poor assessment and treatment on initial presentation. So we have different backgrounds, we have lack of infrastructure, we have lack of skilled surgeon. And of course, in the last 10, 15 years, we've had a huge number of spine surgeons all over the country. There is still awareness among orthopedic surgeons, poor socioeconomic status, and poor health infrastructure, and lack of transportation facilities. All these are responsible for some neglected spinal cord injury, and so especially cervical spine. And if there is a delay, the treatment is challenging for sure. In this, Dr. Chabra has brought a very good book on spinal cord injury, and in that chapter, he says that in their epidemiological study, about 25% presented after a month of injury, and only 8% present within 24 hours of injury. So there is a variable time duration of presentation of cervical spine trauma. And if you see this paper which has looked into spinal cord injury, you will find, if you read from bottom up, 6 patients died because of direct result of delay in diagnosis. 9 patients had complete paralysis. 26 patients had neurological deterioration. 34 patients had inappropriate intervention risking neural injury. And the most common level was subaxial spine. So there is
the screen sharing has not yet started, sir. Can you share that screen for the presentation?
My screen sharing has not started?
No, sir.
I'm so sorry. But how do, I did share the screen. Let me see again. Has it started?
Yes,
it has. Yes.
I'm so sorry. Anyway, I'll move on. I think we shall discuss about the definition, why it gets missed, issues on presentation, the challenges for treatment, the complications, outcome, and the learning points. And if you look at the definition of spinal injury, then late presentation, usually more than 3 to 4 weeks, is supposed to be neglected spinal cord injury. However, it is different in different parts of the world. And in the developed world, if it is missed in the emergency room or in the initial presentation in the hospital, then it is neglected. However, in India and our developing countries, there are various causes I just discussed. It could be missed, it could be delayed presentation, or poor treatment on initial presentation. So, and as I said, Dr. Chabra has written a book on this, and from there I took out some of the literature and epidemiological patterns And the cause for delay in our developing countries is rural backgrounds, lack of infrastructure, lack of skilled surgeons, unawareness, poor socioeconomic status, lack of transportation. And as I was just saying that if you look at this study, 25% of patients would present after a month of injury, and only 18% would present within 24 hours of injury. And if you look at this long-term study where they looked at spinal cord injury, and if you read from bottom up, 6 patients died as a result of delay in diagnosis, 9 patients had complete paralysis, 26 patients had neurological deterioration, 34 patients had inappropriate intervention risking neural injury, and the most common level was subaxial spine. So there is an issue with delayed diagnosis and delayed presentation, and the treatment is difficult. So I asked when Dr. Srivastav asked me to talk on this, so I asked my boys and our secretary to pick out our data, and I looked at from 2010 to 20, and we didn't have a lot of cases. We had 186 cases of cervical spine trauma, and interestingly, 30 were neglected, and that surprised me that about 15% is neglected in our series also. And 12 were initially treated elsewhere conservatively. So the orthopedic surgeon who saw the patient didn't think seriously of this injury. 2 were referred from other centers later. 7 patients had neglected themselves and presented late because they think the neck pain would go away. 9 patients, the diagnosis was missed. So we had a full spectrum of this. And what are the problems of neglected spinal injuries? There is progressive neural deficit, there is progressive deformity, persistent pain, prolonged morbidity, early mortality, and then medical legal implications are now more and more. However, in some patients, you can have spontaneous fusion due to delay, and that also is an interesting thing in our country because sometimes purged facet, fractured facets can fuse and may have minimal problems, and there could be a kyphosis, and you need to discuss with these patients. So that is also there another aspect which we need to think about before we offer them surgery. So what are the main causes? Missed diagnosis, especially in patients with polytrauma, obtunded patients, head injury, facial injuries, and other injuries which are more life-threatening, then the neck can get missed. Late presentation by the patient himself because he treated himself or he went to an alternative treatment or unable to reach the hospital due to lack of funds or transport or distant area where he lives. And early discharge or inadequate treatment by the hospital where he presents, whether due to finance, beds, priority, by the doctor being unaware, or by the patient or relative these days having lack of confidence in the treatment proposed by the surgeon, because there is a little bit of mistrust these days. So why cervical spine injuries are easily missed? Because you have a various group of patients, and then the radiograph, which is most commonly taken, may not be appropriate. And we teach our students always to have an appropriate cervical spine X-ray. As you can see in this, the short neck, when the shoulder is pulled down, then you can see a purged facet. And this was missed in Delhi itself. And this was one of my ex-school classmates. So, I got this X-ray out, and so this is a problem. What are the other common fractures which are missed? One is odontoid fracture because they have minimal neurology and they can be missed. Teardrop fractures, as you know, can be in flexion, which is more serious, or can be in extension, which could be missed. And they have minimum symptoms, the teardrop fractures in extension, but could be unstable. And especially in Angst-Pons, you have to be very careful. Facet dislocations, unilateral or fractured facets can be missed. Hangman fracture is another thing which can be missed when there is minimum displacement, and they can be ignored because they have less symptoms. So it is imperative that when we are referred or asked to see or must teach our boys to do a proper clinical examination, to have the appropriate radiographs and do a proper interpretation of these radiographs as well. And if any doubt, then do furthermore investigations. These are the routine X-rays that we do: cervical spine AP, cross-trabal lateral, odontoid open mouth. And I think all the people watching this presentation would know that this is very important. The cervical lines, the anterior, the posterior, the articular pillars, the spinolaminar line, and also the interspinous line and the posterior spinous line. And the soft tissue thickness in front, because the soft tissue shadow also tells you If between C1 to C3, it is the large soft tissue shadow, there's there's swelling and edema or collection or hematoma, and you should be very careful about all this. Any loss of alignment, you should be aware and do investigate further. And flexion extension views are still controversial. However, sometimes, as you can see in the neutral film on the other side, you may not see the facet dislocation, and they can be evident, especially if they're less symptomatic. Sometimes additional radiographic films are available, and you can do them. However, CT scan in today's day and world is probably the best thing to do, because CT scan sensitivity is very high, and CT scan can almost detect 97 to 100% of injuries in the cervical spine and also in the head. So that is important to do. So your first choice would be CT scan, because of the ease of access, the speed, and quickly tells you the fracture pattern. Also, you can know about vertebral artery injuries, etc. So MRI is also done more routinely most of the time in our centers and in other centers, because it's also become now cheap and available. But CT scan is to be put on more first line of investigation after an X-ray. However, where you don't have any X-ray or CT finding and you want to exclude discoligamentous injuries, you should perform an MRI scan, and stir sequences are suitable to evaluate the posterior ligament. Especially, we want to see if the posterior ligament complex is damaged, or there is edema, or there is swelling, or there is subtle fractures. So cervical spine clearance is very, very important, and the Canadian Spine Society and the American Association of Spine Surgeons have laid out very clear criteria and guidelines, and this should be all stuck in the casualty of every major hospital which is dealing with trauma. So from a vague symptomatic patient who has no problem, it's okay, you can rule out. But if it is symptomatic and if it is obtended, then definitely get more investigations, and CT scan is a modality of choice. Now, let me take you through some cases so that not to miss or what happens if you miss and how to deal with it. And that was my scope of discussion today. So this is, I'll start from this C1, C2. So this is a 53-year-old male, fall from stairs 2 months ago, had some injury to neck. He did not bother because he had minimum injury. And then after 15 days, he developed weakness in his upper limb. And later, the patient developed gait imbalance, planters were extended, so there was no bowel or bladder involvement. And if you look at flexion extension, this was a non-union of the odontoid, which is reducible. And this is his MRI pictures. There was some facet subluxation as well. And so this is a post-op. We did a C1, C2. This is a routine surgery, which we now do because we prefer to do this surgery. It is easy and predictable, and you can put a bone graft. And this is a 1-year follow-up. This is another patient who was actually managed conservatively, a type 2 odontoid fracture, but persistent pain made the patient come to us after 8 months. So here you have a non-union of odontoid after 8 months. And in these patients, it can be tricky to treat them because they could be non-reducible, they could be soft tissue contraction could be there. And then you may have to do sometimes major surgeries. Here in this case, however, we did a C1, C2 wiring and did a fusion, and then this is a 3-year follow-up. However, sometimes you may have to do occipital-cervical fusion, or you may have to release anteriorly if the soft tissue is contracted. And I think Dr. Srivastava has nicely presented many times about this anterior release of odontoid fractures, delayed non-union or delayed union. Neglected odontoid fractures are the commonest, and they go frequently in non-union, and they're difficult reduction because of the contracted soft tissues. We tend to do mostly posteriorly, and if there is a problem, we do occipital-cervical fusion with the decompression of C1. The other fracture, which is also important to keep in mind, is the hangman's fracture. So this is the other case. And this can also get easily missed. As you know, there are 3 types of hangman fractures with the type 2 as well, in which there is an angulation with where we advise not to give any traction. So this is that case. And in this, this patient presented late as well, but had we did an anterior ACDF with bone graft. So in these patients, I tend to do bone graft without any cage or interspacer device. And this is a 10-month follow-up. This is another case. This is a very interesting case. This patient had a T12 fracture for which she was operated. The neck was absolutely treated lightly, and this was the X-rays. And the patient had an hangman fracture, and this was the X-rays, flexion extension after a month. We don't do flexion extension views routinely. We only do on late presentation and those who are symptomatic. And this came to us after a month. And if you can see the CT scan, somehow the CT scan had not been done initially. You can see there's a fracture to the pedicle. There also has fractures of the C7 and C6 spinous processes. Since the patient had only neck pain and already had a spine surgery, there was a lot of reluctance and there was no cord compression. And so I offered this patient a halo vest interestingly, this is a 1-year follow-up with which has healed. And then I recently asked them to send me some pictures of her movement. So this is an 8-year follow-up, which she has no symptoms and she was reluctant to get an X-ray. She lives in Sonipat. This is another case, young man, as you can see, this is an inadequate X-ray, sustained injury to the head, lacerated wound was sutured. He didn't think much about it. X-ray spine, cervical spine was cleared. And this is why it is so important to get an adequate X-ray. After 4 months, the patient persisted neck pain and right arm weakness developed. He had another X-ray where you see a C5-6 facets perching, and this is the flexion extension. Sometimes I see very delayed facetal dislocations with facet fracture, which have gradually become almost fibrous union to union. And then those patients, I tend to leave them alone and counsel the patient of injury, which can precipitate neurological deficit. And depending on their views or their thoughts, then we would offer them surgery. This patient also had a right vertebral artery thrombosis, and so he was very worried because he had taken already many opinions, and there was an opinion that if we try to reduce this now, there would be a dislodgement of the thrombus and he could get a stroke. He was a young fellow, and he belonged to my school, though he's very young. And then he came to me finally, and I said, okay, the best thing I could do is, because he had a facet, one fracture on one side and a subluxar perched on the other side, I said, I'll fuse it in situ and let it go and see what happens. At least it will be safer for you. So this is what I did. This is a 1-year follow-up. And yesterday he was in Calcutta. I asked him to send him a picture from there. And so this is a fusion. As you can see, the facets have also fused posteriorly and it is anteriorly fused, though there is some degree of local kyphosis. He is at the present asymptomatic and is fine. So neglected cervical facet dislocation in a developing country like ours can be a challenge. And unless you get them in the golden hours or early, and as we know from the study that Dr. Chavra did, that only 8 to 10% present within the first 24 to 72 hours, and 25% present late about in 3 to 4 weeks. Success of close reduction after that is possible. It happens and we do it, but not as good as the fresh sub dislocations. In fresh, you can actually give an online traction and then get along and reduce it and do an anterior ACDF by doing a discectomy. And most of the time, if the disc height is less, then you can do a posterior fusion. But when they come late, then you have two situations. You have a healed fusion, where you can actually discuss with the patient, and if you feel it is unstable, then you will have to do front, back, and front, and that is debatable which you start first, and there's a lot of personal preferences on this. And in unhealed, definitely you must go ahead and do surgery. There is a very little really prospective class 1 evidence which shows that what should be done and how you should go about it. So it all depends upon your local situation and what you're comfortable with. In my practice, I tend to always go from the front and release the disc and put a cage spacer. If I don't get a reduction, then I will try all my best methods to do an anterior reduction by distracting and reducing. If I can't, then I would go posteriorly and remove, burr out the facets and then come in the front and put an ACTF. I am aware that a lot of centers can go first posteriorly and then come anteriorly and do it. But this is personally up to the surgeon themselves. So whether you do posterior, anterior, or anterior, posterior is basically dependent on surgeon's preference and the disc which is in the canal or not in the canal, and the disc height. So that has been, there are multiple views on this, and there is no standard view on this. So let's look at this case. Presented late, RTA was 5 months ago, neck pain in both shoulders. Definitely this is unstable. And a lot of people would go from behind, burr out the facets, and then go anteriorly and put a spare, do a ACDF, put a spacer or put a bone graft and do an ACDF. Here also loss of vertebral artery flow. And this was his MRI scan, as you can see. But we did burr the facet from behind first, but I did not put any lateral mass. You can put lateral mass. A lot of people would do a 360-degree fusion, but I just did the burring, and as you can see, then came anteriorly and put a bone graft and fusion. So basically, if it is reduced and there's disc herniation, we would do ACDF. There's no disc herniation, then you can do a posterior fusion bilateral mass. If it is not reduced, then you will have to do posterior facetectomy and then ACDF. And if there's no disc herniation, you can do posterior facetectomy and fusion alone. So there are multiple reduction maneuvers you can do from the anterior approach. They have all been described in Benzel's book. You can see all the descriptive characters. You can give online traction, then use interspinous distractor, or you can put pins in the vertebral body, distraction pins, and the way the pins have been put in oblique fashion and then distract, that has also been described. Then once you have distracted, you can then push the under control, you can push the facets down and reduce, and then you can put the cage or the bone graft and the plate. And if in the cervicothoracic junction you are not able to see the C-arm well, you can use a hook retractor and see as well. That is also there. So all the reduction maneuvers are described in this chapter by Benzel, and those interested or going to do, they should read this chapter with a lot of diagrams in them. Complications, of course, are there in these: hemorrhage, wound hematoma, damage to carotid vertebral arteries. You have to be very careful if you have a thrombosis, injury to recurrent laryngeal nerve, especially when there is a lot of traction and you're manipulating esophagus, trachea. You have to be very careful about this. And you can cause more neurological deficit if you are not careful about how much traction you are giving. And there is also a high rate of dysphagia associated. So you have to be very, very careful, these patients. So in summary, they are rare, but not so rare. So you have to be very careful when you see these patients in the casualty or emergency, and you have to teach your boys well. And unless the comprehensive management is initiated in timely fashion, there could be problems. Lack of awareness or lack of facilities in all the centers may be another factor. CT scan plays a vital role in the diagnosis. If at all you have any doubt, get a CT scan. Surgery remains the mainstay unless it is fused and the patient is counseled. And then there are difficult psychological and social rehabilitation problems, increased morbidity and mortality, and higher incidence of complications. And they may require longer hospitalization, additional cost, and adversely affect functional outcomes. So this is something, rather than treating it late, should not be missed. I thank you for your attention and happy to answer any questions.
Thanks a lot, Dr. Shankar. Now, since we have both the talks related to cervical spine, in want of time, we'll take questions at the end of Dr. Chabra's session also. Thank you very much, Dr. Shankaracharya. Now, it is my proud privilege to invite the second orator, Dr. H.S. Chabra, who is going to talk on spinal cord injury, what is on the horizon. Now, Professor Chabra is the Chief of Spine Surgery and Medical Director of Indian Spinal Injury Center. He is the President of Spinal Cord Society, Vice President of Association of National Board Accredited Institutions, immediate past President of International Spinal Cord Society, immediate past President of Association of Spine Surgeons of India, Executive Member Asian Spinal Cord Network, chair of the Spine Trauma Study Group of International Spinal Cord Society. He is editor-in-chief of ESCOS textbook. He has more than 145 publications and he has written more than 24 chapters. There are multiple awards in his name, and I am glad to invite him to deliver this talk. Can I have his talk? Tag team, please.
Hello. I've been asked to speak on cervical spinal cord injuries, what's on the horizon. I want to start by thanking the organizers for giving me the opportunity to give this talk. What makes spinal cord injuries as devastating as they are is that everything about them plays out in absolutes. They are instantaneous, utterly disabling, and horribly permanent. However, there have been various advances and there are numerous things on the horizon on each aspect of spinal cord injury management, and let's discuss them over the next few minutes. In the field of pre-hospital and acute care, there have been a lot of advances, and there's a lot in the horizon with regard to extrication, first aid at the site of the accident, immobilization, and evacuation and transportation to a medical facility. And we know that the pre-hospital care gives us an opportunity on improving outcomes, which no other aspect of spinal cord injury management does. There are emerging techniques for imaging, like diffusion tensor imaging for axon integrity, myelin water fraction for myelination, MR spectroscopy to evaluate gliosis or ischemia, and functional MRI for evaluating connectivity. Coming to surgical management, 3D printing is an option for fabricating surgical tools such as screw guides and creation of customized implants. It has a limitation of long production times and high costs. The current indications include complex surgeries like post-traumatic spinal deformities and revision surgeries. There's a limited application in routine spine trauma surgeries. This also helps in customizable implants, and it lacks long-term data on clinical outcomes and cost effectiveness. VR and AR in spine surgery also serves various promising functions in the realm of spine surgery, but these simulation systems remain in infancy, even though we have the possibilities of having long-distance connectivity using VR, AR in spine surgery. Artificial intelligence has tremendous potential in revolutionizing comprehensive spine care. Evidence-based predictive analytics can help surgeons improve preoperative patient selection, surgical indications, and individualized postoperative care. In a trial of augmented reality for pedicle screw fixation with navigation, Negan et al. Designed a virtual roadmap that was superimposed on the surgical site of patients. And by installing two overhead stereoscopic cameras, they coordinated intraoperative video with data sourced from the navigation's infrared tracking system. Pilot studies have been conducted as proof of concept in this regard. Then there is a freehand system which can be implanted as a FES device for restoration of hand function in C5 and C6 level tetraplegics. There's an active receiver or stimulator which is placed in the chest wall. 8 leads come from the receiver under the skin to a connector site in the upper arm. They are joined to epimysial electrode leads passed under the skin from the forehand and hand, and the power and control signals are passed through the skin to the receiver or stimulator or a skin-mounted coil. The subject controls the device by movement of the opposite shoulder using a skin surface mounted position detector. Then there are intraspinal pumps like morphine to treat pain or baclofen for spasticity, and which can be delivered to the epidural space in a controlled fashion via the pump in the reservoir. The trial injection of the drug via lumbar puncture is initially given, and then the reservoir is placed subcutaneously in the lower anterior abdomen, and a catheter placed in the spinal epidural space is then tunneled under the skin to connect to the reservoir, and the reservoir can be filled as necessary. When it comes to rehabilitation management, functional electrical stimulation has been used for rehabilitation of patients in a large way, and there are plenty of new techniques which are on the horizon. brain-machine interface involves performing mental tasks, which produces activity detectable with electrodes placed on or in the scalp. It promises to aid paralyzed patients by rerouting movement-related signals around damaged or compromised parts of the CNS to control and or communicate with assistive devices and the environment. For example, patients during attempted or imagined wrist movements use the signals to steer an electric wheelchair simulated in a virtual environment. Virtual reality, in addition to a surgical tool, also provides a form of human-computer interface that allows the user to interact with and become immersed in a computer-generated environment in a naturalistic fashion. There are various robotic-assisted neurorehabilitation devices which have emerged and are on the horizon. Active leg exoskeleton, lower extremity powered exoskeleton, robotic body weight suspended treadmill training, also ambulation exoskeletons, and these exoskeletons help people not only move on level ground, but they can, once trained, also go up or down the stairs per se. So this is also a promising therapy on the horizon. It's being used already. There can be standing and mouth-controlled wheelchairs in the field of assistive technology, automated stair climbers, adaptive drivers with hand control system, and a host of other wheelchair, hoist or platform lift, swivel driver seats, special pedals, steering wheel knobs, and hand speed controls. There are also a number of environmental control units which tetraplegics who do not have hand function can use for becoming independent. There are sip and puff mouses which can be used for patients with a high level of tetraplegia. Similarly, voice recognition software can be used by high tetraplegics to type on a computer. For skin care, there is pressure mapping which is available, which helps to have an ideal seating surface such that pressure on the bony prominences is the least. Then there is transanal irrigation, which is a peristine anal irrigation device, which is used for chronic constipation and fecal incontinence. It consists of a control unit with a pump, a water bag, and a rectal catheter. In the field of community inclusion, there have been a lot of recent advances, and a lot is on the horizon such that these people become more and more independent in their activities of daily living, and the community inclusion becomes easy. Telemedicine has come a long way, especially during the COVID pandemic, and the patient satisfaction has been very high with this, and it has been a preferable option for a subset of patients. Coming to regeneration after spinal cord injury, there are rapid and significant advances in the area of neurorestoration over the last decade, mainly focused on neuroprotection, neuroregeneration, and adaptive plasticity. We know that there is a primary and a secondary injury cascade, and depending on the various stages of spinal cord injury, there are various barriers for regeneration. These differ across the various phases. In the field of neuroprotection, there have been pharmacological therapies like riluzole, which is a repair of conduction deficits, magnesium, again, which inhibits the barrage of action potentials, minocycline, fibroblast growth factor, GSF factor, and hepatocyte growth factor. Riluzole is a sodium channel blocking agent used in treating amyotrophic lateral sclerosis, but has been used in phase 1, 2, and 3 trials, but the results are still to come out. Minocycline, a tetracycline antibody with significant anti-inflammatory effects, has been used in phase 2 and phase 3 trials, and the results are still not out, but it promises to be having significant effects. Then there can be non-pharmacological therapies in neuroprotection. Therapeutic hypothermia involves rapid cooling of core temperature to 32 to 34 degrees centigrade. A larger phase 2/3 trial has been planned in this regard. CSF drainage attempts to prevent cord hypoperfusion in the cortical post-injury period by relieving pressure. Here again, a phase 2b trial is being undertaken, and it proves to be a promising therapy per se. Then there can be pharmacological therapies in neuroregeneration like Rho-ROCK inhibitor, which leads to growth cone collapse of regenerating axons, neurite retraction, and increasing apoptosis. C3 transferase is shown to inhibit Rho-mediated action, and a phase 3 trial has been done in this regard. Then for anti-novo antibody, which is a protein present in CNS myelin that inhibits neurite growth, a phase 1 trial has been done applying humanized anti-novo antibody, and a phase 2 trial is currently in preparation. When it comes to neuroregeneration, we have spinal cord stimulation, which can be done at various possible sites. It could be deep brain stimulation of a brainstem restorative feedback loop, which augments restorative effects around the injury site, or mesencephalic locomotor region can be stimulated to boost the locomotor central pattern generator. There can be transcutaneous direct current stimulation or repetitive transcranial magnetic stimulation with direct motor cortex stimulation, which can be used for immediate production of movement or to induce adaptive plastic changes in the motor unit. Then brain-machine interface that we talked about, and peripheral nerve stimulation or spinal cord stimulation are other options. Spinal cord stimulation distal to the injury has been used for bladder control. Proximal spinal cord stimulation can be used to block pain per se. Spinal epidural electrical stimulation, there have been various animal studies which have backed it, and there have been clinical studies where limited number of cases have been reported, where independent stepping, intentional overground walking, and even unexpected voluntary motor control and independent standing without spinal electrical epidural stimulation, which was noted in these studies. These studies suggest that spared structural connections at the site of injury, which were functionally inactive, may be capable of modulating the excitability of the sensory motor networks below the level of the injury. A surgical stimulator is placed subcutaneously in the anterior abdominal wall, and wire leads tunneled subcutaneously and connected to the stimulator. Postoperatively, mapping is done to find the right amplitude and frequency in the right electrodes in the 16 electrode array, and there is aggressive rehabilitation in training sessions where the patient undergoes rehabilitation in order to hasten recovery. Spinal networks at the site of injury can be reactivated even many years after injury. And even in complete spinal cord injury, there may be structural connections which are spared at the site of injury and which get reactivated with spinal epidural electrical stimulation. Locomotor training improves the motor ability of chronic spinal cord injured individuals as compared to locomotor training alone. However, larger trials are required to draw a definitive conclusion. Spinal cord stimulators are also available to treat chronic pain and have been well documented in the literature. Diaphragmatic pacing and phrenic nerve stimulation are techniques which are available to wean the people off the ventilator. Similarly, sacral anterior root stimulator provides stimulation of S2, 3, 4 in order to provide bladder and bowel control and sexual functions. Cell therapies have also been tried, and there have been various clinical trials, including autologous bone marrow cell transplantation and autologous mucosal transplantation and various others. But a single approach, it has been postulated, may not be successful in achieving spinal cord injury repair. There is a need for multidisciplinary involvement involving a multifactorial approach, including cell populations, scaffolding material, matrix, growth factor supplementation, and scar removal in order to address this situation. To summarize, investigating new avenues for facilitating functional and neurological recovery after spinal cord injuries is currently the focus of several clinical trials. One can look forward to the results of several trials, some of which have gained worldwide attention. There are numerous possibilities. With evolving technologies, the advances in spine surgery will have new doors opening every day. Achievements which were only a scientific dream a decade ago are now becoming a reality. So as the technology evolves, the target of making a complete cervical spinal cord injured patient totally independent may be realized in the coming years. That's true about the horizon. Every step leads you towards it, but you can never quite reach it. But maybe that's a good thing. Maybe it's nature's way of reminding us to never give up, to always keep striving in order to make life after a spinal cord injury happy, meaningful, and worth living. Thank you for your patience.
Thank you very much, Dr. Chavra. Excellent talk. And now we will be having question. Let me start first question to Dr. Chavra. Yesterday, I was in BSSCON and one of the paper was presented, and that was regarding the spinal cord scaffold. What is your opinion regarding this?
When we talk about neuronal regeneration, we have to agree that the evidence suggests that it will be only a combination of therapies, which will be combination of strategies which will be successful, amongst which will be something to remove the scar, something to bridge the defect, and also something to help regeneration, and something to remove the barriers. So there are various scaffolds which are available, which would help as a bridge. But right now, I would only want to mention that evidence suggests that these are all experimental therapies, and we have not been able to find the right answer yet. I hope I was able to answer your questions satisfactorily.
Yeah, Dr. PTI, sir, do you have any question?
Oh, no question. I think these both people are far beyond my understanding.
I have a question for Dr. Chavra. Can I ask?
Yeah, please.
So when a patient asks you about stem cell therapy of spinal cord injury, what do you tell them? Like, what do you do?
I used to take the pains of describing them in detail subsequently, only coming to know a couple of months later that they succumbed to the hype in the media and the website and other options which sell hope to them, right? And which I think is criminal. So what I right now say, which is more effective, is rather than relying on my opinion, please go on the websites of international and national societies and look at their position statements on stem cell therapies. And then you will get the answer by yourself. That is more convincing to them than listening to my individual opinion. I may give them my opinion, but always refer them to the website of ICMR, to the website of ISCOS and other international societies. Also ASSI, we have it on the website. And this turns out to be more effective in convincing them.
I think the hype creators are very good in their work. They're far better than us convincing the patient.
So they have their incentives also for that.
Absolutely. We are aware of those things. What's happening, we're aware.
My another question is to Dr. Sankar Acharya.
Yeah.
You have presented this neglected trauma very nicely, Shankar. My only one question to you is that suppose you get a case of neglected trauma where the injury is at different level in the cervical spine. One may be supraaxial and another is subaxial. Any tips you would like to give us?
Yeah, I recently, as I said, I pulled out 30 cases. And I recently did a case. He came from Bokaro. He had a Jefferson's fracture with a tip of odontoid. He is an Angst-Pond patient with a C4-5 fracture dislocation with minimal neurological deficit. So what I did was I fixed the C4-5 fracture dislocation and put him in a halo and left him, and it is 3 months down the line. So because it is more difficult to treat a Jefferson fracture with C2 injury with some subluxation, and it is important to keep the subaxial spine in alignment. So I fixed that. So that I may use combinations, and I may use the most unstable one to fix. So that is where I go about it.
Thanks a lot.
Hello,
Any
sir.
other
Hello,
question?
sir. Dr. Vignesh here from Chennai. Just wanted to ask a question to Dr. Shankaracharya.
Yeah.
Please go ahead.
Sir, do you prefer halo or somi brace, sir?
I prefer halo to a lot of, because I use halo in tuberculosis. I use halo in C1, C2. And I have good experience with halo. We get some local manufacturers to manufacture it for about 15,000-20,000 rupees. He comes and puts it, and I put them up for 3 months. So that suits me well.
Dr. Vignesh, you should take patients' X-rays with halo, with your somi brace. So often you will find what apparently think is a correction does not happen. It goes back to the place. And you only become aware of that after 6 weeks, 8 weeks, that the whole thing was displaced from day one.
Yes, sir. Understood. Sir.
Can I ask Dr. Chawla? Sir is there?
Yeah, he's there. Please ask.
Yeah. Sir, always a pleasure to listen to you. Always a great learning points. But research when it comes to cervical cord injury or myelopathy, it is very, very challenging. Like, for example, we did a RCT on injection cerebrolizine, and we did sort of found that it does help. But when it comes to finding a significant improvement, it is very, very difficult. Although we did a class 1 study and RCT, but you do get improvement. But but most of the time it is not statistically significant. You get some improvement. So how do you go about it? How do you say that this really works? And how do you go? And we have continued with it, and we are trying to do a large series, and it will be published in Spine Journal. And we did conclude that it does improve the hand function and it does improve the neurological recovery. But when it comes to really proving it that it has a significant effect, it is very, very challenging to prove that. And that is a challenge for any researcher who wants to do some work on these things.
Ayush, I agree with you that research in the field of spinal cord injury is challenging. But I would want to say that research in the field of cervical spine injuries is easier to document benefits than research in the field of thoracic spine or thoracolumbar spine. Because in the thoracic spine, it needs improvement at a significant number of levels before obvious neurological or functional improvements can be evident. Whereas in the cervical spine, even if there is one level of improvement, it makes a significant difference to the patient and it's immediately evident. On the other hand, the consequences of any complications are far more devastating in the cervical spine than in the thoracic spine. So you need to balance between the two and go ahead, right? So when it comes to documenting the outcome measures, you need to look not only at the neurological recovery, but also the functional recovery. And that becomes very important. Like a person who is C5 becomes a C6, you may say has only one level of recovery, but it may make a totally dependent person, totally independent in that he can eat, he can write, he can brush, he can type, and he can do a lot more things a lot easier than before. In fact, it makes a world of a difference. And that is why we talk not only on outcome measures, but what is the difference statistically important, but you look at minimal clinically important difference. And in the cervical spine, that NCID is at a far lower neurological or functional value than in the thoracic spine. So I think it is important what you say, but I think cervical spine research may be easier than in the other regions, but the consequences may be more devastating. So we have to balance it very well.
Thanks, Dr. Chabra. Very nice explanation. I thank both the orators for giving a nice talk to us, and we were really enriched with their knowledge. Now, because of want of time, we'll have to close this session. Thanks a lot. Thanks, everyone. Thanks, all the participants. Thank you very much.
Thank you, Dr. Srivastava. Thank you, VTI, sir. Great seeing you. Thank you, Satyan and Kritish. Thank you for inviting me.
Thanks for the opportunity. It has been my pleasure. And once upon a time, we would look forward to conferences. Now we have parallel conferences running at multiple places in the country. I have
it's difficult to be present everywhere at the same time.
Right, sir.
Yes.
Thanks, sir. Thanks a lot. I now hand over the session to Dr. Satyan.
Thank you, sir.
Satyan, please.
Thank you, sir. We'll go ahead with the next session, which is the Best Publication Award. I invite Dr. Vigneshwar to present his paper for the Best Publication Award.
Hello, good afternoon, everyone. This is our publication, a comparative analysis of unilateral versus bilateral instrumentation in transforaminal lumbar interbody fusion for lumbar degenerative disorders. This is a single center large series. I am the presenting author, Dr. Vigneshwar Badikilla. So we don't have any conflict of interest disclosures. So no funds were received in support of this work, and there is no potential conflict of interest affecting the manuscript. To introduce, lumbar canal stenosis is conventionally treated with surgical management, either with the decompression with or without fusion. So transforaminal lumbar interbody fusion is well known throughout the world and is performed with bilateral pedicle screw fixation and an interbody, which gives an indirect decompression even on the opposite side, and that is the principle how it acts on. Unilateral TLIF reduces the operative exposure and the cost of surgery, where you expose only on a single side. So we have had a few publications regarding unilateral TLIF in 2014 and 2013 in the recent years. We had gone through that and did our study. So ours is a single institute, single surgeon retrospective study from June 2014 to June 2017 with the minimum follow-up of 2 years. We included, we have to carefully select patients for unilateral TLIF as the failure rates can go up if we select some unинdicated cases. So our inclusion criteria included a single leg radiculopathy or a grade 1 degenerative spondylolisthesis and a recurrent disc problem. Whereas we excluded these patients from the study, which are patients with bilateral radiculopathy, grade 2 and above, degenerative spondylolisthesis, any lytic spondylolisthesis, severe osteoporosis, like with the DEXA scan of -1.5 and below, and morbid obesity. So patients were followed up for 3 months, 6 months, 12 months, and 24 months with the radiological investigation, X-ray. Visual analog scale and osseous-free disability index was analyzed both pre and post-operatively along with neurological assessment. Fusion and implant failure were determined on the follow-up by X-ray, and if there was a doubtful fusion in the X-ray at 18 months, CT scan was usually done. We also analyzed the operative time, average blood loss, average hospital stay. So the technique of unilateral TLIF, it is same as the bilateral TLIF, where you position in a Jackson frame and expose the midline, and after that only expose the paraspinal muscles are erased only on the side where there is maximum radiculopathy. If there is a left radiculopathy, then only the left side of the paraspinal muscles were excised, and then facetectomy was done. Pedicle screws were placed above and below. A laminotomy was done, and the bone from the laminotomy site was used as an autograft to fill the cage and to help in interbody fusion. And compression was achieved once the cage was placed, and confirmation of the implant position was obtained by CM imaging. Wound was closed in layers. Results. We had 112 patients in unilateral pedicle screw fixation TLIF and 121 patients in the same period with bilateral pedicle screw fixation TLIF. The mean age of the patient in unilateral TLIF group was 53.6 years with an age range of 26 to 70 years, and there were 48 females and 64 males in the study. The average operative time in unilateral pedicle screw fixation TLIF was 75.1 minutes, whereas in bilateral pedicle screw fixation was 93.38, which was statistically significant. The average hospital stay was 1.7 days, and BPS bilateral pedicle screw fixation was 2.8 days. Average blood loss during the surgery was 76.9 ml, which was almost double in bilateral pedicle screw fixation. We have all the tables. I just want you to go through the tables. So here, these are the indications for the surgery: lumbar spinal canal stenosis, degenerative spondylolisthesis, only grade 1, symptomatic degenerated disc disease, and recurrent disc prolapse. We have the VAS score for both UPSF, that is unilateral pedicle screw group, as well as bilateral pedicle screw group, where the improvement at the end of 2 years were similar and statistically insignificant. But which was really statistically significant was the average blood loss, which was almost double in bilateral pedicle screw TLIF compared to the unilateral pedicle screw TLIF, and duration of surgery was also statistically significant. So the duration of surgery was also lesser. And so now we can also tell that the number of implants in unilateral pedicle screw TLIF is lesser, the duration of surgery is lesser. So definitely the cost for the patient would also be lesser. Coming to the complications, there were a few regular complications like superficial infection, pseudoarthrosis, cage migration. One patient had foot drop and implant failure, but in comparison with our own bilateral TLIF group, all were statistically insignificant. To discuss, we had a significantly reduced intraoperative blood loss compared to the bilateral TLIF group, which was statistically significant, and operating time was 7.5 minutes compared to the bilateral TLIF, which was 93 minutes. Reduced hospital stay 1.7 days compared to bilateral pedicle screw fixation of 2.8 days. And VAS and ODI scores at the final follow-up were similar. So the patient had relief, what was supposed to happen with the bilateral pedicle screw fixation. In comparison to other published studies, which had very less, like very significantly lesser number in the study group compared to ours, our study fares very well in intraoperative blood loss as well as operative time. Average hospital stay also is like minimal in our study. And to conclude, the unilateral TLIF group in selected group of patients, in carefully selected patients, would give adequate decompression and fusion. It also provides a cost-effective option with minimal blood loss and reduced operative time and lesser hospital stay. But further studies and long-term follow-up is definitely needed to identify the comprehensive criteria for the selection for unilateral TLIF patients. So this is one of our patient, just an illustrative figure, who had a complete fusion in AP lateral view as well as a CT scan and is doing very well. This is our publication, which was published this year in September. Thank you.
Thank you, Dr. Vigneshwar, for this paper. For the font of time, since you have overshot the time, we will not take any questions in this. I just want to announce that all these papers have been selected for the best publication. All these have been published and all of them have been selected for the best publication award of all the papers that we received. So I congratulate you for that. Our next publication which we received was from Dr. Akash Sakya. I would request our team to play his presentation, please.
Good morning. My name is Akash Shakya, and I am presenting a paper which was published in the European Spine Journal this year. This paper tries to answer the question whether a high BMI does indeed affect outcomes following minimally invasive TLIF. To begin with a bit of context and introduction to our paper, as you all know, obesity is an independent risk factor for the development of degenerative spine disorders, which is very commonly seen in the old age. It is estimated that in the next 10 years, approximately a third of the world population will be either obese or overweight. Minimally invasive approaches have been gaining popularity for the past decade or so, and we investigated whether these novel approaches can be safely and effectively applied to those having a higher BMI. To answer this question, a study was conceptualized and conducted at Dr. B.M. Central Railways Hospital, Mumbai, which included patients who were operated over 4 years, that is January 2016 to January 2020, having a minimum follow-up of at least 12 months. We used a Spastic Disability Index and the VAS scores for leg pain and back pain as a functional criteria. We also used a number of clinical and radiological criteria, which included radiological fusion at the end of 12 months. We included all the patients who were operated with minimally invasive TLIF for degenerative lumbar pathology aging more than 18 years and having a minimum follow-up of at least 12 months. We excluded patients having surgery for any other etiology, as well as patients who were operated previously and had a concomitant cervical-dorsal spine pathology. This flowchart depicts our study design. We screened for all the patients who were operated with minimally invasive TLIF during the study interval of 4 years and could find 207 patients who satisfied our inclusion and exclusion criteria. These are further subdivided into 3 subgroups, namely normal BMI, overweight, and obese based on their BMI values. This table depicts the demographic indicators. As can be seen, the BMI is significantly higher in the category of patients having obesity or overweight. We notice a significantly high incidence of diabetes mellitus and dyslipidemia in patients having a higher BMI. This table depicts the clinical and radiological criteria that we used for assessment. Of note, we could see that duration of surgery and incision length was comparable across the 3 groups. However, the blood loss was significantly higher in patients having a higher BMI. Similarly, the hospital stay, the day of independent mobilization, return to work was also comparable across the 3 groups. However, the ICU stay was significantly higher in patients having a higher BMI, which can be explained because of by the presence of a number of medical comorbidities. The complications and the fusion rates were also comparable at the end of 1 year. With respect to the Spastic Disability Index scores, the scores are comparable at each point of assessment across the 3 groups, and the scores at the end of 1 year are significantly better to the preoperative scores in each subgroup. A similar pattern was seen in the VAS scores for both leg pain and back pain, with no statistically significant seen at each point of assessment. To conclude, obesity does not adversely affect the outcomes post minimally invasive TLIF. Rather, the advantages of minimally invasive approaches can be safely and effectively extended to those having a higher BMI. Approach-related morbidities, that is, incision, infection, and other complications, are similar irrespective of the BMI value. But a point of caution can be practiced with respect to the statistically higher blood loss and ICU stay, which was seen in patients having a higher BMI. Thank you.
Thank you, Dr. Akash. Are there any questions? Dheeraj, you had some question for Dr. Akash, Dheeraj or Kshitij?
I had a question for the previous speaker. Why was fusion preferred for against discectomy in PIVD patients?
There was, I'll be answering, sir. Sorry. There was a very severe facetal arthritis bilaterally. So a discectomy would have been an unstable situation.
Is there any other question? All right. In that case, we will move on to the next publication. This was from Dr. Tushar Kundar on degenerative spondylolisthesis, when to fuse and when not to, a new scoring system for the same.
Good afternoon, ladies and gentlemen. Management in degenerative spondylolisthesis has always been a controversial topic. Two schools of thought exist, fusion and decompression. However, there have been no guidelines. And degenerative spondylolisthesis is actually a melting pot of heterogeneity. This fueled our research, and the aim of our research was to conceptualize a scoring system in the retrospective cohort to guide treatment plan in patients with degenerative spondylolisthesis. Use this in a prospective cohort to validate the scoring system. The retrospective wing of the study happened between July 2007 and 2011. The factors were back pain, which was scored 2, age less than 70 was scored 1, high level activity was scored 1, angulation in X-ray scored 1.5, translation scored 1. If both were present together, it was scored 2.5, and if none, then it was scored 0. Sagittal oriented facet scored 1, coronally oriented facet scored 0. A full facet sign scored 1, and a normal facet scored 0. Taller disc scored 1, shorter disc scored 0. Feasibility in performing a decompression scored 0, and if it wasn't feasible, it scored 1.5. We put together this entire scoring system, following which we did a descriptive analysis using Fisher's exact test. A univariate analysis was performed using binomial regression test, and Uden's index was used to determine the cutoff. The scoring system was then prospectively applied to all patients with degenerative spondylolisthesis, and patients who underwent standalone decompression, their outcomes were measured using ODI and VAS at different intervals of time. In the retrospective study, 131 patients were included, 41 underwent decompression, 90 underwent fusion. All of them did significantly well in ODI, VAS leg, and VAS back pain. The univariate analysis showed that all the factors were significant. The ROC curve showed that they were reasonable. They were having reasonable to good discriminative ability. And the interesting part was the cutoff 5.5. Most of the patients below the cutoff of 5.5 underwent decompression, and above it underwent TLIF. And we ascertained this statistically using Uden's test that this was the cutoff point. In the prospective group, 52 patients who underwent standalone decompression, they were examined. 46 showed good improvement. 2 patients were lost to follow-up, and 4 patients eventually underwent fusion. Their ODI improved from 56 pre-op to 22 at final follow-up. VAS improved, VAS leg and back both improved significantly. Now, coming to discussion, destructive laminectomy was a treatment of choice in the early 1990s, which led to a lot of iatrogenic issues like severe back pain, leg pain, neurological deficits. And Herkowitz in his paper in 1991 showed that fusion is much better than decompression. Many others followed suit. And this coincidentally was during the pedicle screw boom time. But now we know better. We know that it is a heterogeneous entity. Fusion is a relatively longer surgery, more morbid surgery, and the current thinking should be to customize treatment for each patient. Another interesting part is that almost 42% of people today attending the conference will have a slip of more than 3 millimeters. And the natural history of degenerative spondylolisthesis is actually to restabilize in majority of the patients. So like a blind man needs to touch the elephant at multiple points, we had to touch on various factors, including clinical, radiological, and patient factors, technical factors, to make our proposed scoring system holistic. The limitations of our study was that it was a single surgeon study, and minimal invasive decompression is technically demanding. However, we conclude that decompression has a central place in the treatment, and this scoring system is a reliable tool in planning treatment for degenerative spondylolisthesis. Thank you.
Thank you, Tushar, Dr. Tushar, for a nice presentation.
Can I ask one question?
Yeah, please.
Yes,
congratulations, Tushar. Very nice paper. Instead, we like to utilize this in our routine practice. My question to you is, why a shorter disc was given 0 against a taller disc? As per our understanding, taller disc is maybe a better disc for a decompression. Shorter disc may be associated with more severe stenosis from the disc as well as from the buccal phlegm. Also, regaining the height in the shorter disc might relieve the foramen as well. Yeah.
Yes, sir. Sir, I would like to answer your question in two parts. So one part is, sir, according to various studies done by Matsunga and Blumenthal, they say that, and Kirkcaldy-Willis, it is the natural progression of degenerative spondylolisthesis. When the disc height is short, it is going to progress to stability. The other thing is we actually excluded when we had any L4 exiting nerve root symptoms, we excluded the patients from the study. So our main conclusion from this is that the disc, when it is short, the degenerative spondylolisthesis is actually stabilizing.
Thank you, Dr. Tushar. There is so many questions that we can ask. We'll have only one question from Dr. Ayush, and then we'll go to the next paper.
Again, coming to your criteria, you have put inability to decompress. Why will be there is a chance not to decompress it? Even with tubular, those who do, we know we can almost get the complete decompression with the either you are doing an open or tubular, it doesn't matter. More 90-95% time you will be able to decompress completely. So why that was given a mark in the scoring system?
Yeah. Unfortunately, there will be a small cohort of patients who will have anatomy where the facets are very near, the lamina is very small, and then it is difficult to dock the tube and do a decompression without compromising the supporting structures, that is the supraspinal ligaments, the interspinous ligaments, etc., which make up almost 30% of the posterior ligamentous support. And if we happen to injure these, then the patient will invariably destabilize. So that is why we included that in our study.
Thank you, Dr. Tushar. There are a lot of questions which we can discuss this paper for a long time, but we'll go on to the next paper. Invite Dr. Abhinandan Reddy to talk about his publication on posterior stabilization without the neural decompression.
Good morning, everybody. Thank you, BSSCON, for providing me this opportunity. I'm here to present our research work published in Global Spine Journal in 2020. To declare, we have no conflict of interest and we did not receive any financial support for the research. Osteoporotic vertebral fractures remains an enigma to the surgeon till date. And previously published reports have shown that incomplete neurological deficit following the vertebral collapse can be due to retropulsed bone fragments, progression of the kyphotic deformity, or instability at the fracture site. And also previously published literature reports that fractured vertebrae gradually undergoes remodeling and normal anatomy of the spinal canal is regained with time. Hence, the role of neural decompression is debatable. So in this study, our objective was to analyze the outcomes of treating osteoporotic thoracolumbar fractures with incomplete neurological deficits by posterior instrumentation without neural decompression. We hypothesized that instability at the fracture site rather than the neural compression is the main factor leading to neurological deficits in patients with OVCFs. And we have done this using a dynamic MRI imaging. In the material and methods, it was a prospective cohort study and approval from the Institutional Review Board was taken, and data of the patients was collected from January 2015 to December 2017. Of the total 204 patients we had after exclusion, 61 patients were included in the study, and dynamic MRI was performed. As you can see in the imaging, we have used a cushion to create a flexion and an extension at the thoracolumbar spine to obtain the images as evident on the image. So demographic data of all the patients, including age, sex, comorbidities, and medications that led to secondary osteoporosis and number of vertebral fractures and levels involved were collected, and postoperatively anterior osteoporotic treatment taken by the patients and incidence of new fractures was also taken. Preoperative and postoperative neurological status was, and that final follow-up was assessed using INSCI. And radiographic assessment was done as seen on the image using a method of Lieberman and Cobbs. This is a sample image showing the dynamic MRI, wherein you can see compression on the flexion and the relief of the spinal cord compression on the extension images. And we have used the cement augmented fixation for this particular case, and we have not decompressed the patient. And statistical analysis was performed using the SPSS software. And as you can see on the screen, there were 39 non-walkers and 22 walkers, and around 40 females and 21 males were included in the study. And 6 people were on steroids for the other diseases which cause secondary osteoporosis, and 2 patients were excluded as they required revision surgery due to implant failure. And in 18 of the patients, we had to use a cement augmented fixation. Of them, 11 were long segment and 6 were short segment. In the present study, all the patients showed spinal cord compression on flexion MRI, which was relieved on extension, as evident by restoration of the spinal canal
alignment, and cerebrospinal fluid column restoration. A total of 65.56% did not show any significant compression on neutral MRI, and nearly majority of them have regained their neurological status at final follow-up. And there were 2 episodes of wound dehiscence which healed by secondary suturing, and rod breakage was seen in one case which was excluded from the study. Traditional MRI may underestimate the severity of the pathological fractures, especially at the dorsal-lumbar junction, and dynamic MRI is a valuable adaptation of the conventional MRI. In our study, dynamic MRI confirmed the hypothesis of dynamic instability. All of them showed significant retropulsion and compression of spinal cord inflection, which relieved on extension with restoration of the CSF column. And the reason for the delayed neurological deficits was dynamic instability caused by repeated micro trauma rather than the static mechanical compression. The simple posterior fixation without decompression is not only technically easier but also safer. The risks of anterior approach and potential damage to neural tissue from the decompressive procedure can be avoided. The surgical time, blood loss, and operative morbidity are reduced. Posterior elements maintain spinal stability are preserved, and adequate space is available for bone grafting. We have few limitations in this study. It is not an RCT or a carefully matched cohort study. Our study population was relatively heterogeneous, as there was a lack of control group or continuous BMD monitoring, and it was a limited sample size, restricting our ability to separately analyze the cement augmented versus non-augmented screws. However, it is the largest series of the osteoporotic vertebral compression fractures with neurological deficit managed by fixation only. In conclusion, our results indicate that posterior instrumented fusion without neural decompression leads to neurological improvement. We propose that neural decompression of the spinal cord is not always necessary for the treatment of neurological impairment in patients with osteoporotic vertebral collapse with dynamic mobility. Dynamic MRI is a valuable tool to make an accurate diagnosis and determine precise surgical plan and improve the surgical strategy of the osteoporotic vertebral compression fractures. Thank you.
Thank you, Dr. Reddy, for again a good presentation, good paper. Question, Ayush, yes, go ahead.
So I do agree with your paper in principle that that is a good solution. But they're like, how did dynamic MRI? We know this is a problem. We already understand that. So did the dynamic MRI really help you? The other thing, did you look at the canal decompression, the indirect decompression? Because we are doing a similar study, and we are axial cut. We are looking at the canal decompression. That is very, very interesting. And there's no comment in your study regarding that, because we do get a decent canal decompression just by putting on the screw and putting the cement or whatever.
Yes, sir. We have done only pre-operative flexion and extension MRI to find the canal clearance, but we have not done a post-operative MRI to see the canal clearance, because as evident on the pre-operative extension protocol, so we were able to justify that there will be a canal clearance. And also because of the cost related issues, we have done only sagittal sections, not axial sections in the preoperative also.
Great. Thank you, Dr. Reddy. A lot of questions we can discuss, especially on patient selections and all about when you would want to do this. So if there are any other questions, you can even ask them in the chat section. I'll go to the next paper by Dr. Saijot Raut on is 2D fluoroscopy reliable in minimally invasive surgery.
Good afternoon, everyone. My name is Dr. Saijot Raut. Is 2D fluoroscopy reliable? Evaluation of perforation indices in MIS TELIF. So MIS has been evolving, and placement of percutaneously screw have been evolving and been regularly used. It is important to know the factors involved in perforation and their clinical correlation, and to assess the perforation indices in MIS TELIF. Study evaluating perforation indices are scanty. So our aim is to evaluate the radiographic perforation rate of CM-guided percutaneous pedicle screw instrumentation in MIS TELIF. We took 300 consecutive patients in which 1200 screws were placed from 2012 to 2017. Single surgeon, single institute undergoing MIS TELIF, which is degenerative lumbar spondylolisthesis grade 1 in a single level. Methodology: pedicle screw perforation, location, grading, and critical versus non-critical plus neurological complications were evaluated. Perforation grading in CT scan were grade 1 degree of cortical violation, which is 0.022 mm of cortical violation, which is seen in grade 1 picture. Grade 2 shows grade 2 violation, where there is 2 to 4 mm of cortical violation, and grade 3 is critical, where there is more than 4 mm of cortical violation. This is the Mirza et al. Classification for pedicle perforation. Surgical procedure is a general anesthesia prone position where we give paramedian incision and we take 3 to 5 centimeter lateral to midline and lateral to pedicle to give medial convergence. And using a Jamshedi or a Cook's needle, we start at the 2 o'clock position of the pedicle and we make sure that we do not cross the medial border of 9 o'clock in AP view so that we don't cross the medial border of the pedicle. This is the picture which shows the incisions. We evaluated by doing a CT scan of 2 mm axial slices with sagittal and axial reconstructive images adjacent parallel to the pedicle screws, and was done after 3 weeks of the surgery. We saw direction of the perforation, rate of perforation, accuracy of placement, perforation grading was done as per Mirza et al. Classification. Screw penetration, if it was more than 2 mm, was critical. Less than 2 mm, we found non-critical. So in 300 consecutive patients of degenerative spondylolisthesis, L4, L5 were 168 patients and L5 S1 level were 132 patients. 55.5 years was mean age, 132 were male and 168 were female. We found that there were 60 screws which were perforated, which was 5%. Most commonly, laterally, the screws were perforated, which were 30. Medial perforation were 24. Grade 1 showed 42 screws showed grade 1 perforation, which is 3.5%. Grade 2 showed 18 screws perforation. There were 0 patients with grade 3 perforation. As we see in the table, L5 pedicle screws were the most perforated screws in all of total 60 perforated screws, and perforation was mainly lateral. This is the demographic data and shows grade 1 and grade 2 perforations only. So now VAS and ODI scores, which was in perforated and non-perforated patients group, shows significant improvement. There was no neurological injury or CSF leak in any cases. Perforation rate with BMI of more than 30 was significant higher than perforation rate with patients with BMI which was less than 30. The increase in depth of spine, which is the depth of spine more than 50 mm, showed higher incidence of perforation. In fatty obese patients, the incidence were higher. This is a paper where by Niels Hansen et al. Showing 9.4% of perforation rate, and most of the screws were perforated laterally as compared to our paper. We also had similar observations. In conventional open methods, perforation rate were 1.5 to 25%. In 2D fluoroscopy guided lumbar region studies, 2.6 to 14.3 perforation was seen. Previously in a study, most of the perforation was seen laterally, and second was medially. Most of them were grade 1 perforations, and there were no screw related complications. Our study results were also same. In high BMI patients, it is most difficult to find the landmarks, anatomical landmarks. So we should be very vigilant in these patients. Obesity brings excessive blood bleeding, muscle retraction becomes more difficult. So in bulky patient, more attention should be given, and we should converge more because the screws have been perforating laterally. This is a paper where a screw inserted freehand were perforated more medially, and those with put with fluoroscopy or navigation were perforated laterally. So again, we have to make sure that we start laterally and go medial convergence. Tips for safe pedicle screw placement is you to start more lateral in the skin incision of lumbar vertebrae for right trajectory. We should be vigilant by using the Cook's needle or Jamshedi needle so that there is no guide wire advancement or pull out. Surgeon should make sure that it makes a pilot hole before entering the pedicle to avoid slippage, and to save time, all the 4 pedicles should be cannulated and AP projection should be taken. Then with all 4 guide wires in, we should take a lateral projection. So what we conclude is we had a 5% of perforation which were non-critical perforation rate. Most of the perforation were lateral or medial, and you should be always beware in obese and high-risk patient. Safe zone in lumbar spine is 2 mm of perforation. There were no neurological complications or significant ODI VAS score difference in grade 1 perforation. So we conclude that C-arm is a reliable for MISS technique and is acceptable procedure with low rate of screw related complications and revisions. Thank you.
Thank you, Dr. Saijot. Good paper. Any questions for Dr. Sai?
I can ask if no one is asking.
Yes, one question.
Yeah. So did you nice paper, and so did you find that especially when high BMI, where we know that because they are fatty and the landmarks, especially in a C-arm, could be a difficult one. Did you find that 2D navigation, did it help you really decrease your complication rate when it comes to putting those screws? Especially, I'm talking about the high BMI subgroup. Did you analyze that?
Yes, sir. So in high BMI patients, already the operative criteria for patients where the images were good, the C-arm quality was good, where the images were clear. And in these patients, when we did the MIS percutaneous pedicle screws, we saw that the perforation rates were higher.
No, but compared to, so did you compare it with your when you didn't use the navigation? So did it help you?
Sir. So this is our limitation, that we have not compared our study with the navigation part or with any other modalities.
That will be interesting. That's what I
want. Thank you, Dr. Saijot. Good paper there. I want to congratulate all the presenters that we received a lot of papers which have been published, and our judges have chose these 5 papers for the publication awards. I want to congratulate all of you all for a very good publication. So we'll move on. I also want to thank our panelists here for being present. We'll move on to the next session. We'll just have to announce one award which was all from the gold medal session. In the gold medal session, we had 6 papers which were chosen by our judges, and they were again evaluated by the judges on various factors, various parameters. It was a close contest, and at the end, the winner of the gold medal paper presentation was on non-fusion anterior scoliosis correction technique by Dr. Umesh Kanade. There was a lot of discussion on this paper as well, and it was and this was finally overall chosen as the best paper in the gold medal section. So congratulations to you, and our team will be getting in touch with you for this. Without further ado, I wanted to now invite our president, Dr. S.K. Srivastava sir, to again congratulate everyone. And after this conference, we will go to the last session. Srivastava sir, are you there?
Yes, I am there, Dr. Satyan. Thank you very much. I wholeheartedly thank all the faculties, moderators, and all the delegates for making all the sessions very interactive and informative. It was really wonderful to listen all these academic sessions. I thank our dynamic organizing secretary, Dr. Satyan Mehta and Dr. Kshitij Chaudhary, and the whole organizing team for crafting interesting academic sessions. I really enjoyed it. I thank WAMA event and industry colleague for their help. Now I hand over the proceeding to Dr. Satyan for workshop. Thank you very much. Thanks a lot.
Thank you, sir. We've been working very hard since many months to get this program together, and it has now come to a fruition. The program has gone extremely well, and the academic content of this meeting has been very good. We will go on to the last session, which is the industry workshop, sponsored workshop by MJ Surgical. Please have a look at this, because this is going to be talking about various case scenarios in adolescent idiopathic scoliosis. For this, I invite the moderator, Dr. Dheeraj Sonawane, to please take over this session. Please allow Dr. Dheeraj to share his screen and unmute him. Dr. Kshitij Chaudhary will also be chairing the session along with him. He will be helping him out. Dheeraj, are you here?
Yeah. Am I audible?
Yes.
Yeah. Thank you very much, Satyan. Good afternoon, respected faculties and delegates. A warm welcome from BSS. This is a 1-hour session on spine deformity, adolescent idiopathic scoliosis. I thank MJ Surgical for the sponsor and support. We have Masters of Deformity as chairperson and moderators. We have Dr. Ajay Shetty. who doesn't need any introduction. He's a senior spine surgeon in Ganga Hospital. We have Professor Sudhir Srivastav, who is an ex-HOD in GS Medical College and KM Hospital. At present, professor in KJ Somaya Hospital, Mumbai. We have Dr. Samir Dalvi from Hinduja, Professor Ashok Rathod, Dr. Parasnis from Pune, and myself and Kshitij also will be helping. So I welcome all the deformity surgeon and request my first speaker, Dr. Tushar, who is an associate professor from KM Hospital, to present his first talk. Thank you. Tech team.
I have already uploaded my talk, so please.
I'm going to discuss about the Lenki classification in a brief nutshell. Previously, we had a King's classification, which was based mainly upon the coronal plane corrections. Now we know there's a sagittal component to deformity as well. And this King's classification was mainly based upon the posterior base construct, which is to impart a significantly less corrective force as compared to modern day segmental instrumentation. So there was a need to define the curve in a both coronal and sagittal plane. And that's when the Lawrence Lenki and Harm study group came out with a new classical system, which was comprehensive because it included almost 42 types of curve types. It was two-dimensional, so now they used to define the triple measure thoracolumbar, lumbar curve, which were not defined separately in a King's classification. It was treatment-based because they came out with an algorithm which recommended treatment based upon the nature of the curves. It was reliable because there was a good inter- and intra-observer reproducibility, and it was set upon the specific arbitrary criteria, so there could be a uniform guidelines in managing these curves.
I think Tushar got disconnected.
We have a video with us. There is a problem from our side, I see.
Yeah, problem is from our side. Yeah.
Tushar is already on. I can see him.
Yeah, but he is not presenting online. He's. We have a recorded video. Tech team.
Do we have a backup? Tushar can share his screen and play his own video.
I can try from myself. Just allow me to share. Okay, let me check.
I'm going to discuss about the Lenki classification in a brief nutshell. Previously, we had a King's classification, which was based mainly upon the coronal plane corrections. Now we know there's a sagittal
start from where we had ended
as well. And this King's classification was mainly based upon the posterior base construct, which is to impart a significantly less corrective force as compared to modern day segmental instrumentation. So there was a need to define the curve in a both coronal and sagittal plane. And that's when the Lawrence Lenki and Harm study group came out with a new classical system, which was comprehensive because it included almost 42 types of curve types. It was two-dimensional, so now they used to define the triple measure thoracolumbar, lumbar curve, which were not defined separately in a King's classification. It was treatment-based because they came out with an algorithm which recommended treatment based upon the nature of the curves. It was reliable because there was a good inter- and intra-observer reproducibility, and it was set upon the specific arbitrary criteria, so there could be a uniform guidelines in managing these curves. So there are specific terminology that one has to understand before embarking on this classification. So a classification in a Lenki has a three component. First component is identifying the curve type. Second component is identifying the lumbar modifier, and third type is identifying the sagittal modifier. And what are these factors we will learn in a subsequent slides. So if this kind of X-ray is given, there are two curves, that is a major curve and a minor curve. So when you see this X-ray, a curve which is of a larger magnitude is considered as a major curve. And by default, major curve is considered to be a structural. Now, in this case, a thoracic curve is a larger magnitude, you can see 60 degrees, so it's a major curve. And there are adjacent curve which may exist. For example, here there are two curves, proximal thoracic that is 24 degree and lumbar curve which is 32 degree. So these will be treated as a minor curve. Now, the second step is to understand whether these minor curves, what is the flexibility? Are they structural or not? And how do we see a particular curve as a structural or not is depending on their flexibility on a side bending radiogram. So what we do is essentially do a bending and see the magnitude of this curve on a side bending. If the magnitude of this curve on a side bending still shows a residual curve angle of more than 25 degree, then it is considered as a structural curve. That is on a coronal plane. What about the sagittal plane? So for example, for a proximal thoracic curve, to know whether it is structural or not, we do a kyphosis angle. We calculate a Kopp's angle between the T2 and T5 vertebra, and if it is more than 20 degree, it is considered as a structural. For a main thoracic or thoracolumbar curve, we calculate the kyphosis angle on a sagittal profile, that is Kopp's angle between the T10 to L2 vertebra, and if it's more than 20 degree, it is considered as a structural. So we understood what is major curve, what are the minor curve, and how do we understand whether the minor curve is structural or not, depending on the side bending radiograph and a sagittal profile. So we need a 4 radiograph to determine this. As we understood, we need a standing coronal profile, standing sagittal profile, and a supine bending types. If there's a pelvic obliquity on an X-ray of less than 2 cm, it can be neglected, but if it's more than 2 cm, one has to give a block to correct the pelvis to determine the curve type. So first step is to identify these curves and measure this curve magnitude. As we discussed, the proximal thoracic curve will have an apex between the T3, T4, T5 vertebra. The main thoracic curve will have an apex between T6 to T11, T12 interspace dispace. The thoracolumbar curve will have an apex between the T12 superior end plate to L1 inferior end plate vertebra, and a lumbar curve will have an apex anywhere between the L1, L2 disc to the inferior end plate of L4 vertebra. So these are the apex depending on the curve region. Once we do that, we measure the same curves on a bending profile. So we will measure what is the bend angle after bending, what is the proximal thoracic, thoracolumbar, and main thoracic curve. Third step is to know what is a sagittal profile. A radiograph shows this particular curve on a sagittal profile. So as we discussed, proximal thoracic will measure the T2 to T5 Kopp's angle. If it's more than 20 degree, it's structural. And for other curve, we'll measure T10 to L2 Kopp's angle. And if it's more than 20 degree, it will be structural. The other thing that we need to measure is to understand what is a sagittal modifier, because that is one of the component of a classification. And how do we know sagittal modifier? We measure a Kopp's angle between the T5 superior end plate and T12 inferior end plate. And if this Kopp's angle is less than 10 degree, it is considered as a hypokyphosis and it will be denoted by minus sign. If this angle between the T5 to T12 is 10 to 40 degree, it is a normal kyphosis and it will be labeled as N. And if it is more than 40, it is called as a hyperkyphosis and it will be labeled as a plus sign. And the third component is a lumbar modifier. So what is a lumbar modifier? We all know central sacrovertical line, which is a perpendicular passing through the midpoint of S1. It's perpendicular horizontal, which is traversing the superior end plate. So we need to determine the relation of CSVL with the lumbar apical vertebra. So if the CSVL is passing through the two pedicles of lumbar apical vertebra, it's called as a modifier. If CSVL is passing between the medial wall of the lumbar apical vertebra and the lateral wall of the lumbar apical vertebral body, it is called as a B. And if CSVL is not touching the lumbar apical vertebra, it is called as a C. So this has an implication on the flexibility of the lumbar curve, and this will also have an implication on the management, because type C are notorious curve and they may sometimes, in spite of being non-structural, may need to be incorporated in the fusion mass. There are 6 curve types that Lenke described. So what is type 1 curve? That is a main thoracic curve. Here only the main thoracic curve is structural and adjacent proximal thoracic or thoracolumbar and lumbar curve are non-structural. What is double thoracic curve? Here both proximal thoracic and main thoracic both are structural, whereas thoracolumbar and lumbar is non-structural. What is double major? Here proximal thoracic is non-structural, but main thoracic and thoracolumbar curve are or lumbar curve are structural. What is triple major? Where both proximal thoracic, main thoracic or thoracolumbar lumbar curve are structural. And all these 4 curves can be subclassified into A, B, and C depending on the CSVL and its relation with the apical vertebra. And each pattern then again re-subclassified into a normal, minus, or plus depending on the kyphosis between the T5 to T12 vertebra. And what is the type 5 and type 6? So type 5 and type 6 are the only curve where the thoracolumbar or lumbar curve will be major curve. And in type 5, Only thoracolumbar and lumbar curve is structural. The adjacent minor curve, that is proximal thoracic and main thoracic, are non-structural. Whereas in type 6, main thoracic and thoracolumbar lumbar is structural, but proximal thoracic is non-structural. These two curve patterns will not have A and B because of obvious curve nature, and they has to have a C classification. And that's why we have only 42 classification and not a 54 classification groups.
Again, the slide is not moving.
So basically, this is a slide which is talking about the drawbacks of the classification as it has a 42 curve types. It increases the complexity, and there are certain rule breakers in this classification, like type 1C, where we go on using even non-structural curve. And the Lenke classification does not give us exactly where to stop and where to start. That's the drawback. So that is what the last slide mentions. I apologize for the technical delay, but that's all in a nutshell about the Lenke classification.
Thank you very much, Tushar. That was very informative talk, and you have really made it simple for us to understand Lenke's classification. By the time we move on to our next talk by our prediction of scoliosis, and we can take some questions from the faculties and delegates. Okay, if there aren't any, Tushar, there are some confusions. Can we pause the video for a while? Tushar, there are some confusions in Lenke classifications, especially for the beginners. That means that usually is type 1 curve is bends less than 25 degree. Okay, that is one confusion. So what we consider? Second thing, if there is a proximal curve which is not in coronal plane and only in sagittal plane there is a deformity. So how Lenke has included that?
Yeah, I think that's a very important question. So this is the only classification. The advantage over the Kings was it also specifically talked about the sagittal classification. So a lot of time there is a confusion when there is a hyperkyphosis or AIs usually get a hypokyphosis most of the time. But if there is a significant kyphosis of more than 20 degree, then one has to be cautious and should incorporate that particular curve in a fusion. And that's what Lenke talked about regarding the sagittal plane correction. And the second thing which you talked about, the 25 degree thing. So I think specifically is that about the 25 degree, it's an arbitrary amount that even Lenke admitted. But I think that works in most of the curve. But having said that, the clinical classification and also clinical examination, and there are certain sets of rule breaker, we like Lenke 1AR, 1AL, which will not be a scope in a 5 minutes talk, that one has to be careful when you are doing the instrumentation.
Thank you very much, Tushar. Tech team, please play on the next talk by Dr. Hitesh.
We can't hear the sound. We can't hear the sound.
Factors, and those factors that affect the curve progression are.
Can we restart the slide?
Let us discuss one by one. As we know that scoliosis is a three-dimensional deformity with curve angle more than 10 degree. If curve is mild, it seems okay. If curve is severe, then there are a lot of other factors, and those factors that affect the curve progression are enlisted here. Let us discuss one by one. The first is sex or gender, and as we commonly know that girls are much more likely to have scoliosis curves that progresses to the point that the treatment required. And literature also said that if the curve is 30 degree or more, girls have 10:1 ratio for the progression over the boys suggested in these articles. The second factor is age at the time of diagnosis, and again, literature also confirms that the diagnosis of a scoliosis at a younger age means there is higher chances of curve progression. This article by Lonstein and Carlson says that children 10 years or younger age group with the medium curve means 20 to 29 degrees has nearly 100% chances of progression of the scoliosis curve. The skeletal maturity is a third factor, and it basically suggests that how much growth a child has remaining, and that is decided by certain growth plates. Rapid increase in spinal height at the time of pubertal growth spurt causes an increase in spinal curvature, and therefore we can say that progression of AIS is closely related to the rapid growth. The maturity is often multidimensional and has various components such as chronological age, skeletal age, research sign, status of triradiate cartilage, Tanner stage, etc. The most important of them is research sign, as we know, and it is basically a calcification of iliac wing apophysis to the iliac wing, and it has been graded from grade 1 to grade 5. The famous article in 1984 suggested that research sign 0 or 1 showed 68% of the chances of progression in a scoliosis patient, and if research stage grows more like 2, 3 or 4, then these chances of progression gradually goes down. Dimiglio also confirmed this report similarly, that if the patient is having research stage 1 with 30 degree of curve, there is 60% of the risk of progression. If the same patient is in research stage 2, then the chances of progression becomes 30%. And similarly, as research stage increases, the chances of progression will go down. The hand X-rays as well as X-rays of olecranon, those are again measurement of the skeletal age and skeletal maturity, and it is also having a similar prognostic factors about the scoliosis curve progression. The rib vertebral angle or Mehta's angle given in 1972 by Dr. Mehta, it is basically a difference between concave and convex side of rib vertebral angle to differentiate resolving versus progressive curve. And as we can see in this picture, that the measurement of rib vertebral angle difference, if it is less than 20 degree, then 83% of the curve will resolve, and if it is more than 20 degree, then 84% of the curve will progress. The initial Cobb angle is an important factor, and literature suggested that the main thoracic scoliotic curve exceeding 30 degree at the beginning of puberty will have 100% chances of progression. And however, Weinstein et al. Has contradicted this curve, and they have suggested that the progressive curve cannot be predicted whether it will progress to 30 degree or 78 degree. We have also developed one paper about the drooping of the apical convex rib, and we suggested that if the rib vertebral angle started drooping after given the bracing treatment, that means the perpendicular corrective forces applicable to the vertebra will not be effective because of the rib drooping, and therefore the curve will progress. The last factor is a serum test. In certain patients, if high ghrelin level is there, it can predict the curve progression over a period of time. So these are commonly seen the factors that affect the curve progression in a patient of adolescent idiopathic scoliosis. Thank you very much for kind hearing.
Thank you, Dr. Kshitij. We have any questions for Dr. Kshitij? By the time tech team can prepare for Dr. Gururaj talk. Yeah.
Dheeraj, it was Hitesh, not me. Hitesh was speaking.
Yeah. So, Dr. Hitesh, is there any study on curve progression as per the COP severity beyond skeletal maturity? That is one question. And also sometimes I find riser sign difficult to assess in some patients. It's not always that clearly seen in all the X-rays. So what are the next question we can do?
I think as we see the research which were previously published in mature patients, one famous article actually published probably in Degenerative Scoli, and they said that curve progression will be around 1 to 2 degree per year over a period of time if the curve is more than 30 degree. So there are a number of research already been published regarding the progression of the curve after the maturity has achieved, and therefore they recommend that if maturity has been achieved and curve is less than 40 degrees, still you can wait, because to reach to the for the curve to attain 70 or 80 degree, which really requires some kind of surgical treatment, it will take another 25-30 years if initial cob angle is less than 30 or 40 degree. So this is after the maturity. And research sign, yeah, I agree that it may be difficult in the beginning, but for that you need to have a proper pelvis with both hips radiogram whenever you are considering treatment or maturity status of the scoliosis curve.
It's not only difficult to assess, but it's inaccurate also.
Yeah.
Yes.
Result is not accurate.
Yeah, Kshitij, what the next thing you follow? I try to look for the triradiate cartilage.
That's true.
Actually, the better thing to do is Sanders. Everybody is using Sanders these days because you get the X-rays done with the hand and the wrist. And Sanders is a modification of the old Tanner Whitehouse classification and the Grulich-Pyle Atlas, but it is a simplified kind of 6 stages. So it's an easier way. Otherwise, you would have to open that book and kind of every time look at every single skeletal age. But wherever you are doing like bracings and end of bracing kind of decision making, or vertebral body tethering, or predicting what will happen, Sanders is better than Reesers. Even Menarche is inaccurate. So there's a big variation between them.
So that is basically known as carpal bone age.
Yeah. No, but what you have to do is when you see a patient, for example, a female, if there is a history of onset of menarche, we know that the growth phase is, the peak height velocity is already crossed, number one. You don't need to take a hand X-ray then. And when you look at the X-ray of the whole spine, you see that the riser is already 1 and 2. You need not look any further. But when you find the riser 0, then comes the question of whether how you will know the skeletal age. Then you have to look at riser plus, that is, whenever there is an triradiate physis is fused, when you know that the triradiate physis is fused, that means about 80% of the peak height velocity has already happened, and still the triradiate is open. Then you want to know the skeletal age, and probably taking a hand X-ray would be an ideal. But if you already have got riser, you already has got menarche, then there's no point in looking at other sorts of investigations.
Yeah.
Right, sir. Thank you, sir.
Does the curve progress even with respect to the anatomical level also? For example, thoracic curves are more prone to progress with respect to thoracolumbar. Is there anything difference among the anatomical levels?
Yeah, there is a research already published that single thoracic curve is, I think, has much more chances of progression rather than double curve, because there is some balancing act between whenever there are 2 curves. So those research are also there in adolescent idiopathic scoliosis. However, I have not included all those factors because of the time constraint here.
Only thing I would like to add is, if you have a lumbar curve, the consideration has to be 30 degrees, not 50 degrees.
Yeah.
The 50 degree is defined mainly for the thoracic curve because it can tolerate a higher degree of deformity without affecting the mobility. Whereas a lumbar curve, when it crosses 30 degree, when the child is skeletally getting to the age of maturity, if you leave it alone, there is a significant amount of back pain and progression of scoliosis with the age on. I mean, you have to read the article by Lonstein and also article by Kai Watanabe, which was published recently, some time ago.
Thank you, Ajay sir. Thank you, Hitesh. Can we move on to our next talk by Dr. Gururaj on level of selection in AIS? Dr. Gururaj is a senior spine surgeon in Indian Spinal Injury Center and heading a unit there.
Good afternoon, friends. Myself, Dr. Gururaj Sangondimat. At the outset, I would like to thank Bombay Spine Society for giving me this opportunity to talk on selection of fusion levels in AIS in Lenke type 1 curves. Basically, why this is controversial? Because if you see in this paper, all of them are senior surgeons. Still, they ended up choosing 5 different proximal levels and 4 different distal levels for fusion of these curves. So that is why we are discussing about this today. So clinically, if you want to select fusion levels, you should always look at these 4 parameters, that is shoulder balance, truncal shift, thoracic prominence, and lumbar prominence. And we should also always remember this important classification of AIS, that is Lenke classification. So considering general principles of fusion levels when it comes to AIS is in the sagittal plane, we should include all pathological curves. Never should we leave out kyphotic curves, and we shouldn't stop in between the pathological curves, be it in the coronal plane or be it in the sagittal plane. And in transverse plane, in selecting LIV, we should always go to a rotationally neutral vertebra. And the disc that opens on both directions in bending films can be left outside the fusion level. So LIV should always be within the stable zone or within the zone which is bisected by the CSVL, that is central sacral vertical line. In immature patients, LIV should derotate to neutral or near neutral on bending films. And always secure your lower instrumented vertebra with the secure fixation with pedicle screws. Anterior fusion applies to only Lenke type 1 or 5 curves, and it is done when you want to do a single curve fusion. And in this, you fuse from end vertebra to end vertebra. You can use a single rod technique or a dual rod technique, depending upon your training. The more controversy exists when we come to this entity called selective thoracic fusion, which was described by Moe in 1950. What is selective thoracic fusion? When a fusion you do of a thoracic curve in the presence of a lumbar curve. So that is called selective thoracic fusion. This is based on the principle that the leftover lumbar curve spontaneously corrects itself with time. And the selective thoracic fusion should give a long-lasting correction of all components of the deformity and also aims at maintaining as much as cranial and caudal motion segments as possible intact. So what are the main 2 causes of basically distal adding on or a basically curve progression of the lumbar curve? That is inappropriate lower instrumented vertebra selection and skeletal immaturity. That's why in a skeletally immatured children, we have to be very, very cautious when we try to do a selective thoracic fusion. In this paper, Wong et al., they said that if LIV and CSVL distance increases in the postoperative period by 10 millimeters, it is a predictor of distal adding on. They also said how to choose a LIV in Lenke type 1 curves. That is, a LIV should be the first vertebra from the sacrum, that is away from CSVL more than 10 millimeters. They also said that if a preoperative standing radiograph, if LIV plus 1 deviation from the CSVL is more than 10 millimeters, then it is more likely that you will have a adding on. Again, there is a concept of 1 AR and 1 AL curves depending upon the tilt of the L4. 1 AR curves are the long thoracic curves and 1 AL curves are the short thoracic curves. 1 AR curves, you have to go more distally into the curve for the fusion. And it is also said that 1 AR curves have 2.2 times more likely probability of adding on. So that is why if you see these 2 curves, we have fused short here and we have fused long in 1 AR curve. Suk et al. Also said that when preoperative neutral vertebra and end vertebra show no more than 2 level gap difference, the curve should be fused down to neutral vertebra. But If the gap is more than 2 levels, we should fuse neutral vertebra -1. That is, we are saving levels there. This is again an case example. For the want of the time, I'll just them. Coming to 1B curve, that is 1A and 1B curve should be subject to selective thoracic fusion, and they're amenable in 90% of the times for selective thoracic fusion. What is the difference? In a LIV, in a 1A curve, you go to a last vertebra touched by the CSVL. But in type 1B, you go to the most cephaloid vertebra intersected by the CSVL. That is last substantially touched vertebra. That's again an example of 1B curve. Exceptions for selective thoracic fusion are obesity, if the curve is more than 80 degrees, and if you have a junctional kyphosis, you have to be careful in doing selective thoracic fusion. Coming to main thoracic curves, that is type 1C curves, most of them you might have to go down and fuse the lumbar curve also. But in some, you can do a selective thoracic fusion. What are the criteria? So the ratio between the Cobb angle measurements of the thoracic and lumbar curve and apical vertebral rotation and apical vertebral translation of the thoracic and lumbar curve, if all these measurements are 1.2 times more than the lumbar curve, and if there is no thoracolumbar junctional kyphosis, you can still do a selective thoracic fusion. But here you have to be careful. You have to leave some angulation at the lower instrumented vertebra to accommodate the lumbar curve. So that's an example of, again, 1C, where this 1.2 criteria didn't satisfy. We went ahead and did a long fusion. Coming to the upper instrumented vertebra in Lenke type 1 curves, you have to see for the shoulder balance. If in right curve, right shoulder is high, you can safely go to D4 or D5. If the shoulders are level, you have to go to D3. If left shoulder is higher as compared to right shoulder in a right thoracic curve, you have to go to D2. So, in nutshell, most of the Lenke type 1A, 1B curves are amenable for selective thoracic fusion. If LIV is chosen properly, you can prevent distal adding-ons. In Lenke type 1C curve is also amenable for selective thoracic fusion, satisfying the criteria of 1.2 ratio. And this selective thoracic fusion, we should remember, is based on the principle that lumbar curve corrects itself. If it fails, then your selective thoracic fusion will fail. Thank you.
Thank you, Dr. Gururaj. It was an excellent talk. By the time we can take over questions, we have questions for Dr. Guru. Guru, my questions for you is, we are only considering coronally stable vertebra. What about the sagittal stable vertebra? That is my one question. And my second question, how you consider to, in the case when you want to preserve the level, especially in lower instrumented vertebra, which is coming in the lower lumbar level, by taking supine AP and traction X-rays and relying on the CSVL. Yeah.
Okay. Coming to your first question, if you at all want to consider a sagittal stable vertebra, then it means that you already have a kyphosis there. So that means that you cannot go short there. You will have to include this kyphotic segment, and you will have to go down. So automatically you will be ending up in a vertebra which is sagittally stable. So that is why you will have to always remember, whenever we are trying to save levels, we have to remember the general principles, those basic principles where we cannot ignore the sagittal profile. And if there is a kyphosis at the thoracolumbar junction, which is more than 20 degrees, you will have to go down and actually consider the lower curve also as structural, and you have to go down. The other thing is, coming to your second question, there are many theories and many proponents for selection of a lower instrumental vertebra in Lenke type 1 curve. So one principle cannot apply to one curve. So you'll have to individualize and see which is most basically vertebra which is more safer. So coming to, I consider usually two criteria at least. One is the Wong criteria, where actually in a standing X-ray, if your vertebra which your LIV you are choosing as a L1, if it is more than 10 millimeters away from the CSVL, I go to that. But then if L2 is also more than 10 millimeters away, then it is the chance that it will add on. So definitely I'll go to L2. So that is one thing which I make sure that in standing X-rays, where I don't want, as soon as the patient stands, the curve starts progressing. The other thing in bending X-rays, you will have to see mainly for the rotations, whether the rotations are getting corrected, rather than basically going for a stable vertebra in a bending X-ray. So if you see the rotations that it is rotating at least 2 or less than 2, if you are LIV, then you can safely go to that level.
Yeah. Thank you very much, Guru. Ajay sir, Dr. Parasnis, SKS sir, you want to add something to this? Yeah.
I think it's quite comprehensive.
Yeah. Dr. Parasnis, please unmute yourself.
Dr. Rajesh, you have to unmute yourself.
Parasnis, you're not unmuted. You are muted.
Yeah.
Are you able to hear me? Hello?
Yes, we can hear you.
So the question to Dr. Guru Raj, a lot of decision making happens on the bending films, right? So most of us have this difficulty that many a times the bending films are not appropriate. So can you talk a little more about fulcrum bending, traction, or any other way that you take bending films precisely? Because the decision making of the LIV depends on this largely, or you have any personal method to determine that when you take bending films?
Okay. So coming to bending films, you are absolutely right that it always depends on person who is doing it and in the environment where we are doing it, and if the person is regularly doing these bending films, definitely it matters on that. So the best way, what I basically depend not more on the bending films, I mainly depend on the traction films, because that is the one which gives me more idea about the stable zone, where the vertebra is, whether is coming into the stable zone or not. And then especially in type B and type C curves, like it is not a structural curve actually, but then if you see the rotations and the deviation of the apex from the CSVL is too much. So definitely in a center where they are doing fulcrum bending X-rays, that is the ideal way to do it. But in a lot of centers, we don't have the facility of doing the fulcrum bending X-rays. So in those centers, I would say traction X-rays will be more reliable as compared to bending X-rays. Only bending X-rays, we can use it for categorizing the curve by saying whether this is a structural curve or it is a non-structural curve. And as I told, we'll have to see the neutral, basically rotation of the vertebra, which the LIV we are choosing, whether it is derotating itself or not. So the main LIV selection has to be done on the standing X-ray and the traction X-ray, and the bending films can be utilized to see the rotation and whether the curve is structural or non-structural.
Can I add to that? I don't know if we have time. But...
Yes, Ritesh, can.
So, in my opinion, to answer in short, is that the LIV does not depend on the bending X-rays if your LIV is not L3 or L4. So if you have a standard Lenki 1A, 2A, where you are not going into the lumbar spine, your LIV essentially is determined by your standing AP and lateral, and in which you are looking at not only the coronal vertebra as well as the sagittal as well as the neutral. So the displacement of the LIV is in 3 dimensions. So you are looking that in the standing films, and the bending or the fulcrum or the traction or whatever you do are flexibility films that determine what kind of releases are necessary. But the LIV essentially is frozen by your standing X-rays. The only place where bendings or flexibility will determine whether your LIV is going to change or not will be for the L3 versus L4 debate, where if you are going to cheat one level short and go to L3, that's the only place where I think those bendings would make a difference. But it hardly ever matters if you are going to go T12, L1 or L2, depending on the bendings. Like those cheating those levels, sometimes your bending X-rays can make you cheat a little bit more and land you up in trouble. So that's what I follow.
No, I fully agree with Kshitij.
Yes.
You know, you give the traction field, and ultimately after surgery also patient is going to stand. And you know, you get a feeling that this vertebra is coming nearer to the midline. And then as soon as the patient stands, it just tilted. Then what happens? We lose that, inclusion of that vertebra where, there may be off balance. So actually standing field is extremely important.
So can I have last comment? So I agree totally with Kshitij that definitely it has to be based on the standing X-ray. But then in some cases where you want to stop at L1 or L2, sometimes you can decide based on the traction X-ray. If everything is falling into the center in the traction X-ray and the rotation is completely getting corrected with the instrumentation of the pedicle screws which we are using, where we can derotate the vertebrae, we can choose between L1 and L2 sometimes. Otherwise, most of the times I totally agree, the standing film which determines the LIV, especially in Lenke 1 types.
True.
Yeah, thank
So
you.
the L2 is not usually the LIV in Lenke 1. L2 is the LIV usually in Lenke 1AR, where you have to be really careful.
Yeah, right.
Can we move on to our next talk? So our next talk is on pedicle screw insertion in rotator vertebra, various techniques. Dr. Shailesh Hadgaonkar from Sancheti Hospital will be presenting.
Hello, everyone. I would like to thank Team BSSCON, Dr. Srivastav sir, Dr. Kshitij Chaudhary, and Dr. Dheeraj Sonone for this wonderful opportunity. And today I'm going to talk about pedicle screw insertion in rotator vertebra. We all know the evolution of pedicle screws and the usefulness in improving the coronal, sagittal, and rotational deformity. And important things in apical region is always you have to be careful about the dysplastic pedicles, absent pedicles, sclerotic pedicles, and you have to be careful about the concerns of viscera, the greater vessels, as well as the medial wall and the spinal cord. They are difficult thoracic pedicles, normally D3, D4 on concave side, as mentioned by this article, and they always talk about thin or dysplastic pedicles on concavity in deformities. And again, this paper is talking about pedicle width is significantly smaller in concavity of moderate to severe thoracic curves. What was the advice? The usefulness of pedicle screw in concavity. You have to be very, very careful, and you have to understand the anatomy well before you insert the screw. This is a technique by Kota Watanabe, and we know the channel technique. A large channel type A, a smaller cancellous channel type B, the cortical channel type C, where we need to tap in case there is sclerosis, and type D is absent or slit channel. And this is endorsed by the Italian surgeons. Various techniques can be like what we routinely use is freehand, the ball tip technique, the funnel technique, image guided, the C-arm as well as O-arm guided, and the newer technique which are coming up with 3D recon as well as the electronic guided devices. This is the most important image for all of us. The entry point, the sagittal trajectory and the axial trajectory in deformities. We always understand that the superior articulating process and the transverse process junction is our entry point for the thoracic screws. At times, we need to take out the superior articular process by doing osteotomy so that we can get a clearance for entering inside. Gear shift technique is very, very useful outward and inward. And the trajectories are orthogonal to the sagittal curvature. The top two vertebrae, T1 and T2, the axial trajectories are 10 degrees more, which is 30, and in T3 to T12, it is 20 degrees, the convergence. The gear shift probing always useful in freehand, because that gives us a safety towards the cord. When we enter, we cross the pedicle, and once we cross the canal, then we can turn it around towards the vertebral body as the D-shaped vertebral contour, and you can go more convergence. Therefore, this gear shift probe is very, very useful. Preparation, we have to always do all the appropriate X-rays, the CT scan and MRI scan to understand the viscera, understand the vessels and the anatomy of pedicle. Always check the exact pedicle. We always measure the length of the pedicle, the diameter of the pedicle, and we mount it on our operation theater table. This is the bone model which talks about.
Yeah, normally this
The
is
entry points.
where we will be considering our pedicle entry, but in severely deformed thoracic or thoracolumbar spine, you have to understand that the concavity will be facing downwards and the convexity will be facing upwards. Here, the chances of pedicle, which can be type C or type D in concavity of Watanabe classification, are very high. When you are trying to use your Lenke probe, you have to always understand the gear stick so that you enter very slowly, gently, identify the lateral wall, and then shift your gear, and go more converge to the vertebral body and just go with the feel very slow. Maybe there is a possibility of you breaching the pedicle and going again into the vertebral body. Always ask your assistants to give a counter when you are putting the apical screw. There are chances you may hit to the thoracic vessels, or you can go into the cord. You have to be very, very careful.
And if you see the trajectory,
this is the perpendicular to the floor, and we are doing the apical screw in this spine symposium of deformed rotated vertebra. And if you see the angle, if you see the rotation where I am almost parallel to the ground and I am putting this vertebral screw.
and this is how the directions can be. We have to have that three-dimensional judgment of this concave rotated vertebra in deformities. Always keep it in mind in case you get out of the vertebral body, there are chances of you hitting the greater vessels. Always keep it in mind. And the ball tip technique is very, very useful, and it keeps you very, very safe. You'd always feel with the ball tip, and the flexible shaft also helps. So you feel that give way the soft tissue, and then you have to go back, check it. X-rays will be of less use because you the chances of you getting a wrong image or a difficult image can be very high. And the limitations are very, very narrow pedicle, less cortical vertebrae. And the funnel technique, again, we use the probe and use the entry point, burr it, and then use the Carrison Rounger to make it a funnel, and you go and enter. You go very, very slow at this thoracic vertebrae, and they can be useful. Image guidance is important at times, and at times it can give you a wrong judgment also. It's a judgment of your clinical acumen as well as the image guidance in rotated vertebrae. O-arm navigation is definitely a big support these days, with very high chance of accuracy. As we have seen, a big amount of rotations can be very safely dealt with O-arm navigation. And even our personal experience is very good in O-arm navigated pedicle screws in deformities. Just a case, double major curve. This is type 3C Lenke, and we see 78 degrees Cobb and 56 degrees lumbar curve. If you plan it well, there are very good chances that you can go in the apical vertebrae very well. And this is the clinical picture. At times it can be very scary, but when you do a good release, you can really put very good screws. You can do a freehand technique, and if need be, you can always check in C-arm just in case you are in doubt. We really got very good correction, around 70-80% of the pedicle screw density, and a very good deformity correction. O-arm always helps, as we see, and in deformed pedicles, we can go very slow and carefully.
Apical concavity in the thoracic spine, and you can.
Yeah, and nowadays we can have exact with the O-arm navigation, and when we see these patients are very, very happy with good correction. 3D recon, we can definitely use nowadays the bone models and exactly a very cost effective way of doing it, which is been done in South America a lot. And Pediguard is again an important screw placement, safety screw placement device which is come into the market. Salvage, we can change the trajectory, pedicle dilatation, larger diameters, image guidance, laminectomy if required. I think it's again a very important thing. In case you burst a pedicle, you can always leave that body and you can go to the next level in case you are not getting a good trajectory. Thank you very much.
Thank you, Shailesh. It was an excellent talk from you. Any questions for Dr. Shailesh?
Yeah, can I ask one question?
Sir, please. Sir.
See, we had been doing with the free hand thing because we never had any C-arm or anything previously. And what is most important is the feel. What feel you get during passing the thing. It was our own way to just pass a probe, thick probe inside, manipulate, reach to the opposite side. Sometimes you find that on concave side it is practically horizontal, and other side is going there away from the spinal column. So how it is different now when you have all these gadgets? What is the incidence of screw cutout when you are using this O-arm? Because some of the people now you are using O-arm. So how many times you find there is still a problem and practically it is like doing as you were doing earlier?
It's a good question.
Definitely helpful, but what is the, you are very, very happy or there is a still incidence of having problem?
No, I think, sir, the answer is clear. I'm very, very happy. That's the answer, number one. Because you have your own freehand techniques, whatever you do, Roy Camille, or you do a anatomical screw. At the same time, you have exact anatomy in front of you, which is telling you this is the pedicle, there is a sclerosis, and you are going slow, you are burying, you are tapping. So it is everything under vision like navigation. Life becomes very, very easy. There is no feel of give way in this rotation. You don't feel I slept my probe, or that thing is not there at all. You don't have to worry because you are seeing it in axial, you are seeing it in sagittal. Both the images you are seeing and you are seeing in coronal. All the things which are there in front of you, it really becomes very easy and you finish the surgery very, very quicker than what we used to take time. I always felt initially when we started using O-arm that it probably will take a longer time, but within those who are already doing it, is not a long time for learning. There is a very short learning curve for guys who are already doing it.
Thank you.
Can I add something, sir? Dr. Srivastava?
Yes.
Yeah, sir. So actually, I have got everything. I have got O-arm as well. I have got robot as well. But for AIS cases, I strictly rely on freehand only. The reason being, with O-arm, if I'm using navigation, then my release is not complete, because if I have to put screws, I cut the facet first. And if I cut the facet first at each level, then the O-arm accuracy changes. It becomes flexible, it keeps on moving, and the accuracy of O-arm changes. So if you have to use the O-arm for navigation, then you have to do the facet resection later on when you have put the screws. And in those cases, I've seen that my release is not so perfect. So I just use freehand. O-arm is only if there is any neurological signal occurs, then I just use O-arm to check the screw placement there only. I don't use O-arm for AIS.
You will have to make the first spin after you do the release then. Like your O-arm
but it keeps on moving. But it keeps on moving.
No, means you have not done the first spin, you have done your releases, you have done everything. And then you put the tracker on and then do a spin and then register and then go ahead.
I think I agree what Shiti you're saying, that you do the release and do that, but it's a practice. I think it keeps moving. I also felt, but now I'm very much used to it. Once you're used to it, it's not a problem. That's what I personally feel about. Even in AIS, you really can get on very well. Even you can do the facetectomy, but you'll get a very, very rare, very, very less error in this when you are putting the screw at apical or.
In type C
Can I say
pedicles,
something?
do you use EMG stimulation of the probe in the pedicle hole that you have created? And do you come across this issue sometimes, because there could be a very small pedicle, there could be a mismatch, even with a 4.5 mm screws. And when you put a screw, sometimes the threads of the screws can come out of the cortex. So do you just rely on OAM, or you use this EMG stimulation at that time also, or no stimulator to the probe?
So far, I have not used the electrical stimulation, but I rely mainly on the freehand and OAM basically. So far, we have had very good experience with OAM. Means there is no single pedicle which we thought that we should escape, but we could manage to do most of the pedicles.
What about widening these dysplastic pedicles? Even with OAM, we have to use form a trajectory though. So what you do for that? You burr it out, what you do?
Sorry, can you repeat your question, Dheeraj?
What about widening this dysplastic pedicles? So anyway, even if it's dysplastic, the canal is very narrow. So what you do for widening that?
We initially use the burr. We get the trajectory, and if we need to go out and come in, that also we prefer away from the cord. Basically, we use the burr. And even the smallest tip burr also we use for sclerotic pedicles, so that we can enter maximally in and then go very slowly with our the starters.
Thanks. We can go out to our next talk by Dr. Bhavuk Garg. Dr. Bhavuk Garg is a spine surgeon from AIIMS Hospital. We all know him. He is going to present on osteotomies and releasing technique in scoliosis. Tech team, can you please run Bhavuk Garg's talk?
Hello, everyone. And I thank Dr. Dheeraj for giving me this opportunity to talk about the releases and osteotomies for the adolescent idiopathic scoliosis. As with any surgery, we need a thorough preoperative planning to determine a choice of between different sort of releases and the osteotomies. We need to assess the flexibility of the deformity, which is very important to choose between the releases and the osteotomies. And whenever there are two curves or more than two curves, especially like double thoracic, I specifically look at the deformity angular ratio between of the two curves. In the proximal thoracic curves, I always look at the flexibility of that curve, because that curve usually is quite stiff, and the amount of correction which we get by the posterior column osteotomies is quite less in proximal thoracic curve. I also look at the kyphosis in the proximal thoracic curve, and I will discuss, why it is important when you plan releases in your surgery. Anterior release, I must admit that it has been an integral part of my training. Having said that, I must confess that I haven't done it in my last more than 250 AIS cases, and we have shifted completely to the posterior surgery for the AIS. Just to complete, just to give you an idea, this is the with the short video of the anterior release. We, as we all know, that we all approach it from the convex side. We can do it open, or we can do it thoracoscopically. This is an example of a thoracoscopic. This is an example of an open approach. This thing, we take out the rib at the apex, maybe one or two rib higher or lower. You can decide upon the depending upon the deformity, and then you identify the segmental vessels, and you carefully isolate them. You carefully either ligate them, or you either use liga clips to control the bleeding from these segmental vessels carefully. Then you carefully identify the disc spaces, and then we individually take out the ribs. This is like I'm taking out the convex rib head from the vertebra. You have to take it out, convex rib head, which is again a very important part of release. And then you take out the disc from the convex side, from this thing, and then you go through and through the concave side as well. And then you also cut the posterior longitudinal ligament. And once this is through, then you get a very good release. You can see a very nice release after cutting the PLL and the through from convex to the concave disc release. And once you have done it multiple places, then you can then you can stop it. This is very important because the anterior release is kyphogenic by nature. So we know that the AIS by in most of the cases it has got lordosis in the deformity. So anterior release gives you an opportunity to create kyphosis in that segment. So this is very important to understand. Posterior release is basically the resection of the muscular attachments and the ligaments that comprise the posterior tension band. The soft tissue releases basically involves the interspinous ligament, flavum, the facet capsules bilaterally. We all do partial inferior facetectomies, which we call it the grade 1 osteotomy, which I'm going to discuss later. And we also understand that the resection of these structures, they basically results in substantial mobility to most of the curves when we talk about the AIS. When I'm talking about the release of the muscular attachments and ligaments, I usually go for a thorough release. That means that I completely denude the transverse process. I completely cut the capsule between the transverse process and the rib head. So everything has to be done thoroughly to this thing. I also perform the concave rib osteotomies in some of the cases, not all cases, if I'm not able to get the full correction. This is especially very important when, especially in long-standing curves, when these concave ribs, they act like tether basically on the concave side, and just taking out the concave ribs gives substantial mobility in such cases. So this is just short video to show you that I just expose the concave ribs and then just take out the one by one, especially from at the apex. And I usually use the ronger to release these ribs. Coming to the posterior column osteotomies, we know there are different terms: Smith-Peterson osteotomies, Pontes osteotomies, extension osteotomies, chevron osteotomies. By nature, they all are the same. There are some minor differences. I'm not going to detail. The basic thing is that we can divide them into grade 1 or the grade 2 Schwab osteotomies. In grade 1, we just take out the inferior facet, the interspinous ligaments, and the spinous process. Like shown in this thing, we can either use the burr or we can use the osteotomes. And for a coronal correction, in most of the cases, the grade 1 osteotomy is enough. Just to show you, this is how we perform the grade 1 osteotomies. It has got many advantages. First, it gives you an entry to your pedicle point. It gives you release to correct the deformity. It gives you bone graft as well, and it gives you a clear-cut direction of the pedicle screw in your cases. So this is how we perform the facet release. We take out a sort of triangle area to expose the facet joint or the superior facet of the inferior vertebra. Coming to the grade 2 osteotomies, it is mainly required for the sagittal correction, in which you also cut the superior articular process of the inferior vertebra. It may be required for the large deformities which have got limited flexibility, but in most of the cases it is not required. So this is just to show an example that we also take out the superior articular processes as well. And I always keep the 4 mm, the 2 mm upcutters for this thing, which are required. And now we have got the ultrasonic scalpel. So again, doing a grade 2 osteotomy becomes quite easy with this thing. This is a very useful instrument, what we call as the lamina spreader, and we use it to assess the mobility of our osteotomies. So this is just to show you an example. This is a video where how do we check whether the osteotomy which we have performed is sufficiently mobile or not. This you can see that this is a grade 2 Schwab posterior column osteotomies, and we have got sufficient mobility from the posterior this thing. This is just a correction with the help of the posterior column osteotomy. Then you need not to do it at all the levels. Basically, it is required mainly at the apex and maybe 1 or 2 levels surrounding it, the apex. So this is just to show you an example of a case pre and post. And now we have got the superior instrumentation cobalt chrome rod. So now our corrections, they are much better. This is an example. This is another case with this thing which we are using the cobalt chrome, and this is the MESA system which we use. Now, this is a case, in which the growth rods were applied. This was an AIS. I am not sure what was the thinking of the surgeon. She presented at 12 years of age, and he applied growth rods. And at the age of 16 years, she presented to us. Now you can see that the deformity is progressing above and down. So in these cases, when we these posterior column osteotomies, they come very handy. And when we opened it, the middle of the whole of the spine was fused. There was a sheet of bone there, and then we just did the posterior column osteotomies at above and below, and we connected with the additional rods, and we could get very good correction in this child. You can see. Coming to the asymmetrical pedicle subtraction osteotomies, they have got very limited role in my current practice for AIS. I consider them for the double curves when the deformity angular ratio of the proximal thoracic curve is high as compared to distal one. So just let me give you an example. This is a double thoracic, this is a double major curve, you can see. And in this case, if I correct the dorsal, the lumbar curve, the thoracolumbar curve, then you can imagine that the correction will not be much in the proximal curve. And then the whole trunk will be shifted. So from the start, it is a perfectly balanced curve. And but the amount of correction which we will get will be much more the distal as compared to the proximal if we just go for the posterior column osteotomies. In these sort of cases, I consider the asymmetrical PSO at the top, and I always apply a smaller rod on the concave side, and then after achieving the correction, I look at the amount of correction which is required, and I gradually distract it on this rod, this osteotomies. So it gives me an example of how much correction I need, as well as the control over the neuromonitoring, and then we can achieve a very good balance in these patients with the help of this technique, the asymmetrical PSO and the proximal thoracic. Coming to the vertebral column resection, for me, it's too much for the AIS. The AIS is usually a smooth deformity, while the VCR is only for the sharp angular deformity. So in my practice, there's no role of VCR in AIS except in revision cases. VCR is okay for congenital cases, for the deformity, severe deformity, like in these cases, but not for the AIS. Again, in AIS, if you do a small releases and small osteotomies, posterior column osteotomies, bit by bit, so whatever you see is a petty correction coming up at each level, it becomes plenty in these cases. Just to show you an example, this girl, very severe curve, you can see a very sharp razor arm deformity. This was the curve when she presented to the surgeon at the age of 10 years. So it was basically at the borderline of this thing. But when she came to us, she was the age is wrongly mentioned here. She came to us at the age of 14 years, and then it was very severely progressed. The COPS was 127 degrees. The kyphosis was 94 degrees. So this is the kind of this thing, and it may look when we looked at the the images and this thing, then we could make out that there was just within a span of 3 vertebrae, you can see that the vertebrae, they were rotated at 90-degree angles to each other. So there was a 180-degree rotational deformity just within a span of three this thing. So these sort of deformities, they can present with the AIS. People may argue that this may not be an AIS, this may be something else, but we cannot fit it into any other category. So for me, this was the AIS, as we could see the progression of the X-rays, and this was the rotational. So for these sort of cases, you require special, the innovative approach to deal with this sort of rotation. So we actually look at those vertebrae which were rotated into the same directions, and we connected them with a single rod, and then we derotated them in the same direction. So you can see here I have used the multiple rods, and we just connected those vertebrae which were rotated in the same direction, and we derotated them each and individual segment separately, and we could get a decent correction. And I have used the concave rib osteotomies in this child, and you can see that the amount of correction which we could get is quite nice for this sort of deformity. Coming to the another case, 13-year-old girl with deformity in the mid upper back, and which is gradually progressive. And if you see clinically, you know, this sort of double this thing. And if you look at the neck also clinically, the neck also shows the some amount of rotation. If you could make out, there is a rotation in the neck as well. So these were the X-rays, and again we may argue that this may be some sort of neuromuscular or some sort of syndromic approach, but we couldn't fit it into any other category. We couldn't find anything else. So either we classify it to AIS or this thing. But the point of keeping this case here is that these sort of deformities, we have seen the AIS going into the cervical spine in very less cases, but yes, we are seeing it, especially when they present quite late. So how to tackle the cervical rotation was an issue. So we have used the laminar screw in the cervical spine, and then we use this laminar screw to derotate the spine. And we could get quite a decent correction along with all our usual techniques like the posterior column osteotomies and the concave rib osteotomies for this child, and we could get quite a decent correction in this child. To summarize, if AIS patients, they are caught early, then only the soft tissue releases are enough. And again, you can limit the amount of release required by higher anchor density, and the kind of rod which you are using, the cobalt chrome rod, gives you a much better correction. The posterior column osteotomies alone, they are relatively simple and a powerful tool, especially for the AIS. And if you use them judicially and with a careful planning, you can ensure their maximum potential, and always use the neuromonitoring in these cases. Thank you.
Thank you, Dr. Bhavuk. It was an excellent talk from you. Any questions for Dr. Bhavuk? We can take only one question.
Yeah, excellent talk, Dr. Bhavuk. I have one question. Good, stiff curve, you have corrected it very nicely. What is your opinion about the rib hump? Because nowadays people, they talk that they don't do rib hump excision, and with the derotation it comes very easily. But all severe cases where we used to do it, and even the cosmesis was the problem with the patient. So do you get the full derotation of the rib? Because practically it doesn't look like to be. So what is your opinion regarding this?
Sir, I agree with you that that the rib hump remains a problem in certain percentage of cases, but in most of my AIS cases, I am able to get a decent correction with the derotation only. However, in very severe and very severe and the stiff curves, I may have to resort to some sort of thoracoplasty, but I only limit my rib resection to only maximum two ribs. I don't go for more than 2 ribs, because then the complications, they are many.
Yeah. Thanks a lot.
Yeah. So I will invite my next speaker, Dr. Ramachandra from Bangalore. Tech team, can you please play Dr. Rama's talk?
The previous speakers has spoken in detail about the indications for surgery in adolescent idiopathic scoliosis and the levels of. Here to discuss about action maneuvers and the balancing techniques involved in an adolescent idiopathic scoliosis surgery. The action maneuvers has evolved over a period of time along with the instrumentation evolution, and one has to be aware of the various maneuvers that are being used. It varies from compression distraction to cantilever technique, and one should be very much oriented towards the different type of deformities that is seen in a single patient, so that a proper maneuver can be used. The commonest maneuver which is being used as a fine tuning for a shoulder balance is the compression distraction maneuver, where one compression being used on the convex side of the lumbar curve, it produces lordosis. The distraction maneuver is used most commonly in the thoracic curve. Once it is used, it produces not only correction of the curve, but also it produces kyphosis. The translation maneuver, which was first developed by Luque using a wire and rod technique, is being commonly used now with a lot of pedicle screws and extenders. Here, the rod is placed in sagittal profile at the upper and the lower instrumented vertebra and loosely locked, and the spine is translated towards the rod. The rod derotation maneuver is used by Cottrell and Dubosset, where he advocated to use the working rod as the concave rod on the thoracic scoliosis and convex rod as the working rod in case of a lumbar scoliosis. However, it basically produces derotation of the vertebrae in an opposite direction, and hence it produces a worsening of the thoracic column. The vertebral derotation maneuver is most commonly used nowadays with the advent of a pedicle screw, where the vertebra is derotated opposite to the rod derotation maneuver. And in this maneuver, there are two types of vertebral derotation. One is an en bloc vertebral derotation, another is a segmental vertebral derotation. The only difference is being the segmental vertebral derotation is being done in a single vertebra, whereas in en bloc, 3 or 4 vertebrae are used together so that the ploughing of screws is reduced. Because the ploughing of the screws might produce the damage to spinal cord and even damage to the major blood vessels. Differential rod contouring is a part of various maneuvers where, for example, in case of an type 1 thoracic curve, the rod is hyperbent in the concave side and hyperbent on the convex side. This differential rod contouring helps in not only translation and also derotation of the spine. The cantilever maneuver is being most commonly used for an hyperkyphosis, where the rod is locked onto the one end and it is being pushed and then applied to the distal end. The principle of scoliosis surgery is to correct the deformity with the minimal levels of fusion and also to have a balanced spine without producing any new deformities. In case of a shoulder balance, there are various parameters that are available to measure, like coracoid head difference, particular angle, T1 tilt, but none of the parameters whichever I'm talking cannot be reproduced in TROP because the patient is in prone position. We have to have a proper level shoulders. One has to select the proper UAV and also a correction maneuver during in-TROP. In a right side shoulder being high level, one has to compress on the right side and has to distract on the left side and to have a maximal correction of the thoracic curve in case of a type 1 lead gain. However, the amount of correction has to be assessed based on this parameter called as a UAV tilt angle proposed by Kwan et al., where it is calculated based on the pre-op cervical and supine side bendings, and that tilt angle is being reproduced in TROP so that we can have a proper post-op shoulder balance. The truncal balance, especially with the selective thoracic fusion for link A, 1C and 2C, is based on this parameter, which is the undercorrection of the thoracolumbar curve. Undercorrection of the thoracic curve. Because when a thoracic curve is completely corrected, we expected the lumbar curve to completely become straight, but doesn't happen, and it might result in imbalance in the form of coronal decompensation, lumbar decompensations. However, if you do an undercorrection of the thoracic curve, it ends up in a properly balanced spine. To conclude, the correction maneuver sequences that has to be used during any scoliosis surgery is being listed out in the step-by-step manner. And to have a proper balance, one has to do a proper preoperative planning, a clear-cut knowledge about the correction maneuvers that has to be used, and undercorrection principle has to be kept in mind so that we can have an harmonious correction. Thank you.
Yeah. Thank you, Dr. Ram. We can move immediately to our next speaker, Dr. Kshitij Chaudhary. Kshitij, you want to present your talk?
I'll do it in the end. Let everybody go first.
Yeah. So you can play my my talk on severe rigid scoliosis and correction tips. Tech team.
I don't know. Everybody will be tired. It's going on.
Yeah. So what we'll do, we'll make this as a last talk, and Dr. Parasnis will present one case, and we'll finish there. I am Dr. Dheeraj Sonawne, working as a associate professor in Grant Government Medical College and heading a unit at Gokul Deshpal Government Hospital in Mumbai. So today I'm going to discuss on severe rigid scoliosis and the tips and tricks for correction. So we believe there are 3 fundamentals for correction. First one is get loosen rigid spine to loosen up. Second is to get a good anchorage in deformed and rotated vertebra. And third one is with the help of reduction devices, rod and manuals, try to reduce the deformed vertebra. So loosening of the spine. Loosening of the spine is with the help of hallotraction, which is used pre-operatively and as well as added intraoperatively as well. The pre-operative hallotraction is going for 2 to 3 weeks, depending upon the degree of deformity. The Cobb's angle we prefer for its scoliosis is 120 and above. Hallotraction causes ligamental taxes and stretching of tissue and adds a few degrees of correction and makes our correction better. The posterior column osteotomy, which is commonly called as Ponti's osteotomy, as well as fasciculotomy and rib releases, helps in further loosening of the spine. Good anchorage in the disease vertebra is with the help of bigger screws. We avoid using 4.5 screws. Even in the narrowest pedicles, we try to go slightly lateral with the help of in technique. We try to take bicortical purchases in these rotated vertebrae so that the pull out and ploughing is avoided. We have, as you can see in the next example, you can see the screw size as well as the implant density is very high. We always try to take apical vertebra whole, as you can see here in the deformed spine. We have taken all apical, all the concave vertebra and the apical vertebra to have a we believe the apical vertebra anchorage is extremely important. That is the most rotated vertebra, and getting that rotated vertebra derotated helps in better correction. Third is the manual, and with the help of cobalt chromium rod, only in sagittal plane bending of the desired bending, and coronal plane we try to keep the rod straight and let the curve push the rod to the desired and deform the rod. With the help of cantilever technique and reduction devices, clips, we try to fix the rod to the screw. This is the example of severe rigid scoliosis. The Cobb's angle was 116 degrees, and on bending it was bending only 16 degrees from 160. These are traction, supine, AP, and lateral. These all the options were available for this patient, which is anterior release followed by posterior release and fixation. Second one is with the help of hallotraction pre-operatively, and second stage posterior instrumented correction, or we should have gone in the day 1, or additional anterior procedures which has been described like decancellation, vertebral conduction. The desired vertebra of lower instrumental vertebra was helpful. We tried to or higher with L3, and we were successful to get a decent correction. From 116, we have got 42 degree of Cobb's, which was almost 65% correction. These are the clinical pictures. This is another cases of 142 degree Cobb's. You can see there is a fusion of 3 vertebrae at the mid-thoracic level, and other is a structural rigid curve. We have put this patient in the help of, we have stretched the spine with the help of hallotraction for 2 we have continued the hallotraction during the surgery. And this is the pulse what we have achieved. The pulse is around 45 degrees from 142 degrees. So this is what I was discussing on. We have also tried to get maximum screw density. However, the few deformed pedicles we are not able to get. So as I have told you, for rigid severe scoliosis, we have to follow 2 fundamentals for reduction. First one is loosening. Second one is getting good anchorage, and third one is using with the help of cobalt chromium rod and cantilever technique. Thank you very much.
Very nice talk, Dheeraj.
Sir.
But sometimes when you find the curve is quite rigid, and also the screw hold is not good, it's safer to use a titanium screw and accept the correction that comes rather than trying to use cobalt chrome, and you might have a screw back out.
Sir, I have
depend on the purchase of the screw.
Very true, Ajay. We have burnt our fingers using cobalt chrome sometimes. It is a hell of a thing then to salvage.
Sir, I was having the same problem initially also. Fixing cobalt chromium rod, even a bent rod, was quite difficult for me. But I was there with Dr. Lenke, and he is using a bigger rod than me. We are having 5.5 rod, he is having 6 mm rod. And he is using a cantilever technique for a fixation with the similar thing I was trying to follow. Initially also I was having a lot of ploughing, especially in the apical vertebra. So what I have changed after Lenke is extensive releases, okay, bigger size screws, bicortical purchases, especially at the apical and the concave side, sir. So, and then using a cantilever, yeah.
I agree to that. I mean, whenever you feel that your purchase of your screw is not satisfactory, I think you have to make an intraoperative decision to accept moderate correction rather than trying to think that I'm going to achieve a better correction. That's what I mean to imply. If you are happy with your purchase, is fine.
Yeah.
But for Lenke also, what Lenke teaches also is exactly what Dr. Shetty is saying, that unless the primary thing that is least talked about in deformity is the purchase of the pedicle screw. So all those releases and all, everybody concentrates on, but the workhorse is your grip on the bone, and your screws have to be really, really good to do these forceful corrections. Without that, no rod is going to keep that. It's just going to plow out.
Yeah,
so the screws have to be really good.
Actually, Kshitij, in continuation to Ajay's comment, what I feel, whenever you have a problem in the apex and you knowingly trying to push it, if then you put the rod and now you are having problem, now in that apical area is going to keep the deformity. It is better to skip that. That gives you a better correction if you skip that. Okay. So if one vertebra in the apex you are not able to manage it, you can use either other technique. You can use sublaminar wire and try to bring it closer to the rod, or you use other techniques, but don't try to push it. Otherwise, most of the time it comes out. I fully agree.
We'll go with the Dr. Paras.
Yes. Dr. Parasnis has one case to present, so we can quickly move to Dr. Parasnis. Tech team, please allow Dr. Parasnis to share his PPT.
Your video is not. Is it a recording? Because we can't hear it.
No, it's not. It's not a recording. It's a PPT. So Dr. Parasnis can share the screen from his side.
But it's muted.
Dr. Parasnis here?
No, sir.
I think he's not here.
He doesn't. He's not in the list.
Okay. Then Kshitij, you can continue with your case and we can wind up.
Are you able to see this?
Yes, can.
So this was a 13-year-old girl with severe, mostly juvenile idiopathic scoliosis. MRI is normal, 116 degree main thoracic, which on fulcrum bending corrects to 84, which is 28% correctability, and on traction corrects to 92 with a 21% correctability. And these are supervised X-rays by me, because I was worried, because clinically also this patient had a not so correctable curve, which got me worried that what kind of releases are going to be required. And her PFTs were a little borderline, 40s, in the 40s, FVC and FEV1. But this child was nutritionally a little poor, had some chest problems and infections in the past, but never landed up in the ICU or hospitalized for something like that. But nutritionally, definitely she was down. These were her pictures, clinical pictures. But I just want to show you one method which can be an alternative to an halo, which is called temporary internal distraction. And it uses the same kind of principles as halo, which uses the viscoelastic property of bone and the deformity to gradually stretch it over time. So in this patient, what we did is that we used these implants. These are surgical implants, who is kindly sponsoring this event as well.
Please mute Dr. Parasnis.
Should I share my screen?
Oh, sorry. I'll just finish it in 2 minutes and then you can share.
Yeah, please. Thank you.
Yeah. So these implants are from MJ Surgicals, who are kindly sponsoring this event as well. And we did this case using their implants. And this technique has been described before by Buchowski and the Skaggs group, and where they have used these temporary internal distractors. And my boss my mentor, Dr. Vijay Lahiri, used to use a Harrington distractor for these severe curves when I was training. And this is a very similar kind of thing. You don't get these Harrington distractors very easily these days. But the technique that is described here is that you put these hooks on the ribs instead of the pedicles, so that you don't put stress on the eventual fixation points. You do a unilateral exposure because you want to get in this distractor as early as possible into your surgery, so that you can do a distraction over a longer period of time. So what I have done is an exposure on the concavity. I've gotten the screws here in the thoracolumbar area, got the levels right, put in these hooks and put this kind of a contraption. There's a rod connecting the hooks and one rod connecting with these polyaxial kind of a crosslink with a domino. And then you gradually keep on you lock in the hooks and then distract between the domino, so that you put in a little bit of distraction, not too much. You put in a little bit of distraction, then do your exposures, get in some more screws, then do a little bit of distraction, then do some Ponty releases. And that's what I had planned. I did about 8 Ponty releases here, and with every Ponty releases I did like a few millimeters, gradually stretching out that curve, not doing it all at one go, and on everything obviously is under neuro monitoring. So as the stretch happens, gradually the curve corrects better and better and better. And it also derotates a bit, so that your screw insertion becomes easier as well after the release and gradual. So I think I must have distracted in this patient about small increments about 10-15 times until I thought that this much is enough, and then eventually locked in this patient. Our pediatricians and ICU and everybody had said that don't touch her ribs. She's going to go on ventilator and all. So we don't want any of that sort. And since that was only for a cosmetic reason, we didn't touch her ribs and got this reasonable correction. We could have got more, but all these things also depend on the neuro monitoring and the eventual goal. The eventual goal is to get balance. It's not really to correct the Cobb angle to like 0 degrees. And this is a reasonable correction considering what the curve started off with. So this is just an alternative way of doing a temporary internal distraction. And what the original authors also describe is that if you do this intra-op and you don't get a 50% correction on table, or let's say you lose the signals, then what you do is release the distraction, keep the distracting rod inside, suture it, come back after 1 week and do the rest of it. So in a rigid scoliosis which is over multiple segments, you almost almost never have to do, never say never, but almost never have to do a VCR. This case is not really for that kind, but imagine that it would be a large case, just like one of the ones that Bhavuk showed. But curves that span over a very long segment usually don't require very aggressive complete disconnections of the column. You can get few degrees at every level, and here time is your friend. In this procedure, the longer time you have with the distraction, the more benefit you would have with it. So if you're going to do this surgery for 6 hours, you want that distraction at least for 5 hours in that surgery, so that you can use it for a longer period of time. There is no point doing the whole thing and then doing distraction over only in the last 1 hour of your surgery. So that's the technique, and that's about it. So
yeah,
we did use intraoperative traction. So basically, I use like a pelvic traction with Mayfield. I don't know if I'll show a picture of that.
Do you use uniaxial screws at the bottom of your construct at the LIV and above?
Not in this case, because this system does not have uniaxial screws.
Actually, using uniaxial screws in the lumbar curve, especially the lower two vertebrae, allows a good amount of correction of the rotation.
Yeah, but really speaking, Dr. Shetty, here, because the curve is so much, isolated derotation of that LIV, unless that apex really corrects, is going to be really hard. It's not going to be as good.
You need not do that. If you use uniaxial, when you are inserting the rod itself, it derotates, because the movement, when you are pushing it in, it derotates by itself. You need not use a device to do that.
Right.
If you look at the traction film, the L4 is quite good.
Yeah. We do use uniaxials for AIS and all curves, but this system does not have uniaxial screws. Okay. So we just use the usual polyaxials.
Okay. Kshitij, how long can we rely on the rib hooks? If we use this similar thing for a growing rod, is this construct fine?
Yeah, it's fine. Even growing rods, but in growing rods, you can't use this construct. You have to make a claw.
Okay. Okay.
This is just one side. This is going to
not
come
necessarily,
out.
Kshitij. What we do is we use 2 or 3 upgoing hooks. It's basically a rib hook which is put just lateral to the transverse process. I found that if you use a claw, the upper one tends to, because the rib is not a very strong construct.
Yes.
If you use a claw, the upper one tends to become more prominent.
Yeah.
Before I now move into using 2 or 3 upgoing hooks.
But you know what? That's fine for a unilateral construct, but for bilateral, you will need both sides.
Yes.
Because your unilateral, if you distract now, the other side will become loose. So those, the one which again Skaggs has described this, the rib-based constructs for growing systems. And I always worry that you're distracting one side and then, because that's the concavity, and the convex side is going to go out of track. So you need kind of a grip over it rather than something that pushes the ribs.
The advantage that is bound to fail, but it will give you 1 or 2 years, especially if the child is younger. I don't want to use a pickle and then if it fails, I have to go out. If I use a rib, the child is 5 6 years.
I think adding a crosslink would also help, because it will make it stronger, one with the other. If you are using.
Yeah, my question was about crosslink. How strong is crosslink against Domino's clamp? I have only used Domino's clamp for connecting an extra rod. I haven't never used this way what you have used.
Oh, this is temporary. This is not this doesn't go inside the patient.
Okay.
This is temporary. So this is just as a temporary distraction, and it can be temporary from like you doing 1-stage surgery, or you can do it 2-stage also. And you can leave this inside for a week and come back, because in that week, you add a little bit more to the viscoelasticity of that deformity, and then you get surprising results later. So this is not something that is put in permanently.
Got it. Thank you. Yeah. We can move over to last talk by Dr. Parasis. Vishal is here.
we can, Dr. Parsnis can share his screen.
Yeah, I'm trying
I
to.
have stopped sharing, I think. Yeah.
Sorry about that. I had a power failure in between, and that's why the link was gone. So I just want to quickly show a couple of cases to take you through certain problems that we come across in Lenke type 2, especially with the rigid proximal thoracic curve. Right. So this was the first case of a 13-year-old girl with a progressive AIS. She presented with shoulder imbalance. These were her X-rays showing about 76 degrees proximal thoracic curve and mid thoracic curve and a proximal thoracic curve as well. So I don't know. Sorry about that. So these were her parameters. She also had a reasonable kyphosis, a cervical axis tilt, T1 tilt, as well as certain other parameters of radiological shoulder height were especially taken because we are concerned about her cervical curve. The proximal thoracic curve was giving rise, I don't know what is happening. Sorry about that. The slides are just jumping. I don't know what's happening with that. So this was the pre-operative. So the decision was taken from D4 as her right shoulder was up, downwards to the UIV down, LIV down. We did multiple Ponti's osteotomy to reasonably correct the thoracic curve. And because of the hold of the screws was not so great, we added D3 to it, making sure that between D3 and D4, we did not distract it. We got a reasonably good sagittal and coronal balance. Her clinical balance was also quite good later on. Initially, she had a little bit of cervical tilt, the neck tilt on one side. On the postoperative parameters, we saw that the T1 tilt was better. The cervical axis tilt, however, was quite astounding. But later on, after 3 to 4 months, clinically, she improved a lot. Sorry about this. Each time I have to do. So on the right side, you can see that clinically she is doing absolutely all right. But the concern was that her cervical tilt, axis tilt was significant. Somehow clinically, the neck axis tilt wasn't so good. So this forced us to think of certain parameters in each time we come across a Lenke type 2 curve. So this was the next patient, 18-year-old guy with a progressive deformity. You can see over a period of time from 2017 to 19 to 21, his curve angle is increasing. His proximal thoracic curve was again very rigid, remaining more than 25 degrees on bending, making it a Lenke type 2. These were his clinical photographs. And this was the photograph just prior to surgery. The bending film showed that the rigidity was quite a lot. All these curves, they require extensive releases to get a reasonable correction. This was 85 degrees. The kyphosis was less. This was a hyperkyphotic curve, making it a Lenke 2A negative. Now, in this case, we decided that probably we'll go a little higher up with our last experience and decided to go up to D1 because there are quite a few literature references which say that if you have a significant proximal thoracic curves and if you're concerned about your neck tilt, to correct the T1 tilt, you can go up to that level. So these were the clinical parameters. I'll just highlight again. Usually in most of these Lenke 1 or Lenke 1 plus or positive as they call it in the stiff proximal thoracic, which is less than 25 degrees on correction, but it is very stiff. You have to think of these other parameters as well. You see for radiological shoulder height, coracoid height difference, sometimes clavicle chest edge angle, the sagittal axis is extremely important between T1 to T5, but the cervical axis tilt and T1 tilt is absolutely mandated to look at to decide the UIV. So in this case, we decided to go up to T1, doing multiple Pontes to get a reasonable correction. Interruptive monitoring was fortunately absolutely all right. This was just 6 days from his surgery, just before he went home. And he is doing absolutely fine. This is what it looked like. Mild bit of translation mechanical axis, but somehow his shoulder balance and neck was excellent. Still little kyphosis, we just couldn't get it above a certain degree. Again, the periapical screw started giving in. I always use strategic implants, not very heavy on metal. Clinically, he's doing excellent, except for the kyphosis. This was his final picture. So just to summarize, these are the parameters you have to see in Lenke type 2 when the proximal thoracic curve is a concern and neck tilt is a concern. Why so? Because it is known that if you see the health-related quality of lifestyle issues, As much as shoulder imbalance, neck axis tilt is also important. Now, there are enough literature evidences to say that two are not actually very closely related. There could be good shoulder balance, but a bad CAT and vice versa. So aggressive correction in the main thoracic curve can actually cause the higher curve to go on the opposite side. So be very sure if you start at D4 that the T1 tilt is proximally very well corrected. So just like how we know that clinical shoulder imbalance is related with CHD, radiological shoulder height, and clavicular coracoid height difference. Similarly, the cervical tilt, the CAT is closely related with the neck tilt, but more dependent on what is the residual post-op PTC, the proximal thoracic curve, and the T1 tilt. So always give a little bit of importance to these things when you tackle this Linker type 2 curves. Thank you so much. Any questions?
Yeah. Thank you, Dr. Parasnis.
How can we contribute to prevent vanishing of trigger?
Pardon, Ajay, the last part I didn't get.
How can we contribute to the prevention of vanishing of the tigers?
I would love to give a very long talk on that. No questions?
I think no questions. We can play MJ surgical video. It's a 2 minutes video because they have supported this event. Thank you.
Basically,
Tech team, can you play MJ surgical video?
Tech team is also tired, I think. गायब हो गया.
Ajay sir, Kshitish Srivastava sir, my question, sometimes I have an issue to decide what exactly has to be done, especially in skeletally immature girl or boy who is around 10, 11 years with a major to, with a moderate to severe AIS curve. So whether to go for a growth rod or a definitive fixation, I am slightly get confused during such time.
the thing is that it's much easier if it's a girl. We know that the peak height velocity will be attained much earlier. In this scenario, you should not proceed without a hand X-ray. You look at what stage of Sanders the child is in, see how much of the growth potential is still left, and then look at the flexibility and then decide whether you want to have a growth rod or whether you go for a definitive fusion. If there is a lot of growth left, it would be better to have a growth rod, even if the child is 9 to 10 years. If you think there are 2 to 2.5 years of growth left, if you try to fuse, there is a higher chance of adding on, especially at the upper end of the curve, especially if you are stopped at T4, there could be a junction issue when the child attains skeletal maturity. If it's a boy at 10 years, I would definitely think of a growth rod rather than doing a definitive fusion.
Okay, thank you.
Yeah, actually, how many of you use cast? Is it an obsolete procedure or you have been using it?
Still use it.
Yeah. So because many kids means younger than, I would say, 6-7 years, they tolerate the cast very well. If you have a pre-cast explanation to and communicate with the family member, I think the traction cast still have a role where you are contemplating problem. Now, another thing, on day one, you should not start thinking of the surgery in all these kids. It is extremely important to evaluate. If you are following these kids since long, then yes, you decide, this is, engaging very rapidly. And that becomes a totally different, set of patient altogether where you would like to do the release and growth rod.
Yes, sir. Also, cast helps in buying time during this period, especially in very younger child, where we can't rely on growth rod and the number of procedures increase drastically if we try to fix early.
Yes.
Shitish, you want to say something?
No, it's good. We'll end it now. It's anyway, I don't know how late we are.
3:40. Quite long.
Yeah, very long. So, but it was very.
For sure that company person is not interested in so anything. In that case, you can end.
Thank you. Thank you. Thank you all.
Thank you. Thank you, sir. Thank you, Ajay, sir.
Thanks, all of you.
A small factory established by two young brothers coming from a small village in Gujarat in 1996 has now grown to a multidisciplinary business house named MJ Surgical. With its never compromising attitude and quality range of products, MJ Surgical has India's leading orthopedic implants and instruments manufacturing company. In this journey of about 2 decades, range and quality of the products have earned the global repute and recognition to MJ Surgical in ortho-surgical instruments and implants. Product range at MJ Surgical is quite wide and vivid. MJ Surgical offers product ranges like arthroscopy, spine, cranial maxillofacial, and trauma. MJ Surgical's premium flagship brand, C2C Spine System, is a unique set of international quality instruments and implants of spinal surgery and treatments. One segment of C2C Spine System enjoys a particular interest of MJ Surgical, which is deformity segment. MJ Surgical offers a versatile system for different types of scoliosis, in particular AIS, adolescent idiopathic scoliosis. It has hooks, mono, and poly screws of all diameter and length. MJ has recently added uniplanar screws in its portfolio. C2C Spine System also includes iliac screws of length up to 100 mm. Very shortly, MJ will also be developing a pediatric deformity system. The essence of good correction is achieved by good instrumentation. With C2C Spine System, the company has developed user-friendly instrumentation. This helps us in various maneuvering techniques like rotation, derotation, compression, distraction, rod reduction, etc. The DVR system, the direct vertebral rotation system, can capture one or multi-segment to achieve targeted correction. MJ Surgical has been exporting its products globally like Europe, America, Africa, Asia, and other major parts of the world. Quality with affordability. Pledge of precision. Commitment with blessings. MJ Surgical. Implanting trust.
Thank you, MJ Surgicals. So I will request Dr. Sudhir Srivastava sir and Kshitij to take over from me.
Thank you, Dheeraj, for moderating this session. And thank you, MJ Surgical, for sponsoring. I think we are very late. SK sir, should we end?
Yeah, we should end.
35 people were still watching till the end.
Thank you.
This is a very interesting session, rigid deformity correction. And I think in our country, a lot of cases who are not managed early, now they land up, and this is a big issue. And that's why all these public hospitals are full of these cases. And I think this workshop was very nice. And I thank all the faculties, all the participants who were here till late and made this session very successful. Now I declare BSSCON 2021 end.
Thank you very much, sir.
Thank you.
Thank you.